As Albert Einstein once said, I'm neither clever nor especially gifted. I'm only very, very curious. So let's just keep our curiosity up during the whole session. Ask questions, share your experiences, and enlighten us with your wisdom. With this, I, Dr. Shubha Srivastav,
and I, Dr. Mrityunjay Singh,
we feel privileged to welcome you all on behalf of our department for Sepsis Consortium 2024 on this World Sepsis Day, which is celebrated on 13th September.
World Sepsis Day was established by the Global Sepsis Alliance in 2012 with the aim of raising awareness about sepsis worldwide. The day focuses on promoting early interventions and prevention of sepsis. It is celebrated every year on 13 September to raise awareness about the life-threatening condition called sepsis. According to the Global Sepsis Alliance, it's an opportunity for people worldwide to unite in the fight against sepsis. According to World Health Organization, sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection, and if not recognized early and managed promptly, it can lead to septic shock, multi-organ failure, and death. The theme of World Sepsis Day 2024 is Stop Sepsis, Save Lives. The main goal is to promote early recognition and treatment of sepsis globally. The significance of celebrating this day includes raising awareness about sepsis, promoting prevention measures such as hygiene, cleanliness, and vaccination, educating patients and healthcare professionals about early diagnosis and prevention, reducing morbidity and mortality associated with it, and providing support to sepsis survivors. In honor of the Sepsis Awareness Month, Sepsis Alliance is encouraging everyone to learn signs of sepsis. As many as 80% of sepsis deaths could be prevented with early detection and treatment. Take the time to learn the signs. You could save a life.
We bid a warm welcome to all the renowned speakers and chairpersons who took out their valuable time and joined us for today to be a part of this update. We are honored to have you all with us. So without further ado, let's dive into our promising schedule. Our first session on initial resuscitation and fluid management in sepsis. I would like to invite the chairpersons for this session, Dr. G.P. Singh Sir. He is ex-professor and head Department of Anesthesia, KGMU. Dr. Amit Anand Sir, he is an assistant professor, Department of Emergency Medicine, SGPGI, Lucknow.
I may now request our chairpersons to preside over the session and introduce our next speaker. Thank you, sir.
As you have been informed, very good morning to all of you. As you have been informed, today is World Anesthesia Day. And happy World Anesthesia Day to all of you. We are getting late, so we have to start session immediately. Speaker is Dr. S. Jhaveri. He is convener of Indian Sepsis Forum and Dean, Indian College of Emergency Medicine, past Vice President, Society of Neurocritical Care. He is a renowned man in the field of critical care in India. His topic is Initial Resuscitation and Fluid Management in Sepsis. Dr. Jhaveri, please.
Respected chairpersons, seniors and dear friends, I like to thank the Department of Pulmocritical Care and Professor Ved Prakash for the kind invitation. I am going to talk about initial resuscitation and fluid management in sepsis. No conflict of interest for topic or any financial conflict. The objectives of this talk is to understand the role of early resuscitation in sepsis, particularly fluid resuscitation, how to give a decent fluid prescription in sepsis, 1 hour bundle, and surviving sepsis guidelines review for the fluid part. We all talk about timelines, especially in emergency care, time to needle, time to thrombolysis, time to CT, time for antibiotic, but seldom do we follow the timelines for sepsis, and we do not record those timelines. That is an irony. So we need to have something like sepsis clock, and as a quality initiative measure in the emergency and ICU, we should be keeping an account of time to antibiotic, time to IV fluid, time to definitive diagnosis also. So golden hour concept should be applied to sepsis also. What is resuscitation? Resuscitation, rapid resuscitation for profound alterations in tissue perfusion of sepsis, hemorrhage and profound dehydration. This applies for fluid resuscitation in sepsis. While we talk about sepsis resuscitation, we have to think apart from fluids also. This is the 1 hour sepsis bundle. We have to measure the lactate levels. Any lactate above 2 is abnormal. Blood cultures before antibiotics, broad spectrum antibiotics. Begin rapid administration of IV fluids, crystalloids or balanced crystalloids. If the lactates are more than 4 or there are hypotension or signs of hypoperfusion. Apply vasopressors if your blood pressure remains critically low after the fluid resuscitation. As in any emergency condition, we have to address life threats first, and we all understand resuscitation is a horizontal measure. It is not a vertical as we capillary refill time within your vitals. The mottling score, this comes little late, but this can again be a simple tool to assess hypoperfusion. Going back to our case, 2.5 liters crystalloids given over 1 hour, antibiotic started, culture pending, MAP is now 60, 92 by 44, heart rate 120. Now patient is on 0.5 FiO2 with a mask, temperature 38, lactates 4.2. What is the next step? Will you like to give 1 liter more of fluid? You want to start norepinephrine, you want to start dopamine, you want to start dovitamin, or you want to give fluid and norepinephrine infusion and you are not sure. Who is with A and who is with E? E or A? These are two common answers, or might be B. Probably the right subset of answer for more. 3.5 liters of fluid totally, blood pressure is now 56 mean, temperature is 38.2, repeat lactate 3.4. Now at this point we need some hemodynamic assessment because we have given enough of fluids, and norepinephrine also most of us would have started by this time. We need to repeat our focused ultrasound exam after initial fluid resuscitation. We need to repeat our vitals, cardiopulmonary testing, capillary refill time, pulse pressure and skin findings before we give more fluids or before we give some other intervention. Initially we talked about measuring CVP, measuring SVO2 in the EGDT, but we all understand EGDT is practically out now, and a fixed CVP or fixed SVO2 has no value as of today. What helps us? Bedside cardiovascular ultrasound or dynamic assessment of fluid responsiveness and passive leg raise or fluid challenge. This is what helps us in day-to-day life. Bedside cardiovascular ultrasound, dynamic assessment of fluid responsiveness or fluid challenge, and an echo. Some salient points from surviving sepsis guidelines for the fluid. Sepsis and septic shock are medical emergencies as told by our first speakers, and we recommend that treatment and resuscitation must begin immediately. So sepsis is an emergency, treat it as emergency. For patients with sepsis-induced hypoperfusion or septic shock, not all sepsis patients will be in shock, not all septic patients would be hypoperfused. Remember this. Hypoperfusion happens in almost 40-50%, but not all patients of sepsis will be in hypoperfusion. They suggest that at least 30 ml per kilogram of IV crystalloid fluid should be given within the first 3 hours of resuscitation. The level of evidence is weak and the quality of evidence is weak. Level of recommendation is weak and the quality of evidence is low. This statement they have downgraded from strong to weak. Why? Because there were 3-4 major trials we all are aware of. Now they recommend 30 ml in first 3 hours. They suggest this now. Slide अटक गई? Okay.
go भाई
Okay, sir. For adults with sepsis and septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters. Hemodynamics is dynamic, sepsis is a dynamic disease, it changes, so we have to use hemodynamics in a dynamic measure, and whatever clinical measures you use, it should be in a dynamic way. Again, weak recommendation, very low quality of evidence. Adults with sepsis or septic shock, we suggest guiding resuscitation to decrease serum lactate. Lactate clearance is very, very important. Using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. So start using CRT if you are not using it. Crystalloids as first line fluid for resuscitation. Strong recommendation, moderate quality of evidence. For adults with sepsis or septic shock, they suggest using balanced crystalloids instead of normal saline for resuscitation. There is a distinct place for balanced crystalloid, but shall we be using in all the patients? The answer probably is no, and we have to look at cost efficacy in the bigger picture, at least if not for a particular patient. This is again weak recommendation, low quality of evidence. Our past is our future. This is why most of the people live their future based on their past. They cannot break from it, and probably humans also and doctors especially are slow to change. We resist changes. This is the EGDT published in NEJM 2001, and lot of good work has been done because of EGDT. Sepsis awareness increased, the following of sepsis bundles increased. A protocolized treatment for sepsis was brought into limelight for the larger audience worldwide. So lot of laurels to the paper. But larger body of evidence, it showed EGDT has less benefit, especially SVO2, CVP. Targeted CVP and SCVO2 have no role. This was the meta-analysis published in Intensive Care Medicine 2015, a systematic review and meta-analysis of EGDT for septic shock, the ARISE, PROCESS and PROMISE investigators, and all these three major trials failed to show any survival advantage with EGDT, and in fact the outcomes were better in control population. So process was promising, finally we ARISE and our practices changed. Now we are not following EGDT at all. The reverse work, the Emmanuel River work was obviously useful as we discussed, but there were a lot of fixed protocols which are no longer required. Now we always talk about personalized care and individualized care for every patient. So the 30 milliliter per kilogram hoax, this fixed volume of initial resuscitation was based on observational evidence, and the larger body of evidence which stands today is against this 30 ml per kilogram fixed volume. How much to give? This is the bigger question. There is variation in practice ranging from generous initial fluid administration to a fluid restricted strategy with early introduction of vasopressors. But what is the answer? The bigger question. The answer is you have to give just the right amount, which is the most difficult question to answer. We follow the Goldilocks principle, neither too much nor too less. What is the right amount? Still nobody knows. So we have to recognize the substantial clinical heterogeneity of sepsis. SVR is different in every patient. The requirement of MAP to allow perfusion of organs is different in every patient. So the practitioners are increasingly focused on tailoring resuscitation to the individual patient by administering IV fluid judiciously based upon an assessment of fluid responsiveness. Each patient is different, treat them differently based on dynamic parameters. This approach may lead to an overall reduction in fluid administration, although the impact on clinical outcomes is unknown, and probably all of us are using a little restrictive approach nowadays. Many reasons why we should be using restrictive approach. This is a very, very recent paper from South America. Hemodynamic effects of fluids are fleeting, they do not stay long, especially crystalloid 60 minutes. Hemodynamic assessment, most of the tools, especially the high-end gadgets, does not give any significant information in majority of patients, and we are aware about side effects of fluid. Intensive care medicine publication, which was in Critical Care Medicine 2017, International Guidelines for Management of Sepsis and Septic Shock, they further suggested use adjusted body weight for patients with BMI more than 30. Do not use 30 ml per kilogram. Now what we do, 4 ml per kilogram over 10 minutes. This is what I do generally, which comes around 500 ml to 1 liter depending on the weight, and repeat it after hemodynamic assessment. The first fluid bolus could be without a hemodynamic assessment, advanced hemodynamic assessment, but the basic hemodynamic assessment what we discussed from the clinical examination has to be done in each and every patient. Individualizing initial fluid resuscitation, dynamic goals, and reassess fluid responsiveness. Is this time to abandon normal saline? The answer is no, because balanced crystalloids have distinct advantages, but we have to look at cost effectiveness. But the right subset of patient you have to give balanced crystalloid. There you should not shy away from using balanced crystalloid. Which fluids? Normal saline, yes. Ringer lactate, yes. Some people have this concept, especially non-intensivists, that ringer lactate will increase lactate, but if the liver function is grossly normal or even slightly deranged, lactate will be cleared by liver. Balanced crystalloid, albumin 5%. We have discussed about top 3. Albumin 5% has some role, but it has to be used when you are requiring a large amount of crystalloids. This is the only indication. Albumin 4.5, 5%, this is for resuscitation and not 20%. So if the blood pressure is critically low or your fluid requirements are huge, then you can consider albumin. Vast majority of patients, normal saline, few patients, balanced crystalloids. These debates are ongoing and will never end. Crystalloid, colloid versus colloid, which colloid, crystalloid versus crystalloid, dry versus wet. These are the fluids which are available commercially. Which fluid to prescribe? Gelatins were out long back. Hemexil, this was out long back probably before you have entered the medical curriculum. So please do not use these two fluids. We are not even discussing the evidence which is against these fluids. Primum, non-noster, whatever fluid you want to use, do no harm. Fluid is a drug and it comes with various side effects. Graveyard of Hess was this chest 6S and Christmas paper. Balanced solution versus 0.9% saline. I will not bore you with the evidence, but what I practice. If there is pre-existing hyperchloremic acidosis, use balanced crystalloid. New onset hyperchloremic acidosis after fluid resuscitation, use balanced crystalloid. If you see the patient requires large volume resuscitation, start with balanced crystalloid, because with normal saline, hyperchloremic acidosis will happen with large volume resuscitation. It is not for traumatic brain injury, remember this. Albumin, subset of patients, saline and balanced solutions for vast majority. No to gelatins, no to starches, no to hemexil. Fluid management also requires some stewardship. It is a drug. Dosing has to be right, duration has to be right, and when it is not required, you have to stop. There is no bigger concept of maintenance IV fluid unless you are actively resuscitating the patient. So we talk about these 4 phases of resuscitation: rescue, the initial resuscitation, then you try to optimize, then you try to stabilize, and at the end you have to de-escalate and de-resuscitate the patient. The large amount of fluid which you have given might need to be removed after a certain while. In the rescue phase, you might require rapid boluses. In the optimization phase, titrate fluids and conservative use of fluid challenge. Initially boluses, then conservative fluid challenges. In the stabilization phase, zero or minimal IV fluids. In the de-resuscitation phase, avoid unnecessary IV fluids, and you are seeing side effects of over use of IV fluids, you might to give some diuretics also. This is the Bellamy curve we talk about in critical illness. Too little fluid, obviously there will be complications, hypoperfusion, organ dysfunction, worsening of shock. But too much of fluids, tissue edema, organ failure, worsening of cardiogenic pulmonary edema, increased ICU stay, increased mortality. So you have to be just right. The biggest question is how to be just right. So you have to draw a balance between hypervolemia and hypovolemia. Both are dangerous, so you have to have a fine balance. We also talk about fluid accumulation syndrome nowadays, cerebral edema, myocardial edema, tissue edema, pulmonary edema, and many other side effects, endless side effects. So bottom line is balance is the key to life. have the right balance. Initially you can be little liberal, but once your patient has stabilized, then you have to be conservative and you have to use your hemodynamics if your patient further requires. This is what we published recently, the IACCM position statement for management of sepsis in resource limited settings. With minimal of high gadgets, how can we optimize the patient outcomes? At the end, I will like to give you some practice points. Hypoperfusion in sepsis requires resuscitation. Resuscitation has to be individualized. Less is more nowadays. You have to follow the Goldilocks principle, neither too much nor too less, just adequate. Normal saline for vast majority of patients, some subset of patients requires balanced crystalloid. Fluid stewardship is required. Fluid recommendation in sepsis is still fluid. We do not have any rigid guidelines because there will be no rigid guidelines ever. Hemodynamics need dynamic assessment. Thank you. Chairperson.
Thank you, sir. It was very excellent talk. Any questions from audience? Sir, if there is no question, sir, there is one curiosity.
Yes, please.
The first word what had happened in this conference was curiosity. Plover's trial have given me some insight while making fluid resuscitation in the case of CKD patients. But still, if the patient is in chronic heart failure with reduced ejection fraction, can we initiate the fluid in the same way what we are using in normal?
Depends on pre-existing cardiac dysfunction, as you rightly said, and the new onset cardiac dysfunction, which could be because of sepsis. Initial aliquots in, say, ejection fraction less than 45 or diastolic dysfunction more than grade 2, we decrease the size of aliquot 250 ml and then see the response. If there is response, then we can repeat the aliquot. So if we repeat small aliquots, there is no harm. Instead of giving 500 or 1 liter together, we give small aliquots and see the response. We are a little more guarded for those patients.
Thank you, sir. Thank you so much.
Thank you, Javedi sir, for that refreshing dive into fluid management. You made it very clear that balance is important everywhere. And the importance of getting this right cannot be understated. I welcome Professor S.K. Jindal sir, Professor Rajan Prasad sir, and Professor Digambar Bera sir to our program. I would now request Professor Rajan Prasad sir and Professor R.K. Singh sir to please come on to stage to felicitate our speaker and chairpersons. Sir, please felicitate our speaker, Dr. S. Javedi sir. Professor G.P. Singh sir. Dr. Amit Anand sir. Moving on to our next session of the day on early recognition and diagnosis of sepsis. May I now request our chairpersons for the next session, Dr. Rajneesh Srivastav sir, Senior Chest Consultant, Max Healthcare, Lucknow. Dr. Rakesh Chaudhary sir, Senior Chest Consultant, Sahaj Hospital. Dr. Prashanta AP sir, Assistant Professor, Pulmonary Medicine, Sanjay Gandhi PGI. Welcome, chairpersons. I request you to please take over the session and introduce our next speaker.
So, welcome Dr. R.K. Singh sir, who is the professor and head Department of Emergency Medicine, SGPGI Lucknow. His area of interest is infectious disease and sepsis, and we have published over 110 national and international research publication and overall more than 1,000 citations. So welcome R.K. Singh sir for your talk.
Thank you, Chair. Thank you, Ved. And I'm humbled to be presenting it before some well-known dignitaries sitting in the audience. So it is my privilege to be facing Dr. Bora, Dr. Jindal, and Dr. Rajendra Prasad. So welcome all to this consortium in sepsis, and I must congratulate Dr. Ved for continued sessions of this nature every year. Most of the ICU departments are not organizing this, but pulmonary medicine, Dr. Ved has been taking the lead in organizing some of these sessions on a regular basis. And so congratulate Dr. Ved. So the topic for today is early recognition and diagnosis of sepsis. It's a small talk, but let us move fast because the time clock is running. So I'll outlay this program presentation in the form of burden, the complexities, the cultures which delay the treatment, no specific therapies, and then biomarkers. Are we talking about another puzzle? What is an ideal biomarker? What is the most studied ones? And what are the rapid tests that are coming in terms of biomarkers itself, and conclude the sessions. So to introduce, it's a leading cause of death worldwide. Better life support is leading to lesser mortality, but yet the numbers are huge. For sepsis, it is around 50% mortality. For septic shock, this mortality will go up to 80%. So yes, we have advanced in terms of the quality of life support, but yet the mortality continues to be still high. Almost 50 million cases of sepsis and almost 12 million deaths worldwide happen. So out of every 5 deaths that happen in world, 1 will be because of sepsis, and of that 1 death, 85% will occur in the low-income countries, and 2 out of every 5 cases of sepsis in the world will be children. So that's a huge number. If we take this all to Indian scenario, then 20% of global deaths of sepsis will be contributed by India. So that's a huge number. So the challenge. So there are many challenges, but I will just talk only of one challenge, that is early recognition and diagnosis. So the challenges are huge, but the emphasis today is only on early recognition and diagnosis. Look at this definition of sepsis 1, 2 and sepsis 3. Everywhere it is suspected infection, not confirmed. It is always suspected infection. And if you go to sepsis 3, they have added on to the Q SOFA and the SOFA, which is a mortality indicator. So that means still in sepsis 3 definition, we are relying on the suspicion of sepsis. So when suspicion comes, that means we are not sure. We are not sure. So the diagnosis is not sure. That is why it is always looked at suspected infection. So we have not moved from this point from 1, 2 and 3 sepsis definition also. We are relying on SOFA scores. Remember, SOFA scores dysfunction and failures come a little later. We need to pick this up at a slightly earlier stage if we really want to diagnose sepsis. So we can't wait for an organ dysfunction or failure to happen and then say, oh, this patient is in sepsis. So we have to come a little earlier than this. Cultures, as I told, most patients are already on antibiotics and antifungals, so cultures will invariably, most of the time, that is every second culture is negative, and the time delay that is happening in getting a culture is almost 60 hours. So we are wasting 60 hours before we say that this patient could be because of sepsis, and out of that, 50% will be negative cultures. So there is a lot of advancements which are happening in terms of culture analytics for sepsis, which points at figure number 2A, 2B and 2C. These are all elements wherein the developments have happened to pick up a septic infection based on the culture. So either I wait for the culture to grow, or I pick up from the bedside a blood sample and then analyze it, so I can reduce the time. So this article beautifully represents the amount of time that can be saved at each element. So why wait for the culture to happen and then detect? So why not detect even before the culture is growing? So that is one time gap can be reduced. Second is, when the culture is growing, then can I reduce the pickup rate even in that? That is by use of PNFH and other Malditoff. These are other technologies. Once the culture is growing, I can pick up those things. Then there is post-culture analysis. Again, here Malditoff, nestled PCR and PCR. These are all advancements that are happening in culture field. So the traditional microbiology of culture is 60 hours late in picking up a septic culture, okay? We have to move to 24 hours. So within 24 hours you need to get this result, otherwise your septic suspicion is gone out of the window. So how are you going to start an early treatment when you are still based on suspicion? So I have to reduce that from 60 hours to 24 hours. This article, people who want to read this can really look into this article for culture analytics. How do I increase the capacity of my culture analytics? So early recognition comes here. Can I have biomarkers which will help me doing this? Yes, there are, even before the culture. So I need to pick up those things before the culture comes. So if I reduce the culture analytics to 24 hours, then I need my biomarkers to be working even before those 24 hours. So I have to bring the technology which will pick up these things. So in terms of biomarkers, remember, you need them early, you need them for rapid diagnosis. It has to be sensitive, specific, reproducible, at a low cost, not affected by a prior antibiotic use, not affected by the steroids that are already in that patient. It must help me guide a therapeutic decision making. Remember, there are more than 250 biomarkers, and as I present, even more may be jumping on the queue, and it should accurately differentiate between a sepsis and a non-sepsis patient. And we look at biomarkers today in terms of three. One, those can help me prognosticate. Two, which can help me predict whether what is the course of this patient with the treatment. And third is theranostic, that means help me do a precision-based treatment of my patient. So these are three ways in which the biomarkers are now understood. So if we look into the biomarkers overall where we land here, so it must answer a few questions in sepsis. One, is it picking up the likelihood of infection? Can it help me risk stratify my patient? Can it help me identify the pathogen that is likely to grow in that patient? Can it help me guide my most appropriate antibiotic or antimicrobial? Can it tell me whether the treatment that I have started is actually patient is responding to that? Last, can it help me de-escalate the antimicrobials in my patient? So all these answers must be questioned for any biomarker which is being used in the market today. Can it answer? So there is no perfect answer, as I told you. there are biomarkers, but none of these 6 answers will be there for each of the biomarkers. Therefore, you can see a whole lot of mediators and biomarkers which are analyzed and on the market. I will just discuss 3 of them today. The procalcitonin, which is the most popular one which is being used, the HNL, which is in the pipeline, and the CD64, which we are using at our place in SCPGI. So I'll just discuss only on these 2, because otherwise discussing biomarkers in a whole way is going to be huge time consuming. So which is the most studied? Procalcitonin is the most studied. But which is the one which has the maximum diagnostic accuracy? It is CD64 with an accuracy of 0.96 in the area under the curve. Okay? So if you compare to procalcitonin accuracy is 0.85, CD64 accuracy is 0.96. That's pretty high. If you again look into the number of studies which are looked, procalcitonin is the maximally studied ones. Then there are Presepsin, CD64, CRP, IL-6, TREM, lactate, NL ratio, SUPA. So the more studies there are in a particular area, you understand this point that people are interested. That is why they are researching into this molecule. It is, everybody wants to be on the bandwagon. Therefore, procalcitonin maximum studies are there. Studies done on neonates, they done on adults and adult ICU as well, and in the emergency setting as well. And I'll just compare 2 of them. One is the CRP and the procalcitonin. CRP is an acute phase protein. Procalcitonin is a harmokine. Normal values of CRP vary between 0.08 milligrams per deciliter, while procalcitonin less than 1 is the normal one. Anything above 100 is, you suspect it could be, anything above 1 is suspicion of bacterial sepsis. The higher it is, the more suggestive that it could be bacterial sepsis. The source for CRP is liver, but procalcitonin from all the cells in the body, virtually all cells and macrophages. The time to increase is 4 hours in CRP, while the time to increase for PCT is 3 hours. Time to peak concentration is 50 hours in CRP, but for the procalcitonin it is 24 hours. Half-life for CRP is 19 hours, but for procalcitonin it is almost 22, 35. But what is more striking is, because we are using both CRP and, so let us see where confounders are coming. So look into the CRP first. It is not affected by steroid use. It is not affected by immunosuppression in my patient. It is not affected by neutropenia in my patient. It is not affected by renal failure. It is not affected by renal replacement therapy. So these are fantastic points in favor of CRP as a biomarker to be used in the intensive care or into the wards where sepsis is suspected. But where it will ditch you is patients with liver failure, because it is produced from there. So if there is chronic liver failure, 70% of the levels will be 70% down. If it is an acute liver failure, again 70% of the episodes it will not pick it up. So plus it will not pick up a second episode. So I have sepsis on day 1, on third day I have a repeat septic episode, it will not pick that up. Because, so these are the lacunae of CRP. Let us look into the lacunae of procalcitonin. So steroids, frequently it will be false negative. Immunosuppression, again frequently false negative. Neutropenia, again frequently false negative. So in these scenarios, CRP is to be favored, okay, rather than procalcitonin. Renal failure, there will always be a baseline inflammation, so it will always be a little up. So renal failure. Renal replacement therapy, again there will be a ditch in these levels going down, so you have to be careful. Advantage, liver failure, it will not get affected. So you can easily decipher where I want to use CRP as a biomarker, where do I want to use a procalcitonin as a biomarker. So it is not affected by acute liver failure, not by chronic liver failure, and secondary hit. Now secondary hit is a problem, because once the surge happens and if a secondary hit happens, it will not rise. So with procalcitonin, if the patient is immune paralytic and you have a second episode, procalcitonin probably may not pick it up that well. So these are problems that will happen. We did the study on CD64. I'll just rush through this. We compared PCT, CD64 and HL on patients presenting in the emergency septic, and this CD64 is basically a neutrophil cluster of differentiation. It's a transmembrane glycoprotein. It's known as an FC receptor 1. Levels above 1.5 are suggestive of sepsis. There are meta-analysis, 2 meta-analyses are already available suggesting of high sensitivity and specificity, and one specifically for high specificity of sepsis. In our study, we could, and this was a pilot study, so we enrolled around 45 patients. If you compare it with the PCT and the HNL, the area under the curve is 0.986. As I was telling, compared to PCT, this is pretty high as a pickup rate or as a diagnostic accuracy for sepsis. Differentiation between survivors and non-survivors, if you see the delta change in the survivor versus the non-survivor, you see the patients in whom it is not falling with time. That means within 72 hours, if the fall is not much, that means this patient is likely to die. Okay? So it will help you decipher these things better. Mortality prediction, as I told, it is much better. Not fantastic, I would say, but it will help you identify a septic mortality. So it will help you pick up a septic patient. It can help you pick up who within the sepsis is going to die. It can help you if the delta change is not much, that means this patient is likely to die if the CD64 is not changing. So what is new? Now I've got only 2 minutes, so what is new? So, okay, so I told you about biomarkers, the PCT, I told you about the CRP, and then I suggested you there is a whole lot of biomarkers which are available. But remember, the biomarker turnaround time is not 1 hour. Okay, I will send a PCT, I'll get a PCT in probably around 6 hours or even more. So the turnaround time for a PCT by routine analysis is still high. And when I am talking of early goal-directed therapy or early sepsis or early recognition of 1 hour bundle or management, if these reports are coming beyond 1 hour, oh God, this is not helpful. I want them within 10 minutes, within 20 minutes, within 1 hour. Unless I have these biomarkers evaluated and available to me within an hour, how am I going to get this information on my dashboards for treatment of sepsis? So these are the 3 technologies which are used for biomarker analysis. One is the septic biomarkers, I told you 3. IL-6 I did not discuss, but it jumps too much. Then there is transduction mechanisms which are used, but the fastest ones now currently, the point of care ones are the microfluidic point of care. So if you are using a biomarker in your hospital, just go and see what type of technology are they using. So if you want to bring early sepsis, so probably you will have to go for microfluidic point of care. So these devices have to be present within your ward, within your emergency, within the ICU, so that you can do them, okay? I need a turnaround time of around 1 hour without sacrificing the selectivity, no limit of detection. That means even if the rise is 100, it should be able to pick up that 100 times rise, and there are biosensors which I've just told you. So, but the sepsis story is huge. It does not stop just with this. So early recognition, to sum up, I would say the early recognition of sepsis is important. Biomarkers, early diagnosis for prognosis and personalized, that is theranostic. There is no ideal biomarker in the market. Absolutely forget the idea that you will get an ideal biomarker as of now. Point of care technology for biomarker assessment at the bedside by microfluidic analysis is probably the way around for early diagnosis of sepsis. Can't rely on cultures. With that, I will end the session. Thank you so much for hearing. I'm happy to answer if there are questions for me. My first time presenting before Dr. Jindal and Dr. Bora. So thank you so much for sir. Thank you.
Thank you, sir, for beautifully summarizing the biomarkers in sepsis. The problems we face in our day-to-day practice are similar as discussed. It is difficult to ascertain a new onset sepsis, whether it is bacterial or fungal, or when to escalate or de-escalate. Probably more research in markers like CD64 may pave the way for future. We can take a few questions if any are there.
Most biomarkers are for bacterial, so there is a whole lot of viral sepsis which we just don't understand. So there are no viral biomarkers as of now available. If the trends are not rising and the patient is sinking, we think, okay, he could be viral, he could be fungal. So that is what is happening currently.
Yes.
Sir, my question is that although if we are suspecting any patient of bacterial or pathogenic bacterial sepsis, then what was the most commonest reason that we could not find the blood culture positivity?
Again, there is many a slip between the cup and the lip. So the culture कैसे लिया, किसने लिया, किस तरीके से उसको पैक किया, कब तक उसको भेजा, लैब में कैसे पहुंचा, लैब में उसको कैसे एनालाइज किया, कल्चर मीडिया पे कैसे डाला, कल्चर मीडिया के अंदर जब उसमें CO2 एमिशन हो रहा है उसको कितनी देर में पिकअप किया, लैब टेक्नीशियन ने पिकअप किया या लैब सेंसर्स ने पिकअप किया. सो आप समझ गए, देयर इज सो मच ऑफ स्लिप बिटवीन टेकिंग अ सैंपल and actually getting a positive result of that sample. Okay, so there is a whole lot of technology there. इसलिए now Vitec systems, automatic detectors, यानी backtrack plates if you put, then CO2 emission होगा या कोई biochemical parameter derange होगा, वो suddenly lights जलने लग जाती हैं कि something is growing. Technicians normally आएगा, अगले दिन morning में आएगा 9 बजे, वो तो रात में ग्रो करने लग गया था. तो इसलिए मैं बोल रहा हूँ 60 आवर्स डिले ऑलरेडी हो गया जब एक्चुअली आपको रिपोर्ट आएगा. फिर सेंसिटिविटी आनी है, 50% ऑफ द टाइम्स नेगेटिव आएगा क्योंकि ऑलरेडी आपने एंटीबायोटिक्स ऑलरेडी दे रहे हैं. प्लस आपने जो ड्रॉ किया, द अमाउंट ऑफ ब्लड दैट यू एक्चुअली हैव टू टेक इज अराउंड 20 ml, पेड सैंपल 40 ml. अरे 40 ml ब्लड लेंगे कल्चर के लिए, ब्लड कल्चर के लिए, ये तो बहुत है, तो पहले 5 ml निकाल के भेज देते हैं. तो ईल्ड ही खत्म हो गया. तो द लार्जर द वॉल्यूम द बेटर द ईल्ड. ठीक है. सो देयर आर लॉट ऑफ थिंग्स दैट आर हैपनिंग. सो टेक्नोलॉजिकल एडवांसमेंट्स इन माइक्रोबायोलॉजी फॉर कल्चर एनालिटिक्स में जंप होना है, मैसिव जंप जरूरी है. अदरवाइज ये सेप्सिस की डायग्नोसिस और अर्ली डायग्नोसिस ये सब दूर की बातें हैं और फिर बायोमार्कर का मार्केट फ्लड हो जाएगा. तो कल्चर पे फोकस करना है अपने डिपार्टमेंट्स के अंदर.
सर, व्हाट इज योर Sir, any experience with blood-based PCR panels like BioFire?
Yes, we don't have it in SGPGI, but corporate-wise, yes, BioFire is being used, relevant. But हम लोग सरकारी अस्पताल में काम करते हैं, तो BioFire, एक BioFire I think will cost you around 5,000 or more. So
30,000.
30,000.
Yes.
So 30,000 एक बायोफायर के लिए मैं 30,000 वो कहेगा सर एंटीबायोटिक दे दो, मैं मरना पसंद करूंगा एक बायोफायर का रेफरेंस. तो आप समझिए हम लोग गवर्नमेंट में काम करते हैं, गवर्नमेंट में पेशेंट ज़्यादा हैं, ठीक है, और मिडिल इनकम और लो इनकम वाले ज़्यादा पेशेंट्स हैं हमारे पास में. तो हम बायोफायर कब तक लाएंगे उसको कैसे, और MIC लेवल्स, आप सिंपल सी बात है, बायोफायर तो दूर है, मैं MIC की बात कर रहा हूँ. MIC लेवल्स कितने को आपको मिलेगा, सेंसिटिविटी एनालिसिस कितना आपने डिटेलिंग आपके लैब्स दे पाते हैं. तो पहले इन सब चीज़ों में आई थिंक लेट अस ग्रो. कॉर्पोरेट नई चीज़ें लाता रहेगा क्योंकि वो मार्केट है.
So I will now invite Professor Amita Jain ma'am, which is she Dean and Head of the Department of Microbiology. Ma'am will take the lectures on current diagnostic modalities in sepsis. She is credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has credited for managing the diagnostic services and genome sequencing for COVID in UP during COVID pandemics. She has her field of interest and is doing a lot of works in the field of tuberculosis, clinical microbiology, and a renowned microbiologist, virologist. Noted among top 2% scientists, eminent scientists in the world, and has received several national and international awards, has more than 350 publications to her name and highly cited with over 6,000 citations. So ma'am, please.
Thank you, Dr. Rajkumar. And in favor of time, I'll try to be as brief as possible. And I take this opportunity to thank the organizers for giving me this opportunity to speak on sepsis, which is definitely a very serious issue. Like, a lot of people die due to sepsis in the hospital, in ICUs, and if we are able to manage it properly, which is definitely directed by the proper diagnosis and management, it's going to help our patients. So I'm very, very briefly going to tell you that how we diagnose sepsis, in fact how we support management of sepsis from the laboratory side. So few references I have used to make this presentation, and I tell you they are very brilliant articles. Some of them are pretty recent, and if anybody wants to read, they can take a copy from the organizers and cite these. What I'm going to do, I'm basically going to tell you that how we do what we do currently, what should be an ideal test for sepsis should be, what should be the criteria for that, what are the commonly used tests now, and what are the newer markers, just the names. We all understand what is sepsis. I think people who are managing ICUs and pulmonary critical care, they definitely know what sepsis is. It's a life-threatening organ dysfunction caused by dysregulated host response to infections. From time to time, the definition has been revised, and I still feel that there is a lot of gap and there is scope for revision, but there has to be some evidence-based revisions only. Similarly, the management guidelines have been revised from time to time, and they are being updated every now and then. Sepsis is often attributed to bacterial infections. Needless to tell you that it can be other infections too, especially the viral ones, and we have seen a lot of people losing their lives due to sepsis in COVID. This is one of the important cause of hospitalization, and at least 1/3 of the deaths, all hospital deaths, are because of the sepsis. So this is the current sepsis is when you see that there's an infection and the SOFA score more than 2, and what is SOFA is like when you're doing the organ dysfunction, sequential organ dysfunction assessment, that is SOFA, and there are different criteria which are shown in this picture. How do you diagnose sepsis? There is no single definitive test which can tell you what is sepsis. Is this sepsis or not? So there is no definite test for that. However, detailed clinical data, detailed physical examination, and extensive laboratory testing, this is all going to add to the diagnosis. And this also can help in preventing sepsis. This can also help us in prognosticating sepsis. What is going to be the outcome? We can do the peripheral blood culture. Patients, usually if it's out-of-pocket expense, they can afford it. It has high sensitivity for inflammation and the response rapid. These two are the two strengths of this test, but it has limited specificity. So it can be false positive and false negative at times. There are methods available for detection, lot of method platforms, economical test, accessible test. So that makes it very, very important. Procalcitonin is actually the frontliner these days. This is synthesized in thyroid cells, rises sharper and earlier than PCT. It has more sensitivity, so different papers have said somewhere between 73 to 95%. High specificity, again 77 to 95% by different papers. This helps in early diagnosis of sepsis, optimize antibiotic treatment decisions, and it can also predict positive blood culture. This is useful in de-escalating antibiotic treatment. It predicts 28-day cumulative mortality risk. Its concentration that has not declined by 80% or more between day 1 and 4 usually shows a poor prognosis. There are testing methods, lot of platforms available. It has certain strengths and weaknesses. We have to understand them before we order it. But definitely it's a good test and is being exploited to best. Just these are some flow diagrams and some guidance document from where DSA from where I have picked up these. If your patient is not that severely sick, outside ICU, mildly ill, then look at the level. If it is less than 0.25 microgram per liter, then you may hold the antibiotic if the suspicion is also low. But if suspicion is high, whatever the value, start the antibiotic, use the empirical treatment. But if you're suspecting bacterial infection, patient is not that very ill, and value is 0.25, less than 0.25 or more than 0.25, you can take your decision to start the treatment with antibiotic, and definitely you have to repeat it after 6 to 24 hours. If your patient is moderately ill and the values are again 0.25, with suspicion, use this chart. Then the third is, if your patient is severely ill and the value is 0.5 microgram, then if you do not have a suspicion, still start the antibiotic. But if you have suspicion of infection, then you have to start the antibiotic and proceed in a more robust manner. So the value, the 3-4 things which you have to take into consideration: how sick is your patient, number one. Number two, you have to understand that are you suspecting a bacterial infection or not. Number three, what is the PCT value, and number four, is any guidance available for empirical treatment on this. So if you understand that, you follow these charts, you will probably have a better outcome, and you will be not misusing the antibiotic as you are guided or you are instructed again and again not to. Misappropriate utilization of antibiotic should stop. I am not talking about STREM1, but this is another test which can help in diagnosis and prognosis more. We are not offering this test at this point of time, so I am not talking about it, but this has to be combined with other indicators. This is a cell surface receptor which is expressed on myeloid cells, and this can be a predictor as well as a diagnostic indicator and can help diagnose the sepsis. So there are a lot of immunological biomarkers. There are a lot of biomarkers for endothelial and glycocalyx dysfunction. So these all are listed there. You can go and do some self-reading. Nonetheless, remember what I am going to show you here. No definitive diagnostic tests. Clinical examination in detail is very, very important. Peripheral blood culture, it may not give you a value in all the cases, some helpful information in all the cases, but still it is a must. CBC and chemistries are important. Serum lactate measurement, they have to be done multiple times during the patient's stay. C-reactive protein and procalcitonin. With this, thank you very much. And if you have any question and if the time allows, I'll be happy to answer. Thank you very much. Thank you.
Thank you, ma'am, for that wonderful and comprehensive talk on sepsis and the microbiological aspects of sepsis. As usual, ma'am always stuns us with her very, very comprehensive package where she deals from end to end in a very short period of time. Now I would request if any of the audience who are actually treating sepsis cases, if you would like to put any queries on what was discussed.
Thank you.
Any question? I think, yeah. Can someone give her a mic if possible? Jyoti? Is there a mic? Jyoti, maybe
You can be louder, yeah.
So how can I interpret these reports?
So these are two independent markers. They are not dependent upon each other, number one. Number two, there may be some situations when you find results like that. I would advise, had I been treating my patients, I'll say that repeat it at least once.
Okay.
So, kabhi laboratories may make a error,
Yeah.
number one. Number two, still I'll say go with PCT. CRP is not as sensitive or specific as PCT is, so I'll go with PCT.
Thank you, ma'am.
So, thank you very much, and I would like to take the lead. Thank you.
I would thank you, ma'am.
Thank you, ma'am, for enlightening us with your knowledge. Now I request Professor Ved Prakash sir to come on stage and facilitate our chairpersons and speaker. Dr. Amita Jain, ma'am. Dr. Vimla Venkatesh, ma'am. Dr. Rajkumar Kalyan, sir.
Before I leave the stage, I would like to give my special thanks to Dr. Ved Prakash for bringing all the microbiologists on stage and in a way acknowledging the role we play in sepsis, or rather sepsis management. Thank you very much for that.
Moving ahead towards our next session, antimicrobial therapy, timing and selection, I would like to invite the chairpersons on stage, Dr. K.B. Gupta sir, Professor and Head, Department of Respiratory Medicine, Era Medical College. Dr. R.A.S. Kushwaha sir, Professor, Department of Respiratory Medicine, KGMU. Dr. Darshan Raja sir, Professor, Department of Respiratory Medicine, KGMU. Dr. Gyanendra Shukla sir, Consultant, Wilson Hospital. Okay, welcome chairpersons. I now request you to introduce the speaker for our session.
Good morning. First of all, thankful to Dr. Ved Prakash for giving me this opportunity to chair this very important session in the sepsis consultorium. Now, we are going to talk on the antimicrobial therapy, timing and selection. Speaker is very well-known person, Professor Digambar Behra sir.
He is a teacher of teachers, Padam Shri awardee. He was ex-professor and HOD in Department of Pulmonary Medicine, PGI, Chandigarh, and now he is working as director in the Pulmonary Medicine in Fortis Hospital, Mohali. He has so many things to his credit: a good researcher, good academician, and also good clinician. He is also the president of the Indian Society for Study of Lung Cancer, and so many things are there. So, friends, let's enjoy the talk of the Dr. Behra, who is going to speak on this topic. Thank you.
Okay, thank you, chairpersons. A very good morning to everybody. During the next few minutes, I will be talking to you about the approach to use of antibiotics in sepsis. You see, as you have just heard the previous lecture and the earlier lectures, you know, most of the time the problem in the ICU or in the critical care is the difficulty in isolating or getting the bug or getting the organism. Most of the time, 50% or more of the times, you are not able to isolate. It takes time to get a culture and the drug sensitivity report, and many of the times it may be a virus, it may be a fungus, and then some of the other organisms where it is very difficult to grow them also. So we have to, our approach should be to what should be the basic principle of starting the antibiotic, which antibiotic to choose, how long to choose, etc. Oh, it is not moving. Sorry. The basic issue is the sepsis and the septic shock. They are the medical emergencies, their assessment, aggressive management, and repeated the response to treatment. So sepsis management is it is a bundle approach, and it has got many other issues: the fluid management, the vasopressor or the pressure management, nutrition, and many other things. The first hour of the patient with sepsis and septic shock, in the healthcare facility is the golden hour, and appropriate management can make a significant difference. Significant difference to the survival of the patient. This is the surviving sepsis campaign bundle of care, that is what we call as the golden hour. So three important things on us to see was to measure the lactate level, obtain the blood culture before the administration of antibiotics, administer a broad spectrum antibiotics that will cover the most probable, the organism, and then obviously the fluid management and others you have just heard recently. So the principle of antimicrobial stewardship is very important in the approach to the management, antibiotic management in critical care. The antimicrobial stewardship, it refers to the optimal selection of the antibiotic, its proper dosing, and the duration of the antimicrobial treatment. It should be resulting in the best clinical outcome with minimum side effects to the patients and minimal impact on the subsequent resistance. That is what is most important thing, I suppose. So in simple terms, it refers to a coherent set of actions to promote the responsible use of antimicrobials. So this is a group of things which already we are told, it starts with the prevention of infection to the various issues associated with antibiotic use, its dosage, duration, de-escalation, the selection of the antibiotic, etc. So this is it encompasses a number of things. The basic principle of antimicrobial therapy is that it is intravenous antimicrobials must be initiated as soon as possible after recognition for both sepsis and septic shock. In the absence of a definite diagnosis or presentation, which is very common, that is in the golden hour, as I told you earlier, the empiric broad spectrum therapy should be initiated to cover all likely pathogens, including bacterial, potentially fungal or viral coverage. Then selection of optimal empiric antimicrobial regimen in sepsis and the shock is one of the central determinants of outcome. So various factors which must be taken into consideration for deciding the choice of empiric antimicrobial therapy, that I will just come to that. So, one of the important thing is the clinical syndrome. I think Madam just now told you about the site of infection, what are the prevalent pathogens and the resistance patterns, the severity of illness, age and concomitant underlying disease like chronic organ failures, the associated medications, indwelling devices the patient is having, say for example, a catheter, then the immunosuppressions or other forms of immunocompromise status, then the recent infections, then intake of antimicrobials within the previous 3 months, what antibiotics the patient had received. So these are the important determinants. So there are 8, for the principle of antibiotic use, we have 8 important steps. That is one of the making a clinical diagnosis. I think, is it an infection or it is a non-infection? How likely is that the patient has an infection? What are the possible non-infectious mimics? Have we taken the appropriate culture to confirm the final diagnosis? The second step is the limiting the empiric antibiotic therapy. So, to the genuine seriously ill patients, there generally empiric antibiotic therapy is only recommended for a select group of patients after taking the appropriate cultures. Say for example, these are the important group of patients like febrile neutropenia, severe sepsis and septic shock, and community acquired pneumonia having a severe form of pneumonia that requires admission, and ventilator associated pneumonia. Situations where you have to start empiric antibiotic, hence it is important to start the smart and then focus, that is evaluate if empiric therapy can be justified or de-escalated, and then make a plan with regard to the duration of therapy. Then obviously the third important step is know your bugs. The approach should include the identifying the clinical syndrome, elucidate the possible source of infection, predict the possible microbial pathogens, and then choose the appropriate antibiotic. I think that is again another very important thing. Then the step 5 will be obviously de-escalation and modification. So the empiric broad spectrum antibiotic should be modified depending upon the culture as and when it is available, and then the susceptibility reports and the patient status. So then obviously discontinue antibiotic if a non-infectious mimic is identified subsequently, and then the step 6 will be stop antibiotics in the if there is say for example if it is a viral pharyngitis, viral rhinosinusitis, skin and soft tissue infection, asymptomatic bacteria and pyuria, and so on. And the 7th step will reduce the duration of therapy. So the by and large most of the time it is 7 to 8 or the maybe maximum 10 days, but obviously there will be special situations. Say for example it is cystitis, pyelonephritis, catheter associated. On the other hand, if you are seeing it is empyema, if there is a pus in the cavity, if it is a anaerobic lung abscess, there obviously you have to give it for weeks. But by and large, for about week, 10 days duration of antibiotic is very important. And then the optimizing the PK/PD parameters, it is very, very important. That means we have to understand the pharmacokinetics of the drugs. So most of the time, in the most of the situation, you have to give a loading dose so that the minimum inhibitory concentration is maintained over 50% of the time. So that is again another important principle of giving antibiotic in the ICU. So the first pillar of the sepsis or septic treatment, it should be prompt and empiric antimicrobial therapy. After collection of the appropriate culture, then the microbiological sample should be assessed as soon as possible. Once the patient is admitted to the emergency ward, then the whatever is available like blood and fluid or tissue from the sites, then the indeed particularly in cases of septic shock, every hour of delay is associated with a significant increase. So the choice of empiric antibiotic therapy should be based on the clinical like site of infection, previous antibiotic use, immunosuppression, etc., as I have already told you. You know, initially regarding septic shock, a multi-drug antimicrobial regimen with a wide spectrum activity should be given. Say for example, carbapenems and anti-gram-negative antimicrobial dual coverage from gram-negative organisms that might be appropriate in case of high suspicion of multi. Then again, the efficacy depends on the peak of antimicrobial blood levels. As I told you, the appropriate drug dosing is very crucial. An initial loading dose I have already commented on, and then it should be re-evaluated daily. And then the, of course, the choice of the most appropriate empiric antimicrobial therapy is often challenging. Therefore, it might be useful to consider several risk factors for pathogens that that most commonly appear as etiological agents of sepsis. The urgent need to establish the antimicrobial treatment, it is very, very important. There are issues about 1 versus 3 hour bundles with respect to antimicrobial administration. However, the basic principle should be the current guidelines propose the administration of antimicrobials immediately, ideally within 1 hour. Concern for infection persists and after performing an assessment of infection. You have heard a lot about procalcitonin, its role, because it is ideally should not be used to differentiate between viral and bacterial infection, but I think it is very important to help in de-escalating the antimicrobial therapy. That is one of the important use of procalcitonin in However, as explained, the PCT associated with the clinical evaluation was less effective, and they have heard the pros and cons very nicely. Then recently many other things have come up. I think I will not go into those details. You see, this is what I was just exactly telling about surviving sepsis campaign. Once you are telling that there is a shock is present or shock is not present, if shock is present, then the treatment has to be started immediately. That is 1 hour, or the first hour is the golden hour you have to do, and except any moderate to low, whenever it is there, suspicion is there, then you can delay up to 3 hours. So then these are some of the, we have to know some of the organisms. Methicillin resistant Staphylococcus aureus. Say for example, if there is previous infection, if there is a
presence of central venous catheter and other risk factors. I am not going into those details, but only thing you have to know that what are the specific situations where these bacteria or these organisms are likely to develop. Say for example, if it is extended spectrum beta lactamase enterobacterius, like if there is a previous infection or colonization with these ESBL organisms, if there is a prolonged hospitalization, if there is a presence of permanent urinary catheter. For Pseudomonas, say for example, if there are administration of multiple antibiotics, pulmonary abnormalities like bronchiectasis, so they are more likely to have Pseudomonas aeruginosa. Say Candida species, the fungus, if it is immunosuppression, if there is a central venous catheter, prolonged hospitalization, recent surgery, prolonged wide range antibiotic, previous necrotizing pancreatitis, and a recent fungal infection or colonization. So they are, these are certain situations where you have to suspect that yes, this organism might be present. So then obviously these are one of the main empiric antibiotic therapies according to the infection. Say for example, if it is a severe community acquired pneumonia, you have to cover the amoxicillin clavulinate with azithromycin or clarithromycin, and the second choice will be levofloxacin. If when there is allergy to penicillin, that we know. But in our Indian setup, we should be very careful about the use of fluoroquinolones. So be sure that you are not dealing with a case of tuberculosis. Then obviously for hospital acquired pneumonia and the ventilator associated pneumonia, you have to use piperacillin tazobactam, a loading dose, then with the or cefepime with linezolid. So these are only some of the antibiotics. I can't go on reading like this. I will just try to tell you the Indian guideline done by the Indian Society of Critical Care Medicine. Just last month they have come up with very nice guidelines. It is a very extensive guideline for each type of infection, how to handle in the ICU, how to treat these patients, as that has been given very nicely. I think I will be asking you people to go through that. That is available free online, so you can go through that and take your decision. So, ladies and gentlemen, I try to just, it is not possible to go into the every detailed infection because there are so many sites within this short time. I just try to highlight some of the important principles of antibiotic use in case of sepsis in the ICU. Thank you very much for your kind attention.
Thank you, sir. The lecture was very crystal clear regarding this antibiotic steroids. So I think you can invite questions, if any, from the audience. Any question? Yes, sir.
Thank you, sir. It is always a pleasure listening to you, and you covered everything comprehensively. I just want to thank you that you have promoted me at every level. And just audience have any questions otherwise?
Thank you.
Thank you, sir. Your wisdom on antibiotics, we are ready to outsmart even the most smartest of bugs. You have certainly made stewardship a team sport that we all want to play. Now, I would request Professor Ved Prakash, sir, to kindly come onto stage and felicitate our guest speaker and chairpersons. I also... Professor D. Behra, sir. Professor K.B. Gupta, sir. Professor R.A.S. Kushwaha, sir. Professor Darshan Bajaj, sir. Dr. Gyanendra Shukla. For our next session, I would request the chairpersons to please come on to stage. Dr. S.K. Dwivedi, sir, Professor and Head Cardiology, KGMU. Dr. Jia Arshad, sir, Professor Anesthesia, KGMU. Dr. Jyoti Bajpayee, ma'am, Assistant Professor, Respiratory Medicine, KGMU. Dr. Rachit Sharma, sir, Assistant Professor, Era Medical College. And I request our chairpersons to please preside over the session.
So this talk of the next talk is here will be a slight change. It will be, instead of vasopressors and inotropes, it is going to be sepsis and ARDS, which has to be delivered by Dr. S.K. Jindal. He is a Professor Emeritus at PGI Chandigarh. He is Director of Jindal Clinics. He is ex-President of Indian Chest Society, Indian Association of Bronchology. He is an Associate Editor of Chest. He has received several Lifetime Achievement Awards, a very distinguished teacher, academician, and researcher. So I would welcome Professor Jindal to deliver his talk on the topic sepsis and ARDS. Thank you.
Thank you, sir. Thank you for a very kind introduction. And good morning, everyone. I am especially thankful to Professor Ved Prakash and his team for giving me this opportunity to come here. In fact, I had come to KGMU several times in the past, but now for almost 2 decades, I think, could not make it the occasion to come. So I'm very glad to see here that he is one of the largest, I used to say, post fellowship program in the country, you see. Well, I'm going to speak on one particular aspect of sepsis manifestation, I will say. You can also say a complication of sepsis or a manifestation of sepsis, the ARDS, or acute respiratory distress syndrome. You all know the ARDS was described in 1967 during the American-Vietnam hostilities, you see. Although sepsis, of course, has been described even in the past by William Osler. But at that time when OSHBA described ARDS, it was said as adult respiratory distress syndrome. But in due course of time, it was seen that it could the same manifestation in children as well, and it was changed to ARDS, or acute respiratory failure following an acute insult or a catastrophic damage to the lungs, you see, or systemic damage to the lung in a previously healthy individual. I think that was the crux of the matter in the beginning at that time, but in again due course of time it was found that it is not necessary that a person should be healthy before the development of ARDS, and it could very well happen in people with predisposing illnesses, comorbid problems, as well as in patients with sepsis. So sepsis is a major cause of ARDS, other being trauma or any acute insult, you can say. You see, sometimes even acute pulmonary thromboembolism can cause ARDS. But in this session, we will limit ourselves to sepsis-induced ARDS, a life-threatening condition that occurs when an overwhelming infection triggers a severe inflammatory response, I think. So it is almost the same pathogenesis as of sepsis or a septic-induced ARDS, but it differs in pathogenesis, time course, severity, and treatment and prognosis as well from the other types of ARDS, for example, multiple trauma, vehicular accidents for that matter, you see, which may have a better kind of prognosis as compared to sepsis ARDS. Sepsis, of course, you have already heard since morning what is sepsis and what are the manifestations of sepsis. So these are some of the common causes of ARDS which has been listed here. There could be direct injury to the lungs, aspiration pneumonia causing ARDS, inhalation of toxic gases. You all are familiar with the Bhopal gas tragedy, you see, when a lot of people developed ARDS due to the toxic gas inhalation. Respiratory burns, you see, in a fire, so that kind of smoke can cause injury to the tracheobronchial mucosa, near drowning, lung contusion, pneumonia, and even pulmonary tuberculosis can cause, and oxygen toxicity is an important cause of ARDS as well. And then there could be indirect or systemic causes when there is no direct injury to the lungs, for example, septicemia, trauma, etc. And I have some of them I have already said. It is a kind of relationship you see between SIRS or the systemic inflammatory response syndrome, septicemia, ARDS, and multi-organ dysfunction syndrome. People who are working in ICUs and emergencies, they all are familiar with this kind of interrelationship that one can lead to another, you see. For example, the septicemia can lead to acute lung injury first and then manifest ARDS. Similarly, it can develop on to MODS, SIRS, and so on. So we won't go into these details for the time being. But I think risk factors I have already listed, that pneumonias are very important. Older age, pre-existing lung disease, they are important causes, you see. So basically, sequence of events would be as given here in the right side column, that there is a catastrophic event, and then there are several kind of uncertain mechanisms, known and unknown mechanisms. They cause injury to the alveolo-capillary membrane. I think that is what is the crucial point here, that the ARDS develops due to injury to the alveolo-capillary membrane, even in the presence of normal hydrostatic pressure. I think we have a honorable cardiologist sitting here, so that people are very familiar with the cardiogenic edema when there is raised kind of pressure in the hydrostatic pressure, which is sometimes called as pressure edema, you see, in pulmonary edema, cardiac pulmonary edema. Here, there is no raised kind of hydrostatic pressure, but there is a leakage of the fluid of proteinaceous. I think that is another important issue, that the fluid which leaks into the lungs is high, rich in proteins or exudates, you see. First it leads to interstitial edema, and in due course of time, of course, alveolar flooding can occur, you see. These are the sites of inflammation you can see in ARDS. For example, the cardiac edema, there is no kind of injury to the alveolo-capillary membrane here. While in the lower diagram, you can perhaps appreciate that the alveolo-capillary membrane adjoining the alveolus and the capillary is damaged, injured, it is leaky. So I think that leads to leakage of the fluid from the circulation to the lung alveoli, you see. And the same explanation has actually been given for even other organ failures as well. That's why sometimes called this a unifying hypothesis, you see, that injury to the liver, to the kidney, to the brain, to all other organs would occur similarly, that there is a leakage of fluid from the capillary membrane, you see. So this is what I have tried to draw in the earlier figure, that there is a pathogenous lot of, I won't go into these details here. You see, whenever there is sepsis, it can cause circulating immune cells, kind of activation of and release of several cytokines and other mediators, and there is a kind of, these immune cells are circulating in the body and they affect all the organs in the body, and they injure the vascular endothelium, which I had shown you earlier, you see. Now, what is the risk of ARDS development in sepsis, you see? In sepsis, almost 43% of patients are likely to develop ARDS, and these figures are of course variable, but certainly it is a very high kind of incidence as far as sepsis is concerned. That's why I said in the very beginning that ARDS is almost a manifestation of sepsis, you see, a pulmonary manifestation of sepsis. And you can again see here that the 30-day attributable mortality of ARDS critically ill patients with sepsis was 12%, you see. Compared with mild and moderate ARDS, severe ARDS contributed more to deaths, you see. So that is a very important cause of death in patients with the septic ARDS. And histologically, if you really see the picture post-mortem, there is epithelial and endothelial injury. There are various cells which are dying, you see. There is a kind of programmatic cells death, which we call as apoptosis, and then there are other types of cell deaths. There is necrosis, necroptosis, pyroptosis, and so on, you see. So all kinds of cells in the lungs and other organs, they die because of this problem. There is oxidative stress, reactive oxygen intermediates, reactive oxygen species, reactive nitrogen radicals, they all are increased. They are all responsible for oxidation death of the cell membranes, you see. So it is a kind of microcirculation disorder that throughout the body, the microcirculation is disturbed, is kind of damaged, and there is the leakage of fluids all over, you see. So that is how it is clinically developed, the evolution in early stages. There could be basically early development and then intermediate and then of course late types of manifestations. You can see here that these are sometimes the time course drawn for the ARDS in any kind of ARDS practically, but certainly more in septic ARDS, that there is an exudative phase. First there is edema, followed by hyaline membrane formation in the alveoli, and then there is interstitial inflammation. And in due course of time, I think there is an interstitial fibrosis. People who dealt with COVID, you see, they are very familiar with the fibrosis, pulmonary fibrosis developing in the late phase of ARDS due to COVID-19 epidemic. So how to diagnose septic ARDS? When to suspect? Whenever there is acute onset of breathlessness in a patient with sepsis, I think that is the first important manifestation. Then presence of an infection and sepsis, of course, is essential. And cardiac or pulmonary illness may or may not be there, as I said earlier. People with existing or pre-existing pulmonary illness are not immune to develop ARDS, you see. They can also, patients with, for example, asthma, patients of COPD, patients of interstitial lung disease can also develop ARDS if the injury is acute and injury is severe, you see. And there is no significant relief with therapy for CHF. I think that is what is the most important differentiation from pulmonary edema, you see, that there is no increased kind of hydrostatic pressure. So therapy for congestive heart failure, the diuretics and others will not really help in these cases. And physiologically, of course, there is hypoxemia. So these are the diagnostic criteria which are very important. The oxygenation is most important, that the PaO2 over FiO2 ratio is, if it is less than 300, it is generally considered as mild. If it is, and if it is less than 200, it is late or severe ARDS. Then important is chest radiograph, which in the initial 24 hours can be normal, but subsequently there will be bilateral interstitial or alveolar infiltrates. And hemodynamically, I have already talked that the pulmonary artery occlusion pressure is less than 18, which is normal in that. There is no clinical evidence of left atrial hypertrophy. There is normal LA, CP, and pulmonary capillary wedge pressure, etc., etc. So these are some of the typical X-rays seen in ARDS patients. Initially, they may be normal in the first few hours, then there could be interstitial edema, haziness developing, and then there are multiple consolidation, bilateral consolidation you can see here in the later two films you see. As far as the differential diagnosis is, alternative diagnosis must be excluded, like pulmonary thromboembolism, cardiac pulmonary edema, bronchopneumonia, etc., etc. And the radiological evolution I have already talked, you see. What are the management principles? I'm not going to discuss the management in general, but the important is to resuscitate the patient, management of underlying condition. That is most important. Fluid management is important and has been discussed in the morning, that adequate fluid to maximize oxygen delivery, to maximize ventricular filling and cardiac output. But it is a very tricky situation, you see, because giving fluids intravenously in patients with pulmonary edema may actually be risky. So you have to balance between the two, and it's a very delicate balance, as one shown in the one of the first talk. You see that fluids sometimes may be given along with the diuretics. Most important, another issue is the oxygenation, the respiratory support, because that is what is killing the patient as well as his various organs, you see. So you have to take care of this oxygenation, and giving oxygen by nasal cannula or UV mask is usually not adequate, you see, because the lungs are damaged here. So you have to use other methods of oxygenation. Other, of course, things are same for any kind of patient in the ICUs, the nutritional support, the organ failure management, general care of the patient, and monitoring, you see. Ventilatory strategies are very important. I'm not again going to the details. The mode of ventilation is not important. Perhaps it can be given either the AC, the assist control, or SIMV mode, depending upon the patient's condition. FiO2 initially may be equal to 1, and then subsequently you are going to decrease to 0.6 or less than 0.6, because that is the safer. Otherwise, oxygen itself can cause ARDS. Respiratory rate you have to maintain relatively low. PEEP you have to maintain up to 20 normally. Sufficient PEEP to maintain significant tidal kind of recruitment or de-recruitment. But alveolar over-distension should be avoided, because if you give higher PEEP, then obviously it can cause volume trauma, etc. to the lungs, you see. Some kind of hypercapnia is acceptable. In fact, permissive hypercapnia is the important strategy given to these patients. So you will like to maintain PCO2 of about 60 to 70 around with acidosis of 7.2 or so. It is normally well tolerated, but you have to kind of keep a regular watch. The ICU people would obviously monitor such things, you see. Pharmacotherapy is for the sepsis you have already discussed in the earlier talks. Treatment of the underlying illness, drainage of abscesses, antibiotics, and source control, corticosteroids, and other adjunctive therapies. And to correct the physiological abnormalities, vasopressors, for example, I can see Dr. Aloknath coming up, he will talk on vasopressors. Anticoagulants, blood sugar maintenance in diabetics, electrolytes maintenance, and other sepsis-related complications. I think in the next talks we are going to listen to some of these issues. And then to manage treatment to suppress lung inflammation, which is relatively kind of new. Other things are not really important, but certainly some kind of immunomodulation may perhaps be necessary in addition to the sepsis treatment. So in the end, I like to say that a lot of things are evolving regarding the septic ARDS. It is a heterogeneous problem that must be appreciated. Biomarkers should be kind of done as applicable, you see, to detect the early detection and risk stratification. Most important is that it is the septic ARDS or the ARDS is being subphenotyped now, you see. Some may respond differently. So you have to individualize the treatment according to, you can perhaps generalize the ventilatory management and general principles, but otherwise drug treatment, etc. may have to be individualized depending upon the subphenotyping. People are in the knowledge that COVID-19 patients who had ARDS and hypoxemia, they responded very well to corticosteroids and other immunosuppressive like tocilizumab and so on, baricitinib. So I think some of them may respond to these drugs and others may not. So immunomodulation is what is perhaps the future of management of these patients. Extracorporeal management such as ECMO is used whenever there is failure of traditional mechanical ventilation or when patient has to be shifted, etc. So that is what I think more effective strategy one need to develop to improve the outcome for the sepsis. Thank you very much for your patient listening.
Thank you, Dr. Jindal, for this enlightening talk. I hope the first message should be that it may be a manifestation of sepsis rather than caused by any other thing. I am a cardiologist. So once you said that the diagnostic criteria would involve a PCWP of normal PCWP, so we come across situations where we know that the patient is having a higher filling pressure, but at times when their septicemia sets in, it becomes quite difficult for us clinicians to diagnose. So what would we suggest at that time in a phase of high filling pressure? How can we then say that this is now ARDS and not a simple pulmonary capillary increased pressure and LVF?
Yes, that's such a situation of combined cardiac versus kind of non-cardiac edema can occur in presence of sepsis. That is well known. So I think that you have to, for example, if a patient with known cardiac disease and cardiac failure develops bronchopneumonia and increase in the symptoms, non-responsiveness to oxygen, non-responsiveness to your standard cardiac therapy may suggest, you see, similarly, the X-rays, normal cardiac the non-cardiogenic pulmonary edema ARDS does not have cardiomegaly, but such patients are likely to have cardiomegaly. So it is a combined situation where there is perhaps no real test which can distinguish between the two, but certainly you can suspect whenever there is a new onset of pulmonary infiltrates, new onset of fever, and respiratory distress, deoxygenation, and so on.
In these times, what we go by and what I teach them is that for X-ray to be manifest with the pictures of pulmonary edema as the fluffy exudates that are being seen, the PCWP should not only be raised, but it should be more than 25. So if you are seeing this kind of picture with mildly elevated PCWP, without diuretic therapy, because the exudate will take time to go away. So when you see this picture for the first time, see what is the PCWP. You don't expect this picture with a PCWP or let's say pulmonary filling pressure of 25 or less. It has to be more than that. So in that situation, in a intensive care unit, when there is a added cardiac disease, should you suspect that no, it is not only this, and this patient has landed into acute respiratory distress. Thank you, sir.
Thank you.
My co-chairs, do you have any comments?
Yes.
So if there is no other question, we announce this wonderful session to close. Thank you.
Thank you.
Thank you, sir. That was quite informative. It's a pleasure to have you here with us and for sharing your knowledge. I request Professor Ved Prakash, sir, and to come on stage and felicitate our chairpersons and speaker. SK Jindal, sir. SK Dwivedi, sir. Dr. Zia Arshad, sir. Dr. Jyoti Bajpai, ma'am. Dr. Rajesh Sharma, sir. Moving ahead towards our next session on vasopressors and inotropes in sepsis, I would like to invite the chairpersons on stage. Dr. Anand Srivastav, sir, Professor, Department of Respiratory Medicine, KGMU. Dr. Harish Gupta, sir, Additional Professor, Department of Medicine, KGMU. Dr. Vipul Prakash, sir, Consultant Pulmonologist, Medanta Hospital. Dr. Darshan Bajaj, sir, Professor, Department of Respiratory Medicine, KGMU. Welcome, chairpersons, and I would request you to invite the speaker of this session. I request Professor S.K. Dwivedi sir to come on stage as chairperson.
I just barged in as a chair. This is not unusual for cardiologists to barge into the meeting. So it's a forced, you have to have a forced welcome to me. May I invite now Dr. Alok Nath, who is our next speaker. He got late in traffic. He is an expert member. He is a professor in the Department of Pulmonary Medicine in Sanjay Gandhi, our colleague institution, or let's say sister institution in city. He is a member of Indian Guidelines of Bronchoscopy. His areas of interest are in interventional pulmonology, which is a very, very fast, rapidly advancing field, and he has a lot of publications. Renowned academician, a very good orator. Let us hear him for the topics: use of vasopressors and inotropes in sepsis. When and how? It's a very common problem. Presentation with hypotension is a common problem. Maybe cardiogenic or non-cardiogenic. And when it comes to non-cardiogenics, then it opens a plethora, whether it is volume loss or whether it is sepsis, two being the most common ones. So, yes, so slides are here. Up to you. Welcome, Professor Nath.
Thank you, Chairperson, for this, those kind words, and a very good morning to all of you. In next 20 minutes or so, we'll be talking about the role of, the vasopressors in septic shock, about the choice, the dose, and the timing of initiation of vasopressors and inotropes. So I'll be presenting some recommendations and evidence before you, and the final word keeps on evolving, and the literature in sepsis is so rapidly evolving that so many things had come to our to our disposal, but later on we have almost completed a full circle. So there are a lot of critical reviews on a lot of recommendations which were so strong 20 years back, which are not so strong now. So let's start with that. Sepsis is characterized by actually complete hemodynamic failure, vasoplegia, and it's a major challenge with a very high mortality. Fluid administration during resuscitation is the first line of therapy for correcting hypotension. However, hypotension is related to sepsis-related diffuse systemic vasodilatation, and vasopressor therapy is fundamental for correction of hypotension in septic shock. The major aim is to correct the vascular tone, which is depressed, and then improving the tissue oxygenation and perfusion pressure to various organs to prevent organ failure. And the definition of sepsis had been evolving. Sepsis 3 had defined sepsis as suspected infection with a SOFA score of more than 2. And also septic shock was defined as meeting those criterias along with the vasopressors to maintain a mean arterial pressure of more than 65 or lactate levels more than 2 nanomoles per liter. The pathogenesis of septic shock is a systemic inflammatory response due to a infective cause, which leads to dysregulated immune response, release of various pro-inflammatory cytokines, and further organ failure and septic shock. So in first decade came with a bang the early goal-directed therapy, in which initial fluid resuscitation was and the goals were defined that these things should be started within first 6 hours of admission, and that lead to very favorable outcomes, which was published in prestigious journal in 2001, And it was a big study in which hospital mortality with predefined variables of early goal-directed therapy was significantly lower in the study arm as compared to the control arm. And during the interval from 7 to 72 hours, the patient assigned to EGDT had significantly more mixed venous oxygen saturation, and mean Apache scores were significantly lower in patients who received early goal-directed therapy. So this came with a bang, and everybody started following very religiously these recommendations made by this, and Surviving Sepsis campaign also took it very strong, with very strong recommendation for early goal-directed therapy, and was concluded that early goal-directed therapy provides a significant benefit with respect to outcome in patients with severe septic shock. But later, a series of trials were published in between 2010 and 2015, among which the notable are ARISE study, PROCESS study, and the PROMISE study, and a systemic review and meta-analysis of the various studies done in this regard was done between all the studies between 2010 and 15, and 5 randomized trials were included, and it was found that the pool estimate of 90-day mortality from the 3 major multicenter trials showed no difference between the mortality, and early goal-directed therapy increased the vasopressor use and ICU admission. So it was demonstrated that EGDT is not superior to standard therapy in patient with septic shock. So relative to that, latest update of Surviving Sepsis campaign still holds to the initial measures using IV fluid resuscitation of 30 ml per kg in first 3 hours, IV antibiotic, oxygen therapy, and mechanical ventilation if clinically indicated, but they have toned down the level of recommendation to weak level of evidence and weak recommendation. And they still recommend monitoring of dynamic blood pressures, the use of lactate to assess tissue perfusion, and patient remains and if the patient remains hypotensive diffuse, despite fluid resuscitation, vasotherapy is indicated. So, which vasopressor therapy should be considered in septic shock? There are a host of agents like norepinephrine, epinephrine, dopamine, vasopressin, and analogues which act on various receptors, predominantly alpha adrenergic and beta 1 adrenergic receptors, V1 receptors at the vascular endothelium, and so on. The question is, which vasopressors is ideal for the use in sepsis and septic shock? Dopamine was first to be used, but soon it was realized by a large trial, that was the SOAP-2 trial, that dopamine was associated with unfavorable outcomes, and especially tachyarrhythmias, and although no difference in mortality was observed, but high incidence of tachyarrhythmias was seen with use of dopamine. And the latest Surviving Sepsis campaign guidelines also recommended that dopamine should only be used in patients who have bradycardia along with septic shock. Later, with series of multiple trials, it was realized that it has got more deleterious effects apart from only tachyarrhythmias, that it has dysregulated immune response, prolactin metabolism has got a lot to do, and it has unfavorable outcomes in general in patients with sepsis. And the recent meta-analysis in 2012 showed that actually dopamine did not have a favorable outcome, and it was associated with increased risk of death in most of the randomized control trial. However, in observational studies that was not there, but it was associated with significant heterogeneity. So this was a kind of a last nail in the coffin of dopamine, and dopamine was unfavored and was taken off in the from the armamentarium of septic shock predominantly in general. Then noradrenaline or norepinephrine remains the common vasopressor of choice in sepsis, which is recommended by Surviving Sepsis campaign experts also. It has got high alpha adrenergic activity and less beta adrenergic activity, and it is recommended as the first line vasopressor. Vasopressin is recommended as second line, and Surviving Sepsis campaign also suggested adding vasopressin to noradrenaline. It was a weak recommendation with low quality evidence, with the intent of rising mean arterial pressure to target. or to avoid tachycardia due to increased noradrenaline use, which could prevent complication related to excessive adrenergic load. So, addition of various agents was studied, that if vasopressin is added as a second line agent early in the course of the disease, does it have is a favorable effect? From the vast investigators in 2008, it was shown that low dose vasopressin did not reduce mortality, and it was comparable to norepinephrine among patients with septic shock. Then a meta-analysis also was done, which showed that the addition of vasopressin to catecholamine vasopressors compared with catecholamines alone was associated with lower risk of atrial fibrillation. However, the mortality and other primary endpoints or outcomes were not different between the two groups. Then another trial which was done with an aim to find out whether renal failure is less if vasopressin is early used, that also did not meet the primary outcome. Despite that, vasopressin is recommended to be used as the second line agent when you fail for certain targets, and a certain dose is suggested by various researchers, that if that dose of noradrenaline is reached, you can add the second vasopressor. And this was also demonstrated in another trial, that in patient with cancer and septic shock, in which the difference between vasopressin and early vasopressin and norepinephrine was not found to be significant. The congeners of these AVPs was also tried, like terlipressin and serlipressin, and longer half-life of terlipressin actually makes it difficult to use in clinically practice. However, serlipressin was tried in one of the trials called Sepsis ACT trial. It was compared with placebo, but did not increase any vasopressor-free days or ventilator-free days within 30 days. So that was also a negative trial, but the research is on, and these agents still are to find its place in management of sepsis as a second line agents. So now comes the question when or whether inotropes should be added to vasopressors in patient with sepsis. We all know that inotropic activity increases cardiac index and cardiac contractility. So whether or not that is useful or not was also evaluated. But surviving sepsis campaign on basis of evidence says that inotropic agents should not be used to increase cardiac index above normal, and dobutamine up to 20 mg per kg per minute may be added. It was also a 1C recommendation based on that in myocardial dysfunction by elevated cardiac filling pressure or low cardiac output, and if the signs of hyperperfusion are there despite achieving adequate intravascular volume. The largest trial in this regard was a randomized controlled trial in which patients receiving epinephrine or were compared with epinephrine plus dobutamine, which showed similar mortality in both the groups. And patients receiving epinephrine did have persistently low pH levels and high initial lactic acid levels, and than the norepinephrine and dobutamine group. But there, in general, there is lack of data to provide any clinically meaningful outcomes measures that could help us in determining the usefulness of addition of inotropes to vasopressors. Epinephrine similarly has been tried and given a weak recommendation. It has been tried in some trials, and it was found that it did not have it should only be added. It was a weak recommendation from SSC that if the target map mean arterial pressures are not reached, epinephrine can be added. Dobutamine similarly was tried in a large trial of more than 4,000 patients, and all-cause 28-day mortality did not differentiate between the two groups. So dobutamine did not have a favorable effect if added to vasopressors in patients with sepsis, and in fact in this trial it was showed that dobutamine was associated with a longer hospital length of stay. The meta-analysis of all the randomized controlled trials showed that in patient with septic shock, patient who did not receive dobutamine they was significantly associated with longer hospital length of stay. Now, the newer vasopressors like angiotensin 2 have also been tried. It's a human peptide hormone that binds to angiotensin 1 and 2 receptors, inducing vasoconstriction. Angiotensin 2 was compared with the placebo, and it was found that it effectively increased mean arterial pressure and vasodilatory shock that did not respond to conventional high doses of vasopressors. In a trial of 321 patients, the primary endpoint was reached in more patients in angiotensin group, and at 48 hours the mean improvement in SOFA scores was greater in the angiotensin 2 group. So angiotensin 2 effectively increased blood pressures in patients with vasodilatory shock that did not respond to high doses of conventional vasopressors. And similarly, small studies have tried other inotropes, but a large body of evidence is not available for addition of inodilators in septic shock. As we are running short of time, I will go through the summary of evidence that norepinephrine is the first choice vasopressor in septic shock. Vasopressin and epinephrine represent second-line therapies, and angiotensin 2 seems to be promising, having promising results, and maybe having its place in patients with refractory shock. Route of delivery, I'll skip because less than 0.3 microgram per kg, we can use peripheral line also, which was recently published in Chest, and it was found that time to administration of vasopressors was significantly lower in patients with peripheral line delivery or peripheral line usage of vasopressors. When to use the vasopressors? Is early use the better? That was evaluated in various trials, and in a single center RCT of 101 patients, a significant difference in hospital survival rate in early noradrenaline group was reported, in which noradrenaline was actually started between 20 to 30 minutes of hospitalization as compared to 120 to 180 minutes of late adrenaline group, and in early group it was found to be favorable outcomes. But in the another large trial, that is the sensor trial, the primary outcomes was met, that is the shock control was significantly better in the early noradrenaline group, but 28-day mortality was not different, and norepinephrine group was early group was associated with lower incidence of cardiogenic pulmonary edema and new onset of arrhythmia. Other trials have also evaluated early vasopressors in septic shock. However, early administration of norepinephrine septic shock was demonstrated that if vasopressors are instituted early, within the time frame of fluid resuscitation has got a associated favorable early survival rate. But the Clovers trial, which was the largest trial and the most talked about trial, in which a restrictive fluid strategy in which vasopressors were followed by the resuscitation, and liberal fluid strategy in which the fluids were followed by rescue vasopressors was used, and it was found that the restrictive fluid strategy, that is early vasopressor use, did not result in significant lower mortality before discharge, that is within 90 days, in compared to the liberal fluid strategy. So it remains unclear whether early use of vasopressors while giving the fluid resuscitation actually works in these patients or not. But early indication, a simple guide for all the researchers is that use of diastolic blood pressure, which actually has got more to do with the filling pressure and organ perfusion pressures, can be used as a guide to initiate vasopressors. What is the optimal dose and how much is too much? So for that we must understand the autoregulation, and basic aim of this diagram is that in patients who are normal, in that the MAP range, which is recommended by the Surviving Sepsis campaign, and all the recommendation is 65 to 75, or mean arterial pressure around 65 millimeters of mercury, but that is not true in patients who have chronic hypertensive, who are chronic hypertensive, in which a higher pressure may be actually recommended to prevent organ failure. And autoregulation mechanisms play a very important role in that regard. So, high dose of noradrenaline to achieve a higher mean arterial pressure, that is around 85 millimeters, would lead excessive vasoconstriction and hence impairment of microcirculation and ultimately in organ dysfunction, which was this hypothesis was tested in a trial which is Sepsis SPAM trial, but it did not show any difference in mortality at 28 days or occurrence of any significant or serious adverse events, but definitely the diagnosis or occurrence of atrial fibrillation was higher in the high target group. So it's individualized, it is basically important to individualize the therapy in patients with should be looked for other parameters also, like intra-abdominal pressure and centrovenous pressures. A paper in which mean arterial pressure and CVP difference was used as a marker or as a way for adequate vasopressor and fluid resuscitation, and a cutoff of 60 of MAP CVP difference was found, suggesting that in cases of high CVP, a MAP target of higher than 65 may be necessary. So these are the ways in which you can actually kind of indicate that where, in which cases a higher mean arterial pressure may be targeted to prevent organ failure, which cannot be the rule of thumb as 65 in all patients. So finally, individualization of mean arterial pressure should be done on case-to-case basis. Initial map of 65 to 70 in patients with chronic hypertensive may not be adequate, and for non-hypertensives that target seems to be optimal. Whenever in doubt or uncertainty, some other methods like non-adrenaline challenge can be given, like early vasopressors use, or the capillary filling pressure, which was used in Andromeda shock trial, that as compared to lactate, although it was not superior to lactate, but on bedside, a capillary filling time of 3 seconds was the cutoff, which can be used as a marker to assess the patient's hemodynamic perfusion status. The target doses for all vasopressors are given, and more than these doses should be avoided, which leads to very deleterious outcomes and side effects. So in conclusion, noradrenaline is the first line vasopressor in septic shock, with the dose range from 0.1 to 1. Higher doses than 1 are not recommended. Once you reach a dose of more than 0.25 microgram per kg per minute of noradrenaline or norepinephrine, a second vasopressors, preferably vasopressin, should be used. Diastolic arterial pressure, intra-abdominal pressure and CVP should be used as guide in patients who have different profiles as given by the standard surviving sepsis campaign guidelines, and optimal mean arterial pressure target should be individualized as it depends on several factors such as history of chronic hypertension, the values of CVP and intra-abdominal pressures. Thank you very much for your patient listening.
Thank you, Dr. Nath, for beautifully describing the mechanism, how to use them, how one can start, and discussing about what should be the choice. We have been using hypotension in our clinical situation in our ICU much more frequently. However, they are not septic shock, but the basic principle that we follow there may be quite similar here as well. The aim of the inotropic therapy is twofold. One is to increase the pressure, and how does it do is that it increases the volume as well, because the peripheral or smaller arterioles, they react more to the noradrenaline, so they direct the blood from periphery to center, so that increases the fluid. And what we practice is to monitor a CVP or let's say IVC bedside, and we constantly monitor the stroke output and heart rate. So clinical indicators of response may be a settling heart rate in face of increasing noradrenaline, and increase in the stroke output measured by bedside echocardiography may go a long way here in salvaging the patient. When to assess, when the addition has to be there, I don't think there are any other clinical markers, but only the investigative markers, and every 10 minutes or 15 minutes seeing what has been the stroke output, what has been the filling pressure, and what has been the cardiac output will help us go a long way in salvaging the early critical periods of cardiogenic shock or the sepsis shock. Thank you very much. I would like comments from my co-chairs as well, if there are any.
If there are any questions, we can take up a couple of them. Yeah, sure.
Hello, sir. Good afternoon. Very good afternoon. Sir, basically it's very clear from your presentation that mean arterial pressure target is 65 to 85 mm of Hg in sepsis and septic shock. And it is a very important message that this should be individualized. If a patient has baseline blood pressure of say 160 by 80 mmHg, same target cannot be good for that patient.
Absolutely.
So, in order to prevent organ dysfunction, as you said in your slide, it is not very clear from trials although, but say acute kidney injury is very common in ICU settings. So what is your personal target mean arterial pressure for preventing acute kidney injury? Is there anything, sir, like you can enlighten us upon?
As far as the mean arterial pressure targets are concerned, you rightly said that 65, more than 65 to 70 millimeters of mercury is usually the target which is optimal for majority of patients. But in elderly patients and in patients who are chronically hypertensive, in which already the baseline pressures may not be the same, which holds true for these patients. In these patients, somehow targeting a higher mean arterial pressure who are chronically hypertensive, as I've told in my presentation also. But in patients, in other patients, one should look at the diastolic pressures. If there is diffuse systemic vasodilatation, the chances of encountering other organ dysfunctions, and as you rightly said, AKI is one of the most common first organ to go in patients with septic shock. So in patients, if you maintain the diastolic pressures and keep a track on the diastolic pressure, you might be able to prevent further organ failure. Adequate fluid resuscitation, and it should not more also. I mean, water is poison in patient with sepsis and ARDS. If you don't take care of excessive fluid overload, you will again have acute, more evidence of acute incidence of acute kidney injury, which was one of the endpoints in one of the trials which I showed in my presentation also. In these patients, those patients who were over resuscitated or they were overfilled, the chances of AKI was high. So whenever you have, as sir also pointed out, that dynamic measurements of filling pressures and the fluid status should be kept into mind, and IVC diameter measurement, urine output measurement, and now although it is not readily available, extravascular lung water estimation by various techniques is coming into picture. In fact, electrical impedance tomography to actually find out the status of the lungs in these patients. This all, the role is evolving. So neither the patient should be underfilled nor the patient should be overfilled. The optimal mean arterial pressures should be between 65 to 70, because targeting more than that can lead to microcirculation and dysfunction, endothelial dysfunction, and further leading to organ failure. And in patients who have a higher baseline arterial pressures, a history of hypertension, underlying hypertension should be carefully elicited in these patients and should be found and should be decided whether these patients require a high mean arterial pressures than the standard conventional 65 to 75.
Rough kind of 75 works. If a patient has history of hypertension or no patient, 85 should be maintained, and if it's non-hypertensive, it should be 65. My question is, I'm always confused. In cardiology, we can manage shock and we keep our PCW or let's say pulmonary capillary blood pressure at higher levels. But here, and we go up to, let us say, right-sided filling pressure, even up to 12, 13, 14, up to 20, we can go. But what would be the optimal filling pressure, either by AVP or by IVC? That would you say that now this is where we have achieved, and the role of preload is finished now? Unless we give volume, the pressure will not come. We know that. But how to decide that we have adequate? Is there a cutoff for that now you have achieved this filling pressure and let us stop here?
Okay, I'll take that question. Current standards say that no use of CVP. So current standards do not manage severe sepsis or septic shock based on CVP. Current standards are only for 65 mean arterial pressure. For hypertensive, it can be a 10 or 20 plus of 65, that is already there. Where you measure that blood pressure, 65 by a non-invasive blood pressure measurement or 65 by invasive blood pressure measurements. So that is the trick. So if you are using an NIBP, that becomes an inferior modality of estimating the correct map. So you have to go for an intra-arterial mean arterial pressure, not the peripheral mean arterial. So if you are gauging your measurements based on a NIBP, the management of severe sepsis, you are already flawed because the targets are not correct. Okay, so you have to go for an invasive. Now, as far as the CVP and other, now those, they have got out. Lung ultrasound has come now in place of estimating of volume measurements. Doing a stroke index, as you was telling, yes, it is important, but for non-cardiologists who will be most of the times managing patients of septic shock, doing a stroke index every time will be a difficult issue.
That is what we do.
Yeah.
But that cannot translate into a clinical.
Yeah.
So how do you manage
We do it by lung ultrasound. We do lung ultrasound pre-fluid estimation, what are the lung rockets, B3, B7, and then post-resuscitation, what are the lung rockets. We are capable of doing the stroke index and the stroke volume, we do that. And advanced measures, as you was telling about thermodilution techniques and other impedance plus plethysmography. There are other methods also because there is a lot of talk about dynamic indices of fluid management. Now there is too much of advertisement, but actually when you come down to practically bedside, उनकी utilization इतनी ज़्यादा नहीं है.
Lung ultrasound,
is
much easier and it's available at the bedside. It's
easy to train. It will hardly take me 30 minutes to train person for doing a lung ultrasound. Just 30 minutes. And he can tell whether this patient is having excess fluid or less fluid. So that is the easiest way.
The estimation, a rough estimation of extravascular lung water is very important.
Because that is the edge. If I am overdoing it, it will go into the lung. So I will protect it by putting the patient on ventilator, giving him PEEP. Then my estimations will start upping up because I have provided PEEP to that patient. So I can play with a little more volume. So I will say 250 is not okay, this BP is not rising, okay, let us try another 500.
Instead of going by the echocardiographic,
I will do a lung ultrasound.
you will go by the imaging.
Yeah,
Much more correlated.
there are other methods to that also, like you see the PEEP related graphical analysis of the ventilatory waveforms. So you have to see how the waveforms are varying based on the amount of fluid and amount of pulmonary artery occlusion pressure. Because doing a pulmonary artery wedge pressure in all patients will not be it was a fancy thing 10 years, 20 years, so that's already gone out. So we are now relying mostly to lung ultrasound to estimate the extra volumes that may be going in. Doing IVC is not, again IVC is there, to estimate, but I
It's
can
a crude
check-
measure actually.
Yeah,
It's a-
IVC I will do because I want to see the compressibility or the distensibility index. If he is on ventilator, I will go for the compressibility. I will go for the distensibility index. If not on the ventilator, I will go for the compressibility. So there is a difference, and I'll check the inspiratory expiratory difference, delta difference, and then estimate whether I have to give more volume. So pre-resuscitation, post-resuscitation, all these indices can be checked, and I can see the trends, whether extra volume is required, not required. If I'm confused, I will rely not on volume, I'll rely on norepinephrine. So I'll up the norepinephrine, less on the volume, because less is now more. So don't go with more volumes.
Cardiology practices are entirely different.
Yeah, it's...
We have to have a very adequate filling pressure before we start using our inotropes. By non-invasive methods, we have to ensure that preload is there, and by non-invasive method, we have not only to see the right but left heart filling pressure also before we initiate. So the practice here in cardiology is that unless you have a good filling pressure on the left side, by PCW, what we have seen also is that, but here the mechanism is entirely different.
Yeah,
here
it's
it is the vascular failure. Here
diffuse.
the primary need is that.
So you are talking of a pure cardiac cause of hypotension. Yeah, and we are talking of a septic phenomena which is diffuse, and here the relationship is very different. 30% of all septic will be myocardial depressant, biventricular failures. Now in that scenario where he was talking of dobutamine, there the dobutamine picture will come. That norepinephrine is there, volume is okay, lung rockets are not there, I can add on a dobutamine. So that is how we are relating now information with us. So
The two spectrums of actually the two opposite spectrums. One in which cardiac patients, you have to take care of the filling pressures, you have to take care of those, and if you slightly overdo, that will not harm the patient. But in these patients, if you overfill these patients, there will be interstitial edema, there will be release of pro-inflammatory cytokines, and a bio injury, in which the patient will have organ failure distant to lungs, extrapulmonary organ failures because of interstitial edema and increased alveolar distension.
And last question to Dr. Narayan Prasad sitting here. What matters more, the fall of, what matters more, the extent of fall of the systolic pressure, or for the duration for which the systolic pressure is fallen, even milder for AKI?
Sir, basically, as we all understand since our MBBS teaching, the map of the 65 is a must. So we have to see how early we are getting this map. If a longer duration of hypotension, which is definitely going to injure kidney, at least some degree of acute kidney injury is expected with this. So as soon as possible, you should achieve the map. Volume is always important, as in your cardiac settings, in our settings also, but our patients with the kidney failure, really, those who do not have this hypovolemic shock or hypovolemic conditions, most of the times patients are little bit volume overloaded. So if renal failure is already settled, patient is volume overloaded. So that is never a problem. Only post-gastroenteritis AKI, like conditions where the dehydration is the reason, there we should ensure that volume is adequate and then try to achieve your map. That's become important. So I think everything needs individualized.
So thank you very much, sir. With this, we conclude this session. And thanks a lot.
Thank you, sir. Thank you.
Thank you, sir. Using vasopressors is like driving a car in ICU. Timing and control are everything. You have shown us that. Thanks for giving us the roadmap. Now I'll request Professor Ved Prakash, sir, to please come onto stage to felicitate our guest speaker and chairpersons. Professor Alok Nath, sir. Professor S.K. Dwivedi, sir. Professor Anand Srivastava, sir. Professor Darshan Dujal, sir. वही Professor Harish Gupta, sir. Dr. Vipul Prakash, sir. We'll now move on to our next session. I request the chairpersons for the next session to please come on to stage. Dr. S.K. Sonkar, sir, Professor of Medicine, King George Medical University. Dr. Rajesh Harshvardhan, sir, Professor and Head, Hospital Administration, SGPGI. Dr. Medhavi Gautam, ma'am, Additional Professor, Medicine, KGMU. Dr. Lakshya Solanki, Consultant Nephrologist, Midland Hospital, Lucknow. Dr. Durgesh Pushkar, sir, Assistant Professor, Nephrology, KGMU. Welcome, chairpersons. I now request you to please introduce our next guest speaker and preside over the session. Thank you.
So good afternoon. So Professor Narayan Prasad is the head and from the Department of Nephrology at SGPGI and the Honorable Secretary of Indian Society of Nephrology, and has a fellowship as a fellow in the Indian Society of Nephrology, has various publication. And sir, your topic is dosing of CRT, permissive low dose, how much? Thank you, sir.
Thanks, chairs. And at the outset, I would like to thank Dr. Ved Prakash ji and for this kind invitations to speak on such an important topic. So, as this CME is particularly associated with the sepsis, and major focus was on sepsis, and one of the important complication of the sepsis is always AKI. That complicates the course of the sepsis. And once the AKI happens, renal replacement therapy becomes one of the important modality to support the patient. So common questions and quest for renal replacement therapy in AKI So are all AKI in ICU are the same? Is sepsis associated AKI are different from non-septic AKI? AKI with multi-organ failure is different from mono-organ failure, or whether the comorbidity affects the choosing the modality of renal replacement therapy. AKI status in ICU is, we all understand, it is very dynamic. In hours time, the patient was stable, patients develop sepsis, develops hypotension, patients may develop hypoxia. So this is dynamic and changes, one organ changes, suppose hypotension happens, it affects not only kidney, it also affects the lung, it also affects the heart also. So it is a very dynamic situation. So two organs which have the most commonly have crosstalk between the two organs are usually the acute kidney injury in kidney and lung, acute lung injury. Whenever you have hypoxia, patients can develop ischemic injury all across, not only limited to the kidney, but can have the acute kidney injury of the other organs, including the muscles, can have the increased production of the lactic acidosis. And at the same time, when you have the kidney failure, the patient would have the volume overloaded, and there would be situation of the pulmonary edema that might be emergency-like situations. So two crosstalks, that becomes very important, and supporting both organs becomes important. If the patient in hypoxia, you are not supporting with this ventilator, it is possible that your kidney function is also going to simultaneously worsen. If the patient has volume overload, pulmonary edema, if you are not supporting with this RRT, not doing ultrafiltration, not doing volume balance, it is possible that the situation may get worse. So how much dialysis or when to start dialysis? So is more and more dialysis beneficial in any modality? Suppose most of the study related to dosing of the dialysis or RRT came between 2000 to 2010. At that point of the time, there was concept that do more and more dialysis, the patient would be better. So, but what happens, there was one study, hemo study, good randomized control trial in hemodialysis, that has also shown there is no difference in the outcome, whether you are giving the high dose of the renal replacement therapy, dialysis, or the standard dose. There was no difference. Similarly, Edimex study was on the peritoneal dialysis, and that also concluded giving more and more dialysis is not really beneficial. So more is not better than less. So that was the concept. Don't do over dialysis, that is also important. Then situation comes early versus late. How early we should do, whether there is any impact. I am giving you this 5 randomized control trial study of the AKI, early versus late. Early most of the times between 8 to 12 hours, late most of the times 48 to 72 hours. What you can see here on the mortality data, 60 to 90 days mortality, no difference, no difference. 4 studies have shown no difference at all, whether you are giving the early or late start of the dialysis. Only 1 study has shown early start might be the beneficial. So what is the message from this all randomized control trial? Individualization of the patients, whether really your patient requires at what time of support. So there is no hurry, take your time, study your patients, then start. Whenever I get the call from CBTS ICU, probably this patient worsened because you have not started CRRT within our time, this patient is going to worse, that kind of the blames comes on from other departments. But I can show you with this all 5 randomized control trial, there is no hurry. Study your patient, see your patient, and then individualize whether really when to start any modality of renal replacement therapy. There are different modality, intermittent hemodialysis, now SLADE, slow low efficiency dialysis, longer duration, slower dialysis. Then CRRT, continuous renal replacement therapy. In that modality, you might have the CVVH, only hemofiltration. and CVBHD when you use some dialysate also, and CVBHDF. So there you can manage the patient by only getting hemofiltration, by ultrafiltration, or you can get by giving some dialysate also. So different modality are there. Then again there is long debate which modality should be chosen. I will come on conclusion by the last. So coming to my topic of this, how much dialysis CRRT is required in patients who develops AKI, who are on the sepsis or due to any reason, if the patient has AKI. The first study was conducted by Claudio Ronco. He is thought to be one of the masters of the critical care medicine, and he has done randomized control trial study with the 3 doses, 20 ml per kilogram per hour versus 35 and 45 ml per kilogram body weight. What you can see here, 35 and 45, there was no difference in the mortality. But definitely 20 ml, 25 ml, this dose was looking like little inferior, survival was not that good. So 35, it is somewhere above the 20, and but 20, not more than 35 to 45 ml is the same. And in that same study they have shown the presence of sepsis, blood urea nitrogen at start, and Apache 2 score were the significant factors for the mortality. But what you can see here, this related to the sepsis, those patients who had sepsis, on adjusting other risk factors for mortality, there was protective effect on mortality compared to other regions when they have adjusted everything. Other important studies, I think most of the studies at that time was published in NEJM kind of the journals. Here the dosing was such an important phenomenon, because on CRRT, if you are giving higher doses, you are putting a lot of cost to the patients. So whether dialysis should be done thrice per week, less intensive group, thrice per week, hemodialysis or SLADE, or in intensive group daily, almost 6 times per week, or if you are doing CVH, 20 ml per kilogram versus 35 ml per kilogram. Again, what do you see here? Mortality at 60 days was similar in less intensive group or high intensity group. It is almost 52 versus 54%. So again, this was again a very good landmark trial supporting that probably. This was famous with the ATN trial. There is no difference in the mortality whether you are giving the daily dialysis almost 6 times per week or 3 times per week. So again, you can see here 60 days mortality, there was no difference between the two. You can see the curve of the survival was overlapping with each other. There is no interactions of the p-value here. We can see significant interaction whether depending on the SOFA score, oliguria, gender or sepsis. Again you can see. But only thing there was in intensive group, requirement of vasopressure was relatively less, and hypophosphatemia was relatively more. Hypophosphatemia, patients those who are getting intensive dialysis, hypophosphatemia was more. Again, what we can see here, another important study, CVBHDF. When you are along with the hemofiltration, you are supporting with the some of the dialysate also, some dialysis also. Here again randomized control trial. She is Isita Tolbani. She is thought to be the CRRT queen of University of Alabama. Most of the studies conducted, she was one of the authors. Here we can see she has randomized 2 groups of the patient, 100 groups in each group, 20 ml versus 35 ml. What you can see again here, there was no difference in the survival curve between the 35 ml per kilogram per hour versus 20 ml per kilogram per hour. Even with the CVBHDF modality, there was no difference in the survival difference or mortality difference of the 90 days between the high dose versus low dose CRRT. Then again situation comes, early high volume hemofiltration or early low volume hemofiltration versus late low volume hemofiltration. Again, what you can see, survival at 28 days there was no significant difference. 74% versus 68 versus 75%. There was no difference at all whether you are starting late or early with high dose or low dose VHF. So probably the patient was not dying because of only the renal replacement therapy or this lack of this support. Probably the reason might be something else. Then one paper came whether adding a dialysis dose to CVVH. This was the one positive study which have shown that probably giving more dialysis might be better. In this group of the patients, they have given CVVHF 25 ml per kilogram per hour. On add-on value, they have been given dialysis use of 18 ml per kilogram per hour. And then they have compared this. They have shown 28 days survival and 90 days survival was better in high dose group. If you are giving add-on therapy with the dialysis, 18 ml per kilogram per day, patients might do better. So this was like a cherry on some ice creams. What you can see here, again the same, there was CVVHDF has better survival as compared to CVVHF alone. So adding dialyzers in the system, patient might do better. Then there were a lot of papers came in critical care medicine journals that came in NEJM. So this was the time to have this meta-analysis. 6 randomized control trial having the meta-analysis of more than 3,500 patients. What we can see here, most of the studies have not shown any significant effect of the high dose of the CRRT. Only 2 studies, the first study which I have told about, the Roncos study, and another study by Saudan, which has been published in KI, they have shown little better outcome with the high dose of continuous renal therapy. Here the intensive dose means 35 to 48 ml per kilogram, but less intensive dose 19 to 25 ml per kilogram per hour of the ultrafiltration. So there was no impact of high dose CRRT overall. When you look at this meta-analysis, everything was favoring. There you can see all diamonds here on the central line. Another important quest came when there was one study recently published in 2024 in American Journal of Kidney Disease. There was situation in Japan. Japanese, and the cost was the major barrier, insurance policy was not allowing. So in that study, what they have shown, their median dose of the dialysis was 13 ml per kilogram. What they have shown, below the 13 ml, mortality was high. So that was quite low given all across the world. At least 20 ml was the 20 ml is the minimum requirement of dialysis, where this came as low as 13 ml. So that was too low. And again, they have shown too low of the dialysis is really not beneficial. It deteriorates the patient's condition. Mortality is usually high in this group of the patients. Here again, see, when they have compared 10 to 15 versus more than 15 ml, 10 to 15 ml has higher mortality. And our risk ratio of mortality was more than 53%. And then there, in the same group of the patient, what they have seen, there was major impact of which favors median showing better in patients with the age of more than 72 years, female gender, BMI of less than 22, Apache score if it is less than 25, or the presence of the sepsis again has favorable outcomes in that study of Japanese studies. Concern was always if you are giving the high dose versus low dose, cost always remains a concern. If you are giving the low dose with the equal efficacy, you are saving the cost. And at least $67 was the mean saving in this group of the patients. Another randomized control trial, again, you can see continuous renal replacement therapy. The 2 AKI study, which has the EKAKI or ideal ICU study, again, what they have shown, they have taken some patients from both the studies, and compare the high dose versus low dose, what they have seen, again there is no difference in the two RRT modalities in more severe septic patient. What you can see at this, they have compared the high dose versus low dose with different SOFA groups. Except one, 3 to 10 of the SOFA scoring, there was benefit of intermittent hemodialysis and CRRT. There was some gap in the curve, but the rest all, there was no significant difference. So what does this indicate? It indicates that probably the patient is dying due to some other reason. It is not only the renal support system which is affecting the survival of the patients. So probably so far score, more sicker patients, you might require CRRT supports. If the patient is less sick, you can go away with the intermittent hemodialysis, saving the cost. This is our own SGPGI-MS data. One of our senior resident in critical care medicine has conducted this study, SLADE versus CRRT. Whether slow, low efficiency dialysis is equally good with the CRRT. Outcome was similar, but cost saving you can see, per session cost saving was almost 500 USD when you are doing SLADE and getting away from the CRRT. So concept of the dynamic CRRT delivery. Situation of the patient in ICU changing every hour. It is possible that in the next hour the patient deteriorated a lot. In the next 6 hours patient becomes totally stable, does not require vasopressor is off, everything is off. So why to do CRRT, the costly therapy? Stop CRRT, go on intermittent hemodialysis. Patient's hemodynamic status is now stable. And the concept is there, at least most of the times you give the longer dialysis, 24 hour on the CRRT, some machine down time. Sometimes our dialyzer gets clogged. So at least 80% of the 24 hours of the time, at least 80% time patient should be on the dialysis. Ratio of delivered and prescribed dose should be more than 0.8. So in conclusion, neither early nor more is better. Optimum is optimum. Dosing of CRRT, KDIGO recommend in their 2012 clinical practice guideline an effluent dose of 20 to 25 ml per kilogram per hour. And they have given this rating of 1A. So that must be 20 ml per kilogram per hour should be the ideal dose of the CRRT. More is not required. And this has been reiterated in another guidelines by NKF Doki guideline in 2013. So ladies and gentlemen, thank you ladies and gentlemen, thank you for your kind attention. And we have a World Congress of Nephrology at New Delhi, first time happening any World Congress in nephrology scenario at Delhi. And tomorrow is the last day of abstract submission. Anybody interested can join that meeting. Thank you ladies and gentlemen, thank you.
Thank you, sir. That was a nice lecture. So these patients on CRT, most of the time they are on inotropic supports, and there is volume disturbances also. So how to manage with regarding sepsis, patients on inotropes? This CRT could be modify anything, or we can go with SLADE?
Yeah, definitely. The emphasis was there that you have to individualize your patient's management. If your blood pressure always should have the mean blood pressure recommended was the 65, more than 65. So MAP at least should be 65. That should be maintained anyhow. Whether the patient is volume deficit, we should give replacement. We should have this vasopressors used, noradrenaline as recommended. I have seen in the previous lecture. So that is another important point. And definitely CRRT in patients who are very much compromised, requiring high dose of the vasopressor, you are not connecting the patients with this intermittent hemodialysis machine where there is likely chance of the acute deterioration of the blood pressure. There it works definitely. But excessive use does not require that once the patient's vasopressure is off, patient becomes stable. It permits you to go for the intermittent dialysis, you can do. SLADE versus CRRT is always a concern. You have to judge the patient. If the patient, you think that patient will tolerate SLAD, you can start on the SLAD. If the patient is well maintaining vasopressure, lower dose of vasopressors, blood pressure is 110/70 maintaining, some amount of the urine is coming, you can choose SLAD rather than CRRT. It is not always required. Outcome is almost similar.
Thank you, sir. Thank you so much for this wonderful talk. Sir, I have a question. Is it audible? Hello? Sir, what are the clinical parameters which can prompt us to readjust the CRRT settings? Like here we go for blood pressures, volume overload, electrolytes, and also the urine output. Like low dose versus high dose does not have any mortality benefit, but are there any parameters where we should switch the patient from low dose to the high dose or vice versa?
Definitely, what you can see, not only the mortality, low dose versus high dose, whenever you are giving too much of the ultrafiltration, suppose 40 ml of the ultrafiltrations, then your replacement fluid cost go up without too much of the benefit. So whenever your basically hemodynamic parameters is important. Whenever your hemodynamic parameters allows you to shift from one modality to other modality, one mode to other mode, we must consider that is the most important thing. If patient becomes totally stable, patient is no longer in volume overload, patient vasopressure you are gradually decreasing, urine output is gradually improving, then giving too much of the dialysis is of no use.
So he's talking about IV albumin role.
Role of IV albumin, see.
As far as blood pressure control and volume and all these things parameters.
Usually in day-to-day practice now, some of the intensivists use albumin. When you think of the colloidal pressure is required to maintain the blood pressure, sometimes it helps. But when you look at all the trials, use of the IV albumin is not going to help too much. Yes. Unless the patient's albumin level is very low, patient is abnormally edematous. So as a recommendation, routine recommendations, no.
Yes, sir. And sir, because we have so much of downtime, like patients are shifted to for some procedure and all that. So at that point, should we keep the dose towards the higher side or like?
No. Actually, downtime is reported across the world. In best of the ICUs, there are downtimes, but that should also be considered in giving the duration of the dialysis. It should be more than 80% time. Patient should be on modality. Downtime should not be more than 20%. So yes, that is usual recommendations.
Yes, sir. Thank you so much, sir. Thank you, sir.
Well, if the time permits, one or two quick questions from audience, if any. Thank you, sir, for such a wonderful topic. One question from my side, sir. Actually, we usually divide AKI on the basis of increase in serum creatinine and urine output criteria, but no guideline recommends initiation of RRT on the basis of urine output. So, what should be the criteria for urine output to start over RRT AKI?
Yeah. In most of what I have shown you, the 5 different AKI randomized controlled trials, they have taken 2 important parameters. One was the urine output criteria also. If more than 12 hours the patient is anuric, it is thought that probably there would be some indications will come out to start on the dialysis. Some centers start at 6 hours, some centers at 12 hours. Anuria for 12 hours is an indication irrespective of any status of the serum creatinine value. It is possible that your patient is totally malnourished, patient has severe liver disease, and the serum creatinine value of the 2 is again equivalent to your GFR of 5 or 10. So in that situation, you have not to wait, you should start on dialysis, you don't go by the serum creatinine value. So anuria is again important parameter. Whenever you have the anuric patient for more than 12 hours, you can think of if the patient requires renal support. There are 2 important things from the renal support point of view. One is the dialysis, you are treating the patients. One is the only to support the other organs. Suppose patient is anuria, you have resuscitated with the more than 3 liters of the fluid, and now the patient is in pulmonary edema, and patient needs removal of the fluid. So in that situation, either you can do isolated ultrafiltration, or you can connect with this dialysis and can get some ultrafiltration. So that situation changes, but definitely urine output criteria is important. And another important criteria is always
If there are no more audience questions, then you would like to close the session.
Thank you very much, sir.
Thank you, chairpersons. We'll proceed with felicitation after the inauguration ceremony. In the silent corridors of care, where breaths falter and futures hang, we stand united in a pious mission to turn the tide of a cruel hand. For in each heartbeat there is hope, and in each patient's gaze a plea. Then we, those who fight unseen, shall rise and work with unity. With science as our shield and compassion as our guide, we strive to heal, soothe, save on this perilous yet noble ride. Today we gather a consortium strong to share our knowledge, to right the wrong. Together we light a path anew for those who trust in us to see them through. Good afternoon, everyone. We'll begin our inaugural function by inviting on stage our esteemed dignitaries who have joined us here on behalf of the department. We welcome our chief guest, Honorable Deputy Chief Minister of Uttar Pradesh, Minister of Medical Education, Medical Health and Family Welfare, Maternal and Child Welfare, Shri Brijesh Pathak ji. Welcome, sir. Taking our event further, we welcome our Chief Patron, Dr. Sonia Nityanand, ma'am, Honorable Vice Chancellor, KGMU. Welcome, ma'am. Next, I would like to invite our guest of honor, Professor S.K. Jindal, sir. He is the founder, professor and head Department of Pulmonary Medicine, PGI Chandigarh, Emeritus Professor, PGI Chandigarh. He is Medical Director, Jindal Clinics, Chandigarh. Welcome, sir. Moving ahead, I would like to invite our next guest of honor, Padma Shri Professor Digambar Behra, sir. He is an Emeritus Professor and ex-professor and HOD PGI Chandigarh, ex-director National Institute of Tuberculosis and Respiratory Diseases, and is director Pulmonary Medicine, Fortis Healthcare, Mohali, Punjab. Welcome, sir. I would like to now invite our special guest, Professor Amita Jain, ma'am, Dean Academics, Professor Deepak Malviya, sir. We cordially welcome Professor Dr. Rajendra Prasad, sir, Organizing Chairman of Sepsis Consortium 2024, ex-Director VP Chest Institute, Emeritus Professor, National Academy of Medical Sciences, and Director Medical Education, Eras Medical College and Hospital, Lucknow. Next, I would like to invite our special guest, Professor Suryakant, sir, Professor and Head of Department of Respiratory Medicine, KGMU. I now welcome our Scientific Chairman, Professor R.K. Singh, sir, Professor and Head, Department of Emergency Medicine, SGPGI, Lucknow. Our next special guest, Professor Alok Nath, sir, Professor and Head, Department of Pulmonary Medicine, SGPGI, Lucknow. Welcome, sir. We now invite on dais our guiding force and mentor, Professor Ved Prakash, sir, Head of Department, Pulmonary and Critical Care Medicine, KGMU, and the Organizing Secretary of Sepsis Consortium 2024. Welcome, sir.
Welcome, everyone. Now I request our Organizing Secretary, Professor Ved Prakash, sir, to felicitate our esteemed dignitaries with saplings. I request him to felicitate our Chief Guest, Shri Brajesh Pathak ji. Kindly felicitate our Chief Patron, Dr. Sonia Nityanand, ma'am. Guest of honor, Professor S.K. Jindal, sir. Guest of honor, Professor Digambar Behra, sir. Our organizing chairman, Professor Rajendra Prasad, sir. Our special guest, Professor Suryakant, sir. Our scientific chairman, Professor R.K. Singh, sir. And our special guest, Professor Alok Nath, sir. Now, according to our tradition, may we request our esteemed members seated on the dais to kindly inaugurate the event formally by lighting the auspicious lamp. Let's pray to God that we may continue to burn the auspicious light that may bring in happiness, prosperity, and healthy long life to the people of India and around the world.
और हमारे बहुत ही प्रिय डॉक्टर वेद प्रकाश, एक थोड़ी सी बात अच्छी नहीं है, क्योंकि स्वास्थ्य मंत्री जी बैठे हुए हैं, मैं कह सकता हूं कि जो देखिए बड़े बड़े मेडिकल कॉलेजेस में हमारे ज़माने में जब हम यहाँ हेड थे तो आईसीयू नाम की चीज़ सुनते थे, 1-2 वेंटिलेटर थे। बधाई के पात्र हैं पूरी उत्तर प्रदेश सरकार, खासकर हमारे स्वास्थ्य मंत्री जी, कि अब वेंटिलेटर से बड़े बड़े अस्पताल भर गए। मेरा मानना है कि सिर्फ बड़े अस्पतालों से ही काम नहीं चलेगा, ये हमको जिले लेवल पर जाना पड़ेगा, क्योंकि बहुत कॉमन चीज़ें हैं और उनको ट्रेन करना पड़ेगा। और जब मैं कहता हूँ क्रिटिकल केयर या इंटेंसिव केयर, जिसका सेप्सिस एक अच्छा खासा हिस्सा है, उसके डॉक्टरों की ट्रेनिंग, और डॉक्टरों से ज़्यादा मेरा मानना है जो पैरामेडिक्स हैं उनकी भी ट्रेनिंग बहुत अच्छी करानी चाहिए। मुझे बड़ी खुशी है, जब मैं सैफई में डायरेक्टर था 2011 में आसपास, तो वहाँ एक पैरामेडिकल कॉलेज था। जब मैं गया तो पैरामेडिकल कॉलेज 5 साल से बन के, मैं वहाँ का दूसरा डायरेक्टर बना था, 5 साल से बन के वो खड़ा था और मुझे आदेश मिला था कि डॉक्टर साहब इसको चलाना है। और मुझे बड़ी खुशी है कि वो पैरामेडिकल कॉलेज हमने 4 महीने के अंदर वहाँ, वो मेरा एक अचीवमेंट वहाँ के लिए मैं मानता हूँ, 4 महीने के अंदर वहाँ का पैरामेडिकल कॉलेज शुरू कराया। तो मैं ये और लगभग 800 विद्यार्थी उस वक्त पैरामेडिकल में हम लोगों ने एडमिशन कराया था, अब तो बढ़ गया होगा। तो मेरा कहने का मतलब पैरामेडिकल ये जो जितनी भी क्रिटिकल केयर है, इंटेंसिव केयर है, सेप्सिस से रिलेटेड है, यहाँ पर पैरामेडिक्स की भी ट्रेनिंग बहुत ज़रूरी है। काफ़ी काम हमारे सरकार में हुआ है, लेकिन हम चाहते हैं अभी और आगे बढ़े, जिससे हम मरीजों को, जो इतनी ज़्यादा मृत्यु हो रही है, भारत में भी हो रही है, प्रदेश में भी हो रही है, हम कम कर सकें। यही मेरी एक इच्छा है। एक बात और मैं कहना चाहता हूँ, हम जितने भी गाइडलाइंस हैं वो हम विदेशों की पढ़ते हैं, और सेप्सिस की भी गाइडलाइन सब वहीं से बन के आती है। आल्दो हमारा क्रिटिकल केयर का पूरा एसोसिएशन है, लेकिन मेरा अपना रिक्वेस्ट है कि हम सबको अपने देश के अनुसार, अपने प्रदेश के अनुसार कुछ जो वो भी मॉडिफिकेशन करना है। देखिए, मानना पड़ेगा कि हमारा देश अभी बहुत अमीर तो नहीं है, बीच में हो रहा है, तो हमें उस हिसाब से गाइडलाइंस को बनाना पड़ेगा, जिससे हर व्यक्ति, गांव का छोटा सा छोटा व्यक्ति भी इन सब चीज़ों से लाभान्वित हो जाए। इसी सिलसिले में मैं पाठक जी का, अभी 2 दिन पहले पाठक जी ने मैंने इसी ध्येय को लेके, अभी तक हम लोग चेस्ट एक्सरे की किताबें सब विदेशियों की पढ़ते थे। फेल्सन की किताब मुझे याद है, हमने जब हम 1976 में MD करने आए थे तो पहली किताब हम लोगों ने वही पढ़ी होगी, सूर्यकांत को भी याद होगा कि पढ़ी होगी। तब से मेरे ड्रीम था कि हम क्या इंडियन पेशेंट्स के संग, इंडियन एक्सरे के संग, क्या हम रेडियोलॉजी की किताब नहीं लिख सकते हैं। मुझे बड़ी खुशी है, लग गए 40 साल, लेकिन वो किताब अभी हमारे आदरणीय पाठक जी ने अभी 9 तारीख को उस पुस्तक का विमोचन किया। इन शब्दों के संग मैं ज़्यादा ना बोल के आप सबों का मैं पुनः स्वागत करता हूँ। धन्यवाद।
Thank you, sir. I would like to invite our guest of honor, Padam Shri awardee Professor Digambar Behra sir, to share his thoughts on the occasion.
Honorable Deputy Chief Minister, Shri Pathak ji, Madam Vice Chancellor, Professor Nityanand ji, Professor Jindal, Professor Rajendra Prasad, Dr. Suryakant, Dr. Singh, Dr. Alok, Dr. Ved, and ladies and gentlemen. In fact, I remember few years back, myself, Dr. Rajendra Prasad and Dr. V.K. Jain, we were invited by the then Vice Chancellor, Professor Ravikant, to select candidates for the Department of Critical Care Medicine in this institute. So of course I had taken the off the record permission from my dear friend Professor Suryakant that whether he wants this critical care medicine department in this institute or not. I told him, but anyway he was very kind and gracious enough to agree that yes, this department should be started. And Professor Rajendra Prasad, I think we have not done any mistake by selecting this man. And of course another we selected, he left this department, but I think a wonderful job Ved you are doing, bringing about the awareness about critical care. I think, sir, very simply I will tell you, when the COVID thing came in, everybody came to know about the importance of when the country needs for other reasons why the pulmonary medicine should be there. We have the TB control, we have got many other pulmonary diseases in addition to at least some basic training of critical care. I am not telling every every PG student of chest and TB should be a critical care medicine specialist, but at least they should have some knowledge. So situations like COVID, we could handle, we could fight in future. The second issue is, obviously we should understand the figures which we are discussing since morning is about 50 million cases of sepsis cases in the world. In India, the figure is around 12 million per year, with many people dying. So that you can imagine, sir, the necessity or the requirement of specialists. It is not only the requirement of specialists and paramedics, as Dr. Rajendra Prasad said, it is also very financial equipment and other facilities, they are also very much required. And we are very happy to see the department here. I come many times, I have come here and we have seen this department, but I think this it needs still further improvement. It still needs further help from the government of Uttar Pradesh, and please make it one of the best critical care medicine departments. I am sure the person here is very committed, as we are seeing, and you see he has at least bringing about the awareness about the sepsis consortium he has felt, and all of us are now part of that, and at least an awareness is being brought about. So with these few requests and suggestions to you, sir, I am sure you are a very dynamic person, and I am very deeply associated with this KGMU. As I told you, Dr. Rajendra Prasad, Suryakant, Ved, and other young friends. I was here also. I come very often. Earlier I was coming establishing the Raebareli AIMS. I was the officer on special duty while the institute was being built. I was very deeply associated with it, traveled extensively, and KGMU was one of my favorite stops. So I know many things about KGMU, and I will again request you, a dynamic person like you should try to develop this department and help them. Thank you. Jai Hind.
Thank you, sir, for sharing your experience. I would like to invite now our guest of honor, Professor S.K. Jindal, sir, to please come onto stage and enlighten us with his wisdom.
Well, thank you. Honorable Chief Guest Shri Pathak Ji and Deputy Chief Minister and Minister of Health, Honorable Vice Chancellor, Professor Rajendra Prasad, Dr. Ved Prakash and other friends, Dr. Suryakant, Dr. Alok Nath, you see, Dr. R.K. Singh, of course, my own old friend and colleague, Dr. Behra, you see. Ladies and gentlemen, it is a matter of great pleasure and honor for me to be here today and visit this department with which I have been In fact, I have been coming to KGMU several times, you see, in the past, but now, since Dr. Ved Prakash had taken this, I think, department further, you see, earlier with Dr. Rajendra Prasad and Dr. Suryakant, of course, I had long association, and now it is a new department, which as I said earlier, it is one of the largest DM program in pulmonary medicine in the country. I must say that, you see. At least the number of beds, the number of ICU beds and so on. I think very few kind of pulmonary medicine department talk of things like sepsis and other things. So mostly they are limited to asthma, COPD or tuberculosis. So it is a matter of great pleasure to see that they talk of these things like sepsis, ARDS and other critical issues. Of course, the importance of sepsis everyone has realized during the COVID-19 epidemic, you see, and the management which it required on a large scale from the public health point of view, not only from the institutes, but from the governments in general. And the issue was handled very well all over the country and of course in UP as well. So I am really glad to be associated with this activity, and I'm very thankful to Dr. Ved Prakash for giving me this opportunity. So I think I agree with what Dr. Behra had said about various other issues, and thank you very much for your patience.
Thank you, sir. Now I would like to invite our Chief Patron for the event, Professor Sonia Nityanand Ma'am, Honorable Vice Chancellor, for her blessing and message.
थैंक यू। माननीय उप मुख्यमंत्री ब्रजेश पाठक जी, सॉरी, डॉक्टर बेहरा, पद्मश्री डॉक्टर बेहरा, डॉक्टर जिंदल, डॉक्टर सूर्यकांत, डॉक्टर आर.के. सिंह, डॉक्टर आलोकनाथ, डॉक्टर वेद प्रकाश, और भी जितने फैकल्टी मेंबर्स हैं KGMU के और जो बाहर से आए हैं, एंड ऑल द स्टाफ एंड पार्टिसिपेंट्स, सबसे पहले KGMU की तरफ से आप लोग सबका हार्दिक अभिनंदन। मैं माननीय उप मुख्यमंत्री जी, जो हमारे मंत्री भी हैं मेडिकल एजुकेशन के, सबसे पहले आपको धन्यवाद देना चाहूँगी कि आप बहुत बिजी हैं, पर तब भी आपने टाइम निकाल के आए हैं और इस फंक्शन को एक अलग महत्व दिया है। बहुत बहुत धन्यवाद आपका। आई एम ऑल्सो वेरी ऑनर्ड कि डॉक्टर बेहरा एंड डॉक्टर जिंदल हैं, ये लोग स्टॉलवार्ड्स हैं इस फील्ड में, जिन्होंने पल्मोनरी मेडिसिन की स्पेशलिटी इस देश में इस्टेब्लिश करी है, DM प्रोग्राम शुरू करा है। बहुत बड़ा ऑनर है कि आप लोग आए हैं इस फंक्शन में। सेप्सिस एक ऐसा एरिया है जो लगभग सभी डिपार्टमेंट्स के साथ ओवरलैप करता है। सबसे कॉमन ऑफ कोर्स लंग इन्फेक्शंस होते हैं, पर यूरोसेप्सिस भी बहुत इम्पॉर्टेंट है, GI सेप्सिस है, स्किन के इन्फेक्शंस हैं। सो लगभग सभी ऑर्गन्स के, सभी सिस्टम्स में इन्फेक्शन हो सकता है। और जो सबसे वरिंग है इस समय भारत में, स्पेशली भारत में बट ऑल ओवर द वर्ल्ड, वो ये है कि आज के दिन बैक्टीरियल इन्फेक्शंस मल्टी ड्रग रेजिस्टेंट हैं, बिकॉज हम लोग इनडिस्क्रिमिनेटली यूज़ करते हैं एंटीबायोटिक्स। हम लोग के NEP नेशनल एजुकेशन पॉलिसी में आप देखिए 2020 में बहुत ज़्यादा नहीं है मेडिकल एजुकेशन के बारे में, कुछ मेडिकल एजुकेशन डिटर्मिन्ड है मेडिकल काउंसिल ऑफ इंडिया से, बट एक चीज़ का फोकस है वो प्रिवेंटिव मेडिसिन है। और इन्फेक्शंस का प्रिवेंशन बहुत इम्पॉर्टेंट है। वैक्सीन एक चीज़ है, बट हर चीज़ के लिए वैक्सीन नहीं अवेलेबल है। सो सिंपल, स्पेशली एक हॉस्पिटल के लिए ये बहुत इम्पॉर्टेंट है, सिंपल टेक्निक्स फॉर हाइजीन। और ये मैं रेजिडेंट्स, नर्सिंग स्टाफ, पैरामेडिकल स्टाफ के लिए कहना चाहूँगी कि सिंपल प्रिकॉशंस फॉर इन्फेक्शंस अगर हम लोग अडॉप्ट कर रहे हैं, जैसे हैंड वॉशिंग टेक्निक है, वेयरिंग ऑफ मास्क, फेस मास्क जहाँ रिक्वायर्ड हो, इनडिस्क्रिमिनेट यूज ऑफ एंटीबायोटिक्स ना करें। हर संस्थान में अपनी एक एंटीबायोटिक पॉलिसी होनी चाहिए जो एंटीबायोग्राम पे डिपेंडेंट हो, तो हम लोग इसको रोक सकते हैं जो स्प्रेड ऑफ इन्फेक्शंस हैं विद मल्टी ड्रग रेजिस्टेंट ऑर्गेनिजम्स। मैं समझती हूँ कि ये ज़रूर कवर करा जा रहा होगा आज की सिंपोजियम में। और डॉक्टर वेद प्रकाश, आपको मैनी कॉन्ग्रेचुलेशंस कि आपने ये आज कंसोर्शियम बेस्ड सिंपोजियम रखा है। ये जितने भी डिपार्टमेंट्स के आज फैकल्टी यहाँ मौजूद हैं, सब लोग को जॉइन हैंड्स करके, एवरी वन ऑफ अस शुड जॉइन हैंड्स विद ईच अदर एंड रियली मेक अ पॉलिसी अपने अपने अस्पताल में, अपने एटलीस्ट KGMU के लिए तो मैं कहूँगी बहुत, आई कैन सी अ लॉट ऑफ फैकल्टी हियर, आई कैन सी द मेडिकल सुपरिटेंडेंट ऑल्सो हियर, कि हम लोग एक ऐसी पॉलिसी बनाए कि द इन्फेक्शन रेट अपने वार्ड्स में कम हो जाए एंड द इमर्जेंस ऑफ मल्टी ड्रग रेजिस्टेंट ऑर्गेनिजम्स कम हो जाए। थैंक यू फॉर आप लोग सबको कि आप लोग आए हैं, इस सिंपोजियम में अटेंड करेंगे। जितने डिग्नेटरीज हैं डायस में, आप लोग को बहुत बहुत धन्यवाद कि आप लोग आए हैं। थैंक यू। जय हिंद।
Thank you, ma'am. Now I would like to invite our chief guest, Honorable Deputy Chief Minister Shri Brijesh Pathak ji, to deliver his message.
विश्व सेप्सिस दिवस पर आयोजित सेप्सिस कंसोर्शियम 2024 कार्यक्रम में उपस्थित KGMU की कुलपति प्रोफेसर सोनिया नित्यानंद जी, पद्मश्री प्रोफेसर D बेहरा जी, प्रोफेसर SK जिंदल जी, प्रोफेसर RK सिंह जी, प्रोफेसर आलोकनाथ जी, प्रोफेसर राजेंद्र प्रसाद जी, प्रोफेसर सूर्यकांत जी, प्रोफेसर वेद प्रकाश जी, सामने बैठे सभी प्रतिभागीगण, फैकल्टी मेंबर्स, पत्रकार मित्रों, मेडिकल साइंस में भारत ने बहुत अच्छी प्रगति हासिल की है। दुनिया के पैमाने पर जो भी बदलाव हो रहे हैं मेडिकल साइंस में, भारत ने अहम भूमिका निभाने का काम किया है। भारत में खासकर उत्तर प्रदेश की मैं चर्चा करना चाहूँगा। उत्तर प्रदेश में चिकित्सा विज्ञान के क्षेत्र में अभूतपूर्व प्रगति हुई है। हमारे चिकित्सा संस्थान, मेडिकल यूनिवर्सिटीज, मेडिकल कॉलेज मेडिकल की पढ़ाई के लिए, गुणवत्तापरक पढ़ाई के लिए जाने जाते हैं। साथ साथ में नई विधाओं का, नई आविष्कारों का, अपने विशेषज्ञों के साथ सेमिनार का आयोजन करना, कंसोर्टियम का आयोजन करना हम अक्सर अपने यहाँ देखते हैं। मैं कार्यक्रम की सफलता के लिए बहुत बहुत शुभकामनाएं देता हूं। देश भर से आए हुए अपने जो मंच पर विभिन्न राज्यों से हमारे प्रोफेसर्स आए हैं, बेहरा साहब, जिंदल साहब, आप सबका हृदय से मैं स्वागत करता हूं। आपने अपना पूरा जीवन चिकित्सा व्यवस्था को देकर के मानव कल्याण के लिए नए मार्ग प्रारंभ करने का काम, नए मार्ग खोजने का काम किया है। मैं आपके अनुभव को आपके किए हुए कार्यों को प्रणाम करता हूं, आपका अभिनंदन करता हूं। भारत सरकार ने आपको पद्मश्री दिया है। समाज में आपने उल्लेखनीय काम किए हैं। वैसे भी हम सब जानते हैं कि जैसे जैसे हम सब प्रगति की ओर आगे बढ़ रहे हैं, नित नई बीमारियां आ रही हैं। कितनी भी एंटीबायोटिक हम ले, लेकिन एक रोज चर्चा सुनने को मिलती है कि एक नई बीमारी हमारे सामने खड़ी हो गई। अभी कोरोना काल से हम उभरे हैं, लेकिन मुझे बताने में प्रसन्नता है कि अपने प्रधानमंत्री माननीय मोदी जी के नेतृत्व में दुनिया के पैमाने पर चर्चा हुई कि हमने कोरोना महामारी से बेहतर ढंग से प्रबंधन करते हुए निपटने का काम किया। चिकित्सीय व्यवस्था में तो हम अव्वल रहे ही, जो अपने आप को डेवलप्ड कंट्री कहते हैं। वहां भी आप देखते होंगे कि हाथ की पर्ची से आपको मिलता था कोरोना। हूं कि आधा दर्जन से अधिक मेडिकल कॉलेजों को पढ़ाई की मान्यता मिली है, पढ़ाई शुरू होने जा रही है। चिकित्सकों की कमी है, सब जानते हैं, लेकिन माननीय प्रधानमंत्री जी की सोच को उत्तर प्रदेश सरकार धरातल पर उतार करके चिकित्सा के क्षेत्र में, चिकित्सा विज्ञान के क्षेत्र में अभूतपूर्व प्रगति की ओर आगे बढ़ रही है। सेप्सिस पर आयोजित इस कार्यशाला में आप सब अपने विचार रखेंगे। मैं डॉक्टर वेद को बहुत बहुत बधाइयां देता हूं, शुभकामनाएं देता हूं। डॉक्टर वेद बहुत क्रियाशील हैं और विपरीत परिस्थितियों में भी इंजेक्शन लगाते रहते हैं। सामाजिक और जो व्यवस्था है ना, कई किसी भी ऑफिस में आप काम करते हो, तो जब आप आगे बढ़ते हो तो कुछ ना कुछ समस्याएं आती हैं। उन समस्याओं से दो रास्ते हैं, या तो हम फ्रस्ट्रेशन में आकर के घर में बैठ जाते हैं, या इंजेक्शन लगाते लगाते आगे बढ़ते रहते हैं। तो डॉक्टर साहब अपनी चिकित्सा विज्ञान का काम अपने ऑफिस में भी लेते हैं, धीरे धीरे इस विभाग को स्थापित किए हैं। मैं आपको बहुत बहुत बधाइयां देता हूं और अपनी सरकार की तरफ से मैं आपको भरोसा दिलाता हूं। अभी डॉक्टर साहब हम लोग साथ बैठे थे, वाइस चांसलर साहब भी बैठे थी। फेफड़े का प्रत्यारोपण अपने यहां नहीं होता है। कोरोना महामारी में हम लोगों ने फेस किया, ढेर सारे मरीजों को हम लोगों ने साउथ भेजने का काम किया, लेकिन वहां सफलता बहुत कम मिली। तो अपने यहां भी ऐसा हो, हम लोगों ने भारत सरकार से संबंध स्थापित किया है। हो सकता है कि आने वाले दिनों में हमें ये सफलता हासिल हो कि उत्तर प्रदेश राज्य में KGMU में ये सुविधा मिले। इस बात के लिए हम लोग दिल्ली से बातचीत कर रहे हैं केंद्र सरकार से। माननीय प्रधानमंत्री जी ने तो परसों ही केंद्रीय कैबिनेट से पास कर दिया कि 70 साल तक के सभी जो हमारे भाई बहन हैं, सबको 5 लाख तक के निःशुल्क इलाज की गारंटी देने का काम करेंगे हम सब। हम केवल जब भी KGMU आते हैं, एक बात जरूर मैं कह के जाता हूं, वाइस चांसलर महोदया बैठी हैं, हमने बहुत सुधार किया है मरीजों की सेवा करने में। ट्रामा में जब कभी शाम को हम आते हैं तो लगता है किसी जुलूस में आए हुए हैं। 5000, 8000, 7000 लोग। OPD हमारी 7000, 8000 की OPD है। पूरे प्रदेश के आशा के केंद्र बिंदु KGMU बनकर के उभरा है। तो हमारे पास अतिरिक्त स्टाफ भी होना चाहिए, अतिरिक्त मैनेजिंग कैपेसिटी भी हमें डेवलप करना चाहिए, और इरिटेशन को हमें दूर रखना होगा। सबकी सेवा करना होगा, मरीज की भगवान मान करके सेवा करना होगा। हम हर स्थिति में आप लोगों के साथ खड़े हैं। मैं कार्यक्रम की सफलता के लिए शुभकामनाएं देता हूं, और KGMU ने तो पूरे देश दुनिया में नाम आगे बढ़ाने का काम किया है। हो सकता है कि सेप्सिस पे भी कुछ यहां से ऐसी बात निकले कि पूरी दुनिया में वो आपका झंडा आगे, सबसे आगे चले, पताका आगे चले। मैं कार्यक्रम की सफलता के लिए शुभकामनाएं देता हूं। अभी राजेंद्र जी की पुस्तक का विमोचन किया हम लोगों ने 2-3 दिन पहले। पुस्तक विमोचन में जाते ही रहते हैं हम लोग, 2-4 दिन में कहीं न कहीं पुस्तक विमोचन। लेकिन ऐसी पुस्तक जिसमें डॉक्टर साहब के साथ डॉक्टर साहब के सारे शिष्य और डॉक्टर साहब के सारे मरीज पूरे प्रदेश से आए थे, और कार्यक्रम भी पुस्तक विमोचन का कोई साधारण कार्यक्रम नहीं था। सामान्यतः सोचते होंगे कि पुस्तक विमोचन के कार्यक्रम के लिए सरकारी कोई हाल मिल जाएगा, ऑडिटोरियम, और दिया जला के पुस्तक विमोचन करके चले जाएंगे। डॉक्टर साहब ने बहुत तगड़ा इंतजाम किया था। 5 स्टार होटल में भोजन भी था साथ में और वो कार्यक्रम कितनी देर चला जानते हैं आप? हम तो घंटा 1.5 घंटे में चले आए, 6-7 घंटा कार्यक्रम चला है।
बड़े सबके भाषण हुए, डॉक्टर साहब के जितने मरीज थे वो लोग भी बोले, और जो डायस पे थे वो तो बोले ही, और डॉक्टर साहब के जो सहपाठी थे, कोलीग थे, साथ में सीनियर्स थे, सब लोग बोले, और मरीज भी अपना बोले जो सीनियर मरीज हैं। डॉक्टर साहब के मरीज बहुत सीनियर हैं, कोई आईपीएस अफसर हैं, कोई रिटायर आईएएस अफसर हैं, कोई साहित्यकार हैं, कोई पत्रकार हैं, सभी लोग आए थे। और डॉक्टर साहब तो हमारे लिए कैपिटल है, हमारी पूंजी है। डॉक्टर साहब ने बहुत कुछ उत्तर प्रदेश को दिया है। मैं बहुत बहुत शुभकामनाएं देता हूं और आप सबका हृदय से आभार प्रकट करता हूं। धन्यवाद।
Thank you, sir, for this enthusiastic and motivating talk. Now I request Professor Ved Prakash, sir, to felicitate our dignitaries with memento. I request him to felicitate our chief guest, Shri Brajesh Pathak ji. Sir, please come forward. I request him to felicitate Professor Digambar Behra, sir. I request our chief guest to felicitate Professor Behra, sir, and Professor S.K. Jindal, sir. Now I request sir to felicitate our organizing chairman, Professor Rajendra Prasad, sir. Now I request sir to felicitate our chief patron, Dr. Sonia Nityanand, ma'am. Please felicitate our special guest, Professor Suryakant, sir. Our scientific chairman, Professor R.K. Singh, sir. Our special guest, Professor Alok Nath, sir. I request our chief guest to kindly felicitate our Professor Ved Prakash, sir. May I request everyone to please stand up for national anthem.
जन गण मन अधिनायक जय हे
भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा। तब शुभ नामे जागे तब शुभ आशीष मांगे। गाए तब जय गाथा जन गण मंगलदायक। जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
lacunae and some errors or thing, because it is multifactorial. So many factors are involved, and that's why no study could come forward that this is the line of the management, in new management of sepsis. And there's a lot of potentials, of course. And as you know, the decreasing the pathophysiology, decreasing harmful capillary leak and edema formation by protecting or restoring endothelial cell function. This reversing sepsis-induced immunosuppression you can do by immunostimulation. This is a major cause, immunosuppression, and then having a second set of infection, which is a cause, and you can reverse. There are a lot of stimulants have been tried in the market. And removal of the harmful medicators from the blood using extracorporeal technique. So my talk will be, although there's so many things, will focus on the agents which prevent the capillary leak, number one. Number two, reversing sepsis by immunostimulation. And third is removal of harmful cytokines and other things. Right? This is the basic, everybody is aware about it. This is a bacteremia, insult, then the trigger, and trigger leads to some sensors, and which came out as the markers, and then there are mediators, and that will impact on the systemic inflammatory response, and there's outcome. It may be a sepsis, it may be septic shock, or ultimately death. Now coming to the first option, that is endothelial cell protection. And there are several potential therapies have been developed that have endothelial cell protective functions, include the basic thing is, one is the vasopressin, second is interferon beta, and third is thrombomodulin. These are the three major drugs where work has been done for it. Vasopressin, patient with septic shock are said to have a relative deficiency of vasopressin, that is published in 1999 by Landis in the Circulation Journal. Exogenous arginine vasopressin, AVP, as adjuvant to therapy has been tried a lot. And AVP with catecholamine reduction in catecholamine, AVP if used along with the catecholamines leads to, there's a study by the Dusner in 2003 in Circulation, they published if vasopressin, arginine vasopressin is used with the catecholamines, there is the reduction in the doses of catecholamines. And this vasopressin, ultimately, Russell et al., they published a data in 2008 that the vasopressin use is better outcome is not shown, again after 5 years. Vasopressin V1A receptors may aggravate vasodilation and which may lead to they confirmed it and lead to fluid accumulation. Other drug of this group is vasopressin group is celipressin, which is shown to reduce vascular leak in the wine model. This is the experimental model, and this is published in 2014 in Critical Care Medicine, and Membar et al. They published it, and they said that celipressin is shown to be a better hemodynamic stabilization, preserve lung and renal function, and reduce cumulative fluid balance and prolong survival. This published in 2016. So celipressin is a better choice for that one. There's again a very large trial of 1800 patients known as celipressin sepsis ACT, and this celipressin evaluation program for sepsis induced shock adaptive clinical trial, which is in the 1800 consists of 1800 patients, and primary and end point of this study was 30 days vasopressure free and mechanical ventilator days free days. And celeprocin is used in one of 4 doses or a placebo. Net result of this trial result of this trial is a good one, and there are some recommendation to use celeprocin in the patients with the pulmonary malnutrition. This is a diagram again. This is infection, endotoxin, PMP, and prolonged induced injury, DMP, immune cell. This is how the immune reaction happens. Immune activation is plasma protein system, cellular defense mechanism active, pro-inflammatory mediators are active. They lead to cellular dysfunction, endothelial dysfunction, and cardiovascular dysfunction. Ultimately lead to multiple organ dysfunction and reduced tissue perfusion, and ultimately coagulopathy, and the patient is dead. Right? Second drug which come in the immunomodulator therapy is interferon beta. As you know, adenosine and extracellular signaling molecule that regulates multiple immunological process, and they thought to play an important role in regulating the host response to sepsis. This was published in the 2001 in Japanese trial. Inhibition of adenosine deaminase was associated with reduced vascular leak and improved survival in septic mice. This was published in 2002. The most promising drug which came in the result in the experimental study and the clinical trial in thermodulin, and sepsis known to be associated with coagulopathy linked to endothelial damage. This published in 2015, and activated protein C, that is APC, is a natural anticoagulant. As you know, APC is effective in some patients, but it's too difficult to define which patient is going to be benefited. Not all the patients will benefit, some may be harmful also. Thermodulin, another natural anticoagulant, but with a different mode of action. And thermodulin is a cell surface protein expressed by endothelial cell, binds thrombin and enhances activation of protein C. And thermodulin again inhibits complement and neutralizes high mobility protein, HMGBI, pro-inflammatory protein, which is the cause of vascular endothelial injury that depress it. They are in trial with the thermodulin, and the trial was in 750 patients with the sepsis with DIC received. And thermodulin we are given is known to reduce. They published in Vincent et al. In 2013 after this trial. The result was shown that the 28 days mortality was reduced after this therapy. In subgroup analysis patient one organ system dysfunction, ultimately they concluded that one organ system dysfunction with INR greater than 1.4 most benefited by thermodulin. There are 3 studies, NCT 0159 is ongoing on this topic. So, there is no clear-cut recommendation, or it is just all suggested on the trial. Other experimental agent which is having a immunostimulatory effect is FX06 is natural product of fibrin interaction with the VE, can involve endothelial integrity. Second is FX06, they reduces vascular leak and mortality in mouse. This is all experimental drugs. Other potential targets for endothelial protection includes angiopoietin, sphingosine, 1-phosphate, and receptors and slit ROBO pathway. Sepsis, again, sepsis patients often exhibit concurrent hyperinflammation and immune suppression, resulting in variable effect clinical outcome, including persistent inflammation, immunosuppression, and catabolic syndrome in critically ill patient. The pro-inflammatory phase in sepsis, that is hyperinflammatory response, often you call it cytokine storm, is characterized by intense systemic release of cytokines and other inflammatory mediators, leading to tissue damage and organ dysfunction. This phase aligns with the concept of SIRS, systemic inflammatory response syndrome, but also acknowledging the potential harm of the unchecked inflammatory responses. Neutrophils play a vital role in this phase, contributing to hyperinflammation through the release of proteases and reactive oxygen species and forming neutrophil extracellular traps and nets. While nets are essential for antibacterial defense, excessive netosis can lead to tissue damage, thrombosis, and organ failure. This is again describing the hyperinflammatory response, and there is hypoinflammatory response in the lower down. That upper is the innovative, and this is adaptive, where the patient is going up, and this happens until this time. Immunostimulation, again, the other group is granulocyte colony stimulating factor, GCSF, and granulocyte macrophage colony stimulating factors. These all are the clinical trials, mainly the experimental and some clinical trials, and may give a good result. Some trials give good result, some is a failure. Interferon gamma, IFN gamma, cytokines secreted predominantly by T cell, helper cell, and cellular kills and play a key role in mounting an efficient response against pathogens. Third in immunostimulation therapy is interleukin 7 and interleukin 15, and this other cytokines which are again under trial. There is no definite report for these drugs. Prolonged cell death 1 and programmed death ligand 1, and this PD1 and negative molecules and its ligand programmed death ligand and other potential target because they are negative regulatory to response. Coming to the non-pharmacological method, I think in the morning Dr. Professor Narayan Prasad must have discussed the blood purification system. This is after that. And this is one of the methods, renal replacement theory. As you know, replacement theory is designed to remove uremic toxin, but since the late 1980s, it has been suggested that it could be also used to remove circulatory mediators of sepsis. In 1993, it was the assumption. There was time. And there was first pilot study was published in 2002 by Cole, and they studied 24 patients with early septic shock of continuous venous hemodialysis at 2 liters per hour and lead to no change in mortality, nothing that it. And then comes a second trial, is a multi-center trial comparing high volume, 70 ml per kg per hour, and there is again no change in the mortality. There is no definite report for it. There are so many blood purification systems available in the market now. This is again the high volume therapy. There's increased filter prosperity, Septex Gambro, additional system which is known as CPFA, coupled plasma filtration system, and endotoxin removal targeted is the polymyxin B, emulized fiber, albumin binding, and the oxidase system Gambro again is the market, and there is high volume CRRT and immunotherapy. Non-pharmacological means again the blood purification, hemoperfusion, Cytosarm is the one such device composed of porous polymer beads. When placed in the hemodialysis circuit, removes molecule in the range of 5 to 60 kilo delta, which includes most cytokines and inflammatory mediators. Series, which was published in 2017 in Critical Care, show promising results on hemostabilization. Promising results. There's another drug, which is polymyxin B, which binds and neutralizes endotoxin. In a pilot study by Vincent again in 2005, which was published in the Shock, and the pilot says a study of sepsis secondary to intra-abdominal infection treated with polymyxin cartridges along with the CRT improve hemodynamics and reduces the duration of CRT. This was published in 2005. This is one of the positive study by other study which come with the blood purification system is UFAS. This is early use of polymyxin B hemoperfusion in abdominal sepsis, which also give a very, very promising result and was published by Hughes in 2009 in JAMA. And Euphrates, another study in this series, Euphrates evaluating the use of polymyxin B hemoperfusion in randomized controlled trial of adult treated for endotoxemia and septic shock, and this again failed to show any survival benefit. CPFA, coupled plasma filtration absorption, there are 4 meta-analyses going on, and it claim that there is a reduction in the mortality in these patients. Although, again, to conclude, for non-pharmacological options, although no recommendation can currently be given regarding blood purification technique in the patient with sepsis because of the poor quality and conflicting evidence available, some system may be effective in some patients, and the result of the ongoing study should help identify who can benefit from this approach. To summarize the talk, identification of the accurate biomarkers to better select appropriate phenotypes is essential to evaluate new drug candidates for the adjuvant treatment of sepsis. More than 10 promising drugs are currently in the clinical development in the sepsis field. In the is under trial. Immune response is probably one of the most appropriate target to work on later on, and several drugs, including monoclonal antibiotics, are likely to be marketed in the near future. Clinicians have increasingly realized that not all the patients with sepsis are the same, and no single intervention will work in all the patients with sepsis. Sepsis need to be adapted to individual patient depending on the immune status and associated organ dysfunction at the time of intervention. Thank you.
Thank you, Professor Dr. Dept for lucid talk on emerging therapies in sepsis. Now, topic is open for discussion. Any questions, please?
Hello. Sir, very exhaustive talk. Sir, here.
Huh?
Ajay. Sir, among the blood purification systems.
Yes, sir.
I would like to ask, what are the...
Sir, mic, please. Mic on.
Hello. Mic in on, sir.
Huh.
So, among all the blood purification systems, are there any chances that in sepsis we are doing blood purification? On one side it is removing toxins, on the other side it is removing the beneficial molecules like immunoglobulins or others?
Actually, the blood purification system, the trial for the hypothesis for to use the blood purification system is if you can remove the toxin somewhere, and especially the cytokine storm, then the blunt of the sepsis will fall, will decrease. Again, the target organ will be saved somewhere. But ultimately, they are not successful, not promising results are available, except in the patient with the polymyxin B cartridges along with the CRRT in the intra-abdominal infection. There are some promising results. But there is no clear-cut guidelines, no recommendation that can be used. There are so many in the market, cytosab in the market, there are so many cartridges are available.
Right, sir. One more question, sir. Nowhere I could find a mention of plasma exchange. Can plasma exchange has plasma exchange been tried in sepsis?
Yes. Still, again, there is no clear-cut recommendation. Is an trial. Even the stem cell is a trial for sepsis. Everybody wants some modality. Basic still after 30 years even for working lot of sepsis, we are again basically blunt on the antibiotics and the supporting system. Then no different way.
So
that's unfortunate.
So again, no clear-cut guidelines.
No clear-cut.
Thank you so much, sir.
Any more question? Thank you, sir. Now we are closing the session.
Thank you, sir, for wonderful session. And I now request Professor Vishwajit sir and Professor SNS Yadav sir to come on stage and felicitate our speaker and chairperson. Please felicitate our speaker, Dr. Deepak Malviya sir. Dr. Nikhil Gupta sir. Dr. Anand Gupta sir. Dr. D.K. Verma sir. Moving ahead towards our next session on sepsis in immunocompromised patients, I would like to invite the chairpersons on stage, Dr. SNS Yadav sir, Senior Consultant Chest Physician, Balrampur Hospital, Dr. Armin Ahmed ma'am, Additional Professor, Department of CCM, KGMU, Dr. Amit Kumar sir, Assistant Professor, Department of Medicine, KGMU, Dr. Sachin Kumar sir, Assistant Professor, Department of Pulmonary and Critical Care Medicine, KGMU. Dr. Satish Kumar sir, Assistant Professor, Department of Medicine, KGMU. Okay, welcome chairpersons. I now request you to introduce the speaker for this session.
Thank you, sir. Thanks a lot, sir. Thank you, everyone, and thank you, Dr. Sachin and Dr. Ved, for calling me here. Yeah, please. So I have been given this topic, sepsis and immunocompromised individuals, which, if you look at it, encompasses a lot of diseases. It could vary from HIV to oncological diseases to even chemotherapy and new fields like the transplant patients. So when we talk about sepsis, we all think that all immunocompromised patients are equal, but they are not. That's what I'll try to explain, and maybe rather than just the treatment, I'll try to explain why we need to understand what we are treating. So the scope is basically to make you understand what sort of immunocompromised state are you really dealing with. And then you can actually start understanding what are the different types of infections which you expect and the sepsis that they would be causing. And once you know that, you will be able to understand what antibiotics, antivirals or antifungals that you need to select to actually counter them. So when we, So when we talk about immunodeficiency, you can have a secondary as well as primary cause of immunodeficiencies. And in secondary, we have HIV, and then we also have malignancies, nutritional deficiencies, chemotherapy, radiation injury, transplant patients, and even if you look at it, CLDs and CRF patients, with time they're all immunocompromised. It's not that their immunity is very good, so they all tend to be immunocompromised at some level or the other. The primary immunodeficiency, in most ICUs we tend to see less, so I'm not going to discuss much about it because this is a totally different paradigm. The disease process, the type of organisms that you see are totally different. I'll stick to the secondary immunodeficiencies, that is the acquired, which are more common and which is what you see day to day in your clinical practices. Most commonly what we see is the cancer patients, the chemotherapy and patients with HIV. When we talk about immunosuppression as such per se, you have to remember that there are three arms of immunity which are actually acting at one time: the B cell, the T cell and the innate immunity. You have to understand it in most of the diseases, it doesn't happen that all the three are actually blocked, except in certain cases. One of the best example is a drug, steroids. Steroids are one of those drugs which block all the three at one time. Therefore, the risk and the sepsis that you see in steroid, you can see any organism. But when you look at, suppose I'll give you an example of HIV per se. In HIV, basically the blockage is at the T cell level. That is why when you test for HIV, you test for the antibodies. Even when the CD4 is nearly 10, you will still have the antibodies coming because the B cells are still activated and they are functioning. When you look at the other way around in patients of chemotherapy or patients of transplant, post chemotherapy, the first thing that happens is that T cell immunity starts actually falling. Initially, they will have a neutropenia, and after that, the T cell immunity starts going down, specifically when you're trying to suppress with tacrolimus and all. So once you understand which arm is suppressed, then you'll understand what sort of diseases you expect in these sort of patients. The B cell immunity, when it is suppressed, you would see more of pyogenic bacterial infections and enteric bacterial infections. And that's what you will see. Most of the patients of cancer patients or leukemia patients, what you would see is they are getting recurrent infections, sepsis from gram-negative bacteria and all. You can also have viral infections like herpes is very common when your B cell immunity is actually lowered. When we look at the T cell immunity, you will see that the organism spectra changes. Majority of them are those which are intracellular microbial agents, like pneumocystis, like you will see also cryptococcal, pneumococcal infections might come into picture, and then you can have the viruses like CMV and EBV here. I would like to also tell you one thing, that even the viruses change as per the sort of immunity which is suppressed. The best example is CMV. We have been taught CMV retinitis is very common, but you will see that in a patient of transplant or patient on chemotherapy, you will hardly ever see CMV retinitis, but you will see basically more of CMV hepatitis or CMV enteritis, and along with sometimes you might even get CMV pneumonitis. But when you look at HIV per se, you will hardly ever see them having CMV enteritis. Majority will have either esophagitis, but CMV retinitis becomes very common. So this area also changes with the type of immunity which is suppressed. The mechanisms, of course, there are lots of mechanisms which we have already discussed. I'm not going too much into this thing. in HIV, you have CD4 cells which are suppressed. In radiation, the bone marrow is totally suppressed. The tendency is that you will get a lot of neutropenias. In immunosuppressive drugs, you tend to basically suppress the T cell. When you want to suppress the graft versus host, you are actually suppressing the T cell based, the T cell lines, so that the organ can be actually suitably taken by the body. In asplenia, you tend to have actually a hypogammaglobulinemia, which actually decreases all the sort of infections which are related to the B cell mediated immunity. So this is a slide which gives you an idea what sort of infections do you expect, and the sort of infections which are commonly seen in immunocompromised patients. You know pretty well that in bacterial, the biggest and most important still in this country is TB. As a matter of fact, even in West, TB started again coming back when HIV started coming in. And with the control of HIV, again they were able to control TB. Staph and strepto are pretty common, and Haemophilus influenza also becomes important, specifically in the asplenic patients. Intestinal organisms are also pretty commonly seen. MAC is something that you see more in HIV patients. But important factor is those which are not expected, that is the fungal infections. The fungal infections become very common in the immunocompromised patients, and your tendency is that you want to give a prophylaxis to stop that. One line that I would state, which is always taught in immunocompromised, remember what is common in the general population is always common in even in immunocompromised. ऐसा नहीं कि बाहर अगर हमारे पास अगर डेंगू का एपिडेमिक चल रहा है या आपका मलेरिया चल रहा है तो पेशेंट को इम्यूनोकॉम्प्रोमाइज को नहीं होगा. द इम्यूनोकॉम्प्रोमाइज अगर आपके वार्ड में भर्ती हो रहा है, you still have to think that this patient could have had this infection itself. The only difference is those which are not common in general population, things like histoplasmas, things like cryptococcus, they will be seen much more commonly in these group of patients. Well, when we talk about immunocompromise, without doubt we have to talk about HIV, and this you all know that the CD4 counts when they go below 200, then we start seeing all sorts of OIs, and the death in HIV patient is 95% of the times because of the OI rather than the HIV per se. The important infections we all know are PCP, CMVs which come to light, but in India still the most important infection is TB, and you have to remember in HIV the TB is totally different from what you would see in a normal person. One, you will never have upper zone lung involvement even if it enters. It will always be in the lower zones because this is a re-entry, this is a new entry TB, not reactivation TB. Secondly, it is always possibacillary, so even if you send an AFB, most of the times it will be negative. Third, the third important thing is you will get more of extrapulmonary. The spread out will be much more. So even if you start ATT, many of the times these patients will start actually deteriorating. They'll start developing multi-organ failures because there will be a severe iris, that is immune reconstitution, and the patient might actually land up in a much worse state as compared to what he came initially. So TB in HIV is a totally different subject, but I will just try to point out it looks very much like pneumonia, and if you are getting multi-organ failure along with lower zone, it can still be TB if it is HIV. So you have to keep that in mind. These are the different organisms that we see in India as a spectra wise. This just gives you an idea what sort of infection that you would be expecting here. See, that's what I wanted to point out. The CMV, when we talk about, for a gastromedicine people, it will be always about liver. But in HIV, it doesn't. It doesn't involve liver that commonly. So it is basically CMV retinitis because here it is a reactivation of a virus which is sitting there specifically once the immunity starts reconstituting. This is a graph I think most of us have seen from our MBBS days. This hasn't changed over the period of time. And one thing that actually has to be also emphasized, that when we keep on thinking about sepsis, we have to also remember in HIV, it could be because of the reactivation and changes of the viruses which actually modulate, and you can activate even certain malignancies like Kaposis and lymphomas. The good thing is Kaposis is rare in our country, but lymphomas are seen every now and then. Specifically, you can get CNS lymphomas also. When we talk about malignancies, then there are again two things that you have to remember. A malignant patient who is on chemotherapy, a malignant patient who is not on chemotherapy. When you give chemotherapy, without doubt, you must have all seen that after first 7 days, there will be severe marrow suppression. And then there will be severe marrow reactivation and an iris. But this reactivated marrow is not a normal reactivation. There will be still abnormal cells. So they tend to go into HLH and all sorts of problems. And you will actually see more of cytokine storms in these sort of patients. But when you give chemotherapy, the first thing that happens is you will have severe neutropenias and the patient will land up into febrile neutropenias. So nowadays you have most oncologists, what they will do is along with the chemotherapy they tend to give GM-CSF also, or they make it a habit to give GM-CSF every twice weekly, at least in the first 2 weeks. This is just to avoid the neutropenia. But the neutropenia is something that you have to keep in mind, and neutropenia, what it does is there will be a lot of different infections which can occur. The first one is, like you can have with neutropenia, is extracellular gram-positive and gram-negative bacteria and fungi. In other diseases like CLL, with the base cancer itself can cause certain immune dysregulations. Like for multiple myelomas, CLLs and other hematological malignancies, you tend to have hypergammaglobulinemias, where you will have more of the capsulated bacteria like H. influenzae, pneumococcus and meningitis. In Hodgkin's, you have abnormal T cells, and this is where you will start seeing cryptococcus and Mycobacterium tuberculosis. एक सिंपल से याद रखिएगा, अगर आपके पास एक टीबी पेशेंट आया जिसके में पूरे बॉडी में लिम्फ नोड्स हैं एंड यू मेक अ डायग्नोसिस ऑफ टीबी, be careful about it. Most of the times this might be a Hodgkin's or a non-Hodgkin's lymphoma overridden with TB because they are very prone for it. आपने 6 हफ्ते की टीबी की ट्रीटमेंट के बाद देन वो अनकवर होने लगता है. If you are still having lymph nodes, better recheck it because that is when you will unmask the underlying devil which is actually leading to TB in there. Otherwise TB इतना जल्दी किसी immune competent person में इस ग्रुप में lymph nodes में नहीं आता है. It sticks to contiguous lymph nodes. So this is something that you should remember. In colorectal and all, here the immunity that is decreased is the local immunity, gut immunity. So यहाँ पे क्या होगा? You'll all sorts of gram-negative bacteria which are present in intestines which will leak into the blood and they'll cause all sorts of infections. You will see sometimes even some things like Clostridia entering into the bloodstreams and causing, gas bubbled abscess also all over in the abdomen. That's also is seen when you have colorectal cancers. I still remember one case when I saw this patient had growing Clostridium sordeli in the blood. We just couldn't understand why a young male is having Clostridium sordeli. So then we thought, let us just for the sake of it do a colonoscopy. And the moment they put a scope, there was a rectal mass there. So basically the rectal mass was breaking the layer and there was a decreased immunity and all the organisms from the intestines were leaking into the blood. So that is what you have to remember in these sort of situations. So this is what we have in granulocytopenia patients. This is something that you should remember. So what we do is we cover antibiotics accordingly. So we also use that when you have a falling neutropenia, we use the protocol as prophylaxis also. The first one is you try to cover for the gram-positives and enterococcus. And the antibiotic which is good for this is piperacillin tazobactam. Remember ampicillin, then you do not, the penicillin groups, the first generation, the third generation, and then vancomycin covered enterococcus. Meropenems do not, they cover only in vitro, they do not cover in vivo. So that is why if you look at most of the febrile neutropenia cases, the guidelines suggest piperacillin tazobactam, which also gives you an additional benefit that it covers for gram negatives, plus you also tend to add an amikacin where you want to cover for pseudomonas, and then you want to cover for the fungi. So you will say where the patient is poor, people tend to use fluconazole as a prophylactic drug, and where the patient is actually affordable, then they tend to use posaconazole because posa covers all the three. ITRA can also cover all the three. That is something you have to remember. And for treatment modalities, as per FDA guidelines, it is isavuconazole or amphotericin only. POSA is not actually till date approved for treatment, though we use them because of the cost difference which is there between POSA versus isavuconazole. So that was a bit about how you try to treat a febrile neutropenic patient. Similarly, in CNS infections, you tend to again have a look at it and you try to cover for aspergillus and cryptococcal. Now, one simple straightforward rule that you have to remember, each fungi, the major fungi has one antifungal which is important for it. For example, the best antifungal for Candida is echinocandins, best antifungal for aspergillosis is voriconazole, and the best antifungal for mucor is amphotericin along with isavuconazole. But if you want one antifungal which covers blanket everything, then you will find that it is only amphotericin which has coverage for most of them. There are certain species which it does leave out, but otherwise it covers all. And specifically in an immunocompromised patient where you are suspecting cryptococcal possibility is also there, then LAM gives you the best outcome, because when you have no idea, it has a blanket coverage against all of these fungi. So pneumonias as such can also be very difficult. I'm not going much into it, but I think we have had a lot of discussions. But BAL becomes very useful in these sort of scenarios where it gives you a very good idea about what sort of organism it is growing. Plus you can do a BAL galactomannan which has nearly 90 to 95% sensitivity as compared to serum galactomannan. And the nodularities and the pictures which you can use in the imaging can also help. For example, if you have a localized or a lobar sort of imaging, the tendency is that it would be more of bacteria including Legionellas. Nodular is usually fungi. Diffuse would rather be viruses. But I'm telling you this is not hard and fast. You can have nodularities or sometimes cotton wool shadows with even Klebsiella and staph. Similarly, you can have a Legionella which can have a diffuse like a viral. The pictures would change in between. In a transplant patient, as we said, again there is something, what do you do in a transplant patient? Specifically in any transplant patient, why are you doing a transplant? Suppose you have a bone marrow transplant, the first thing that you would do is you hit with chemotherapy, kill out all the cells which are there. Once the marrow is dry, then you would actually do a transplant. So that is the first stage, which is a primary stage, where you tend to have lot of neutropenia and neutropenic infections. And the second phase, where you actually transplant and put them on tacrolimus, there you will have lot of T-cell based infections. In them, first week you have to treat like granulocytopenia, and the rest all you will have to treat them taking into consideration that there is T-cell immunosuppression. So these are the infections you see. In the first 30 days, this neutropenic phase can last from 9 days to approximately, let's say like this, 1 week to 1 month. And beyond 1 month, you tend to have more of T-cell based immunity, which is decreased. In between, you should also remember there can be a graft versus host rejection, which can also mimic a sepsis, and that has to be differentiated from one disease, that is CMV. So आपको जो treatment करना है उसमें basically what I do is, here in the first group you use the same protocol that you use for febrile neutropenia, and here in the second group you have to actually use prophylaxis or treatments where you have to consider CMV and adenovirus and aspergillosis. So you can understand in the first group your drug of choice becomes more of, if you have a sepsis, you use echinocandins, you use acyclovir, and you use one strong gram positive plus gram negative, that is something like piperacillin tazobactam with maybe a vancomycin. And you might also add to it, once the T-cell immunity starts decreasing, you might change over to voriconazole, maybe ganciclovir, and then finally you might add a cotrimoxazole, because this is where you will start seeing PCP pneumonias actually start occurring in these patients. So this is what you have to remember. So this is a basic table about how you treat the different major organisms which cause sepsis in immunocompromised states. How do you make a diagnosis? Well, cultures. There is no second option beyond that. Even whatever we might say, you have to remember that blood cultures have to go, urine cultures have to go. You have to do imaging, you have to do all the biochemistries. You can use the biological markers. एक ही बड़ा अच्छा है कि प्रोकैल्सिटोनिन नहीं है तो बैक्टीरियल सेप्सिस नहीं है ना, ऐसा नहीं होता, because प्रोकैल्सिटोनिन is only good for gram negative bacteria. That is where it is very sensitive. That means अगर हमारे सुमित उंटा साहब GI में अगर निकालेंगे तो ये पॉजिटिव आएगा, but osteomyelitis में it will not come positive. So remember this thing very clearly. I mean, I'm Dr. Sumit Unta इसलिए because he's our GI master. Okay, and then galactomannan इसलिए because you have aspergillosis, but then you have piperacillin tazobactams and all, which will give you cross positivities. Equally, their sensitivity is not always same. Beta D glucan is a pan fungal marker, so it will show you everything. Like if you have candida or anything, if you are not so sure, you can do this, but you have to remember this costs very it costs nearly 40,000 right now in India. PCRs, you should do CMV, HSV and varicella zoster. But the CMV PCR, you have to remember, ऐसा नहीं कि हर CMV PCR को आप treat करोगे या हर IgM CMV को treat करोगे, because the ganciclovir is very toxic. What you should be doing is CMV करने के बाद you have to see the log values. If it is more than log 2, then, and it is actually matching with a clinical picture, then you start ganciclovir, because you have to give for at least 2 weeks. First week में ज़्यादातर आप treatment के बाद CMV load goes up because the cell, it comes out of the cell. It is on the second week it usually gets suppressed. So you have to actually treat for 2 weeks, and the risk for marrow suppression is huge when you treat with ganciclovir. So जब patients हमारे KGMC में आते हैं, where they are poor patients, all these markers may not be useful, then the very simple marker of CRP still remains very useful, where you can use it. As it goes down, you can have an idea that the infection is going down. एक चीज और that I would just point out for all of you, the procalcitonin in oncological patients जहाँ पे GM-CSF लगा रहे हैं, जैसे GM-CSF लगता है ये procalcitonin positive हो जाता है. So please ऐसा भी मत सोचिए कि हर procalcitonin positive भी infection है. So that is where you have to keep your eyes and mind open. So and transplant के लिए I think Dr. Vishwit sir यहाँ पे हैं. I see the whole urology department here. For you all, the BK virus becomes very important. You have to check that whenever you're thinking of immunocompromised state, specifically when you're bringing the kidney nearer to the bladder. This is something virus which starts infecting very commonly. Conclusion is, you have to keep your minds open. Sepsis in immunocompromised state is not one single cause, and you have to understand what sort of immunosuppression is occurring. Then only you can think of the sepsis. Thank you.
Thank you so much, sir, for such a nice talk. It is my privilege to have chaired the session for my own teacher. Himanshu sir used to be my teacher at the time of my MD and also my teacher's guide. It is an honor to chair the session, sir. Is there any question in the audience? So we announce the session closed. Thank you.
Thank you.
Thank you, sir. It was a wonderful session. I would now request Professor Vishwajit sir and Professor Apul Goyal sir to please come on to stage to felicitate our chairperson and guest speaker. Professor D. Himanshu sir. Dr. S.N.S. Yadav sir. Dr. Armeen ma'am. Dr. Amit Kumar. Dr. Sachin Kumar. Dr. Amit Kumar. Now we move on to our next session. For our next session, I request our chairpersons to please come onto the stage. Dr. Ajay Kumar sir, Professor of Medicine and Gastroenterologist, KGMU. Dr. Anil Gangwar, Consultant Gastroenterologist, Vivekanand Hospital. Dr. Preetam Das, Assistant Professor, Gastroenterology, KGMU. Dr. Devendra Yadav, Assistant Professor, Pulmonary Medicine, Mahamana Pandit Madan Mohan Malviya Cancer Center and Tata Cancer, Varanasi. I request the chairpersons to please introduce our next speaker and move on with the session.
Hello. Hello.
Good evening, everyone. I am glad to invite Professor Sumit Rungta sir, Head of Department Gastroenterology, KGMU. Warm welcome, sir. Sir will discuss about the hepatic dysfunction in sepsis. Over to you, sir. Thank you.
Good afternoon, everyone. I would like to thank Professor Ved Prakash sir and team PCCM department for giving me this opportunity. Today's my topic is hepatic dysfunction in sepsis. Hepatic failure is frequently seen type of organ failure in critically ill patients. Liver injury and failure contribute to dramatically increased morbidity and mortality. Liver injury in critical illness may be divided into two groups: primary hepatic dysfunctions like acute liver failure and acute on chronic liver failure. Secondary hepatic dysfunctions are the most frequent form of hepatic injury in critical illness. Today's my talk is limited to secondary hepatic dysfunction in patient of sepsis. Liver phenotype changes from tolerogenic to immunogenic profile to the gut microbiota during the sepsis. It provides site for bacterial clearance, site for nucleosis. It provides defense against intracellular microbes. It produces lots of acute phase reactant that help in clearance of the viruses and bacteria. It is important for hepcidin metabolism and important for liver mediated immunosuppression. This is seen in diagram that when bacteria and lipopolysaccharide comes in sinusoid by breaching the intestinal barrier, and due to ischemia of hepatocyte and cholangiocyte leads to activation of DAMP that leads to activation of Kupffer cell and stellate cells in the liver that form interleukin 1 beta, interleukin 6 and TNF alpha. These cytokine storm activate hepatocyte and recruit neutrophils and monocyte that changes the hemostatic liver into the immunogenic profile of the liver. During the sepsis, nearly about 30 acute phase proteins were produced like C-reactive protein, complements, hepcidin, ferritin, etc. and interleukin 1 and 6 plays the central role in its production. Some proteins required for homeostasis, metabolism and transport decreases their production occurs in the sepsis. Like these are called negative acute phase reactants. These are examples are albumin, transferrin and transthyretin, etc.
Clinical patterns of liver injury in sepsis are cholestatic type of liver injury, drug-induced liver injury, hypoxic liver injury, sclerosing cholangitis in critical illness, and parenteral nutrition-induced hepatotoxicity. First, I will cover cholestatic type of dysfunction in critical illness. This is the most common type of liver dysfunction in critical illness. It is characterized by impaired bile formation and bile acid excretion. Currently, no uniform definition of cholestasis in critically ill patient. Usually, bilirubin, serum bilirubin more than 2 or alkaline phosphatase and GGT more than 3 times upper limit of normal is considered as cholestatic pattern of the liver injury during the sepsis. Nearly about 11 to 33%, which is different in different studies, like median value is about 20% patient develops cholestasis during their ICU stay. Cholestatic alteration more frequently found in septic shock in comparison to cardiogenic shock. The passage of bile salt into biliary caniculus is rate limiting step in bile formation, which is ATP dependent. Conjugated bile salt are excreted into bile through bile export pump, bile salt export pump. The mechanism of cholestasis in sepsis may be due to decreased basolateral transport of bile acid or due to decreased canalicular transport of bile acid. The clinical association of cholestasis and inflammation is very well known. Infection with gram-negative bacteria, malperfusion, retention of toxic molecule contribute to cholestasis in critical illness. Collectively, impaired hepatobiliary transport and bile acid signaling contributes to cholestasis. Clinically, inflammation-associated cholestasis occurs in context of intra-abdominal and extra-abdominal infection, sepsis and septic shock. The risk factor for cholestasis are pre-existing liver disease, shock, severe respiratory insufficiency, renal failure, and total parenteral nutrition. It is shown vasopressor, decreased bile flow, and excretion of bile acid possibly through intercellular increase of calcium in hepatocytes. It is diagnosed by increased total serum bilirubin more than 2, alkaline phosphatase, GGT more than 3 times upper limit of the normal for the cholestatic pattern. Alkaline phosphatase and GGT sensitive markers but non-specific indicators of cholestasis. Total bile acid potentially represent a feasible biomarker for severity of liver disease. It predicts short-term mortality independent of serum bilirubin and severity of underlying disease. This is the algorithm which shows how to diagnose cholestatic liver injury in the sepsis. If a patient presents with serum bilirubin more than 2 times and increased alkaline phosphatase and GGT with near normal SGPT and SGOT, then we advise ultrasound in these patients. When ultrasound doesn't show any biliary dilatation, then when ultrasound showed biliary duct is dilated, then diagnosis of obstructive jaundice is made. Obstructive jaundice is caused usually by gallstones, cholelithiasis and malignant causes of the biliary obstruction. If biliary ducts are not dilated, then sepsis-induced cholestasis could be considered, and non-obstructive causes like infection, sepsis, drug-induced liver injury and TPN should be considered. If suspicion is very high about the obstructive jaundice, then we can advise MRCP or CT scan to rule out obstructive pathology. Cholestatic dysfunction in critically ill patient is associated more than 2-fold increase in mortality rate. Patient with serum bilirubin between 2 to 3 had nearly about 27% hospital mortality rate. Serum bilirubin between 6 to 10 has about 38% mortality rate, and if serum bilirubin is more than 10, mortality rate is about 48% in one study. There is no established targeted treatment of cholestatic of critically ill patient. Current guidelines recommend hemodynamic stabilization, optimizing perfusion and adequate treatment of infections. Glucose control, particularly intensive insulin therapy, reduces the rate of cholestatic dysfunction and biliary sludge in critically ill patient. Early enteral nutrition is generally recommended as standard of care in critical illness. Contraindication of enteral nutrition are uncontrolled shock, severe acidosis, increased gastric residual volume, abdominal obstruction, and abdominal compartment syndrome. A pilot study showed biochemical improvement in critically ill patient receiving high dose of UDCA, although it does not affect outcome. Nor UDCA is a novel side chain short derivative of UDCA. Clinical evidence pertain primarily to sclerosing cholangitis but not to critical illness. So RCT is needed to have definitive role of UDCA or nor UDCA in critically ill patient. Advanced extracorporeal system such as albumin dialysis are able to remove albumin bound substance like bile acid and water soluble substances. Albumin dialysis devices improve hepatic encephalopathy. Systemic hemodynamics significantly reduce bile acid, although they did not demonstrate improved survival. So it is proven in this slide, it is shown in this slide, if a patient have sepsis-induced cholestasis, there is no definitive role of any therapy. Only perfusion and treatment of sepsis have role to treat the cholestasis which is occurred due to sepsis. The problem is in every institute and every hospital. If a patient come to ICU having deranged liver function test, then it is told that get a reference from gastroenterologist or hepatologist to treat this condition. But it is shown in various studies the role primarily of treating infection and controlling blood sugar, enteral nutrition, hemodynamic stability is the only factor that can treat jaundice and all organ dysfunction which occurred due to sepsis. Second cause is drug-induced liver injury in critical illness. Data on the incidence of drug-induced liver injury in ICU setting are lacking. Many drugs are potentially capable of causing drug-induced liver injury. One of the most common drug is acetaminophen in the ICU setting. Typical and more frequent causes of elevated liver function parameter should be excluded like cholestatic liver diseases and hypoxic liver injury. Drug can cause cellular injury or cholestatic pattern or mixed pattern. Cellular patterns means more increase of ALT and AST in comparison to alkaline phosphatase. Drugs, those causes cellular injury like acetaminophen and anti-tubercular drug. Some common drugs used in ICU that can cause cholestatic pattern of liver injury are amoxiclav and anabolic steroids. Mixed pattern of liver injury can be caused by anti-epileptic drugs like carbamazepine, phenobarbital, and phenytoin. For the drug-induced liver injury, therapeutic options are limited. Withdrawal of the suspected causal agent is the unmet importance. Acetaminophen-induced ALF and acetylcysteine is the antidote of choice. Current guidelines on DILI suggest that NAC may be considered at early stage of non-acetaminophen-induced DILI in adults only. No prospective control trial evaluated benefit and risk of corticosteroids in DILI. Some are using corticosteroids in DILI patients in ICU setting, in the ward setting also. But prospective control trial not evaluated about the efficacy of corticosteroid in drug-induced liver injury. Current guidelines do not recommend routine use of corticosteroid in critically ill patient with DILI other than DRESS syndrome. Next pattern of liver injury in ICU setting is hypoxic liver injury. Hypoxic liver injury, also known as ischemic hepatitis or shock liver. It is characterized by massive rapid rise in serum aminotransferases resulting from reduced oxygen delivery to the liver. Massive means SGOT-PT or ALT-AST comes to 2000, 3000, 4000. HH has become increasingly recognized in ICU. The prevalence of HLI ranges between 1 to 12% in ICU setting. Up to 20% of patient is having cardiogenic shock. Risk factors are cardiac failure, sepsis, respiratory failure, and other hypovolemic shock, anemia, extensive burn, and sleep apnea. More than one underlying risk factor present in nearly about 75% of the patient. Documenting hypotensive event and shock present in only 50% of the cases. Decreased hepatic blood flow in shock does not always cause hypoxic injury. It may occur in patients with normal blood pressure. Many patients who develop HLI suffers from chronic disease like cardiomyopathy, COPD and cirrhosis. Typical histopathological pattern is ischemic hepatitis is centrilobular liver cell necrosis. EASL included HLI as the main cause of secondary ALF in clinical practical guidelines on the management of ALF. Pathophysiology of HLI. As we know, the hepatic blood flow is about 20% of the total cardiac output. Liver has dual blood supply, nearly about 70 to 80% blood supplied by the portal vein and 20 to 25% of the blood supplied by hepatic artery. In setting where hepatic portal venous blood flow decreases, hepatic artery have adaptive mechanism to adjust for this decreased blood supply. This adaptive mechanism relies primarily on the adenosine. An increase in hepatic artery blood flow is able to cover 25 to 60% of the decreased total blood flow. Hepatic oxygen extraction is also increased when supply decreases to the liver. HLI seem to be consequence of unmet increase in hepatic oxygen demand and reduce hepatic ability to utilize oxygen. In addition to direct hepatic injury, when shock improves, liver cell necrosis may be aggravated by reperfusion injury. It is done by activation of Kupffer cell, late activation of polymorphonuclear cells, and disruption of hepatic microcirculation and oxidative stress. In reperfusion injury, in liver biopsy, we get mid-zonal necrosis. In clinically, HLI patient usually is of advanced age. More than 80% patient develop HLI within 24 hours of ICU admission. Patient usually have pain abdomen and hepatomegaly, may have altered mental status. 70 to 80% of the patient require mechanical ventilation. AKI present in about 80% of the cases, and up to 40% patient required renal replacement therapy. Spontaneous hypoglycemia seen in 10% of the patients. It is diagnosed by increased aminotransferase level is as the marker of hepatocellular injury. Raised in the clinical setting of acute cardiocirculatory, respiratory and hemodynamic injury are the diagnostic cornerstone of HLI. Aminotransferase level rise within hours of the shock, and it gradually decreases when shocks improve. AST level improve first, followed by ALT level. ALT LDH ratio less than 1.5 is more typical of ischemic hepatitis than viral hepatitis. So, in the clinical setting of cardiac, circulatory and respiratory failure, dramatic but transient rise in serum aminotransferase activity with exclusion of other causes of liver cell necrosis makes the diagnosis of ischemic hepatitis. This is the algorithm. When AST, ALT raises 20 times above limit of the normal, exclude the viral and toxic causes, and if patient is having cardiogenic, circulatory or respiratory failure, then diagnosis of hypoxic liver or ischemic hepatitis is made. USG abdomen shows dilated hepatic vein following congestion. Most important imaging technique in patient with HLI is transthoracic echocardiography. Liver biopsy is usually not recommended due to typical clinical pattern of ischemic hepatitis. 20 days mortality ranges between 40 to 60%, and 1 year mortality in ischemic hepatitis is about 75%. Highest mortality rate is found in patients with septic shock, those having SOFA score more than 11, and those having pre-existing chronic liver disease. Duration of HLI is also having prognostic impact. Prolonged persistence of HLI triggers progression to other organ failure per se. Therapeutic option in the HLI is early recognition is of paramount importance. Liver transplantation is not indicated in patient with HLI. Fluid overload should be avoided as it may increase the mortality. No ideal vasoactive substance to preserve or restore hepatosplenic circulation. Dobutamine may be sometimes useful as high dose of noradrenaline, as we know noradrenaline having both alpha 1 and beta activity. So in high doses, alpha 1 activity prevails. So it causes, due to alpha 1 activity, it causes splanchnic vasoconstriction. So it further decreases the supply to organ. So dobutamine sometime may be helpful if added with noradrenaline to control the shock. Systemic hypoxia should be treated by oxygen supply and mechanical ventilation according to clinical requirement. Glycemic control, as told in cholestatic liver disease also, glycemic control to keep the glucose level nearly about 150 may be helpful in patient with hypoxic liver injury also. Pre-treatment with statin is associated with reduced incidence of HLI in critically ill patient. A prospective cohort study shows this data. Initiation of renal replacement therapy improved 28-day survival in large observational analysis of patient with HLI. MARS may be tried in patient with HLI in a RCT with 27 patients, 14 patients randomized to MARS and 30 patients randomized to non-MARS therapy. 50% patients survive with the MARS and 32 patients in the non-MARS group. Better outcome using albumin dialysis in patient with cholestatic HLI. But limitation of this study is small sample size, so further studies are needed to verify these results. Another type of the liver injury in sepsis is cholangiopathy in critical illness. Cholestasis induced in critical illness is usually reversible. A small proportion of patients develop irreversible biliary and hepatic damage due to progressive sclerosing cholangitis. Persistent hyperbilirubinemia and elevated serum alkaline phosphatase level after resolution of sepsis indicate toward the cholangiopathy. Sclerosing cholangitis is rare but clinical relevant complication described in patients with severe trauma, burn injury and severe respiratory and hemodynamic failure. Incidence of this is about 0.6%. The main trigger for destruction of biliary epithelium are malperfusion, hypoxia and recurrent inflammatory stimuli due to episode of bacterial cholangitis. Gold standard test for diagnosis of this is ERCP. Endoscopic findings are biliary cast, multiple irregular structure and rarefication of the biliary tree. Progressive disease that potentially result in liver cirrhosis with subsequent need for liver transplantation. Continuous inflammatory damage of the biliary system impair prognosis in non-transplant candidates. Median survival is about 13 months. Next is parental nutrition induced hepatotoxicity. This is mild liver injury occur frequently in infant and adults treated with parental nutrition. After initial mild elevation of aminotransferase, a mixed pattern can be seen. Etiology of parental nutrition induced hepatotoxicity may be related to hepatic bile acid transport alteration. In a prospective study that included more than 3,000 critically ill patients, prevalence of hepatotoxicity in parental nutrition group is 30% versus 18% in the enteral nutrition group. Daily caloric intake greater than 25 kilocalorie per kg along with total quantity of parental nutrition and sepsis are the causes. Preventive measures are reduce lipid infusion to less than 0.5 gram per kg per day, carbohydrate intake to 15 kilocalorie per kg per day and initiate cyclical parental nutrition. UDCA has been used successfully to treat chronic parental nutrition associated cholestasis in adults. So in summary, some clinical problems affecting more than 20% of the critically ill patient. Cholestasis and HLI are the most frequent clinical presentation. Early diagnosis of hepatic injury, early initiation of primarily symptomatic therapy are the cornerstone of the clinical management. Newer therapy directed at liver still require further investigation before they can be widely recommended. Thank you.
Primary and secondary hepatic dysfunction in the critically
Yes.
My question is, you have said that in case of acute GI problem, be it appendicitis, pancreatitis, cholangitis, once we have put the patient on NPO, what are the things apart from hormones do we take in consideration before starting the patient again on the other condition? Number one. And secondly, is there a role of silimarin or vitamin E in case of acute liver injury apart from
Silimarin and
vitamin E?
E. There is no role of silimarin and vitamin E in acute liver failure or acute liver injury. Second, we try to start enteral nutrition as early as possible. Some contraindication I told you in the slide, like severe acidosis, severe shock, and abdominal compartment syndrome. These are the lot of gastric residue. If we started feeding, these are the contraindication, but we keep on trying to start enteral nutrition as early as possible. We see during our MD days, we see if a patient of pancreatitis comes to the hospital, we try to keep him NPO as long as possible for 15 days, 20 days. Now it is proven we can start enteral nutrition in pancreatitis after 1 day or on the same day also. It decreases the gut dislocation of the bacteria from the gut. Enteral nutrition decreases leakiness of the gut. So translocation of the bacteria from the gut to the systemic circulation decreases by enteral nutrition. This is the main hypothesis to start enteral nutrition as early as possible. If patient having recurrent intolerant vomiting, then we cannot start oral feeding despite patient is having normal bowel sound. So we should clinically judge when to start feeding in the patient of any sepsis patient or any disease. Thank you.
Any more questions from audience? If no, then we can close the session. Thank you, everyone.
Thank you, sir, for enlightening us with your knowledge. I now request Professor Ved Prakash, sir, to come on stage and felicitate our chairpersons and speaker. Professor Sumit Rungta, sir. Dr. Ajay Kumar, sir. Dr. Anil Gangwar, sir. Dr. Preetam Das, sir. Dr. Devendra, sir. Moving ahead towards our next session on urosepsis, diagnosis and management, I would like to invite the chairpersons on stage, Dr. Apul Goyal, sir, Professor, Department of Urology, KGMU. Dr. BP Singh, sir, Professor, Department of Urology, KGMU. Dr. Vivek Singh, sir, Assistant Professor, Department of Urology, KGMU. Welcome, chairpersons. I request you to introduce the speaker of this session.
At the outset, I thank Dr. Ved Prakash for inviting me and giving this opportunity. I would like to say that in last year also, in I had an opportunity to present the sepsis, but this time the topic is different. I have tried to make the presentation very simple for all of you. Thank you, Chairperson. So starting. Is this okay? Huh? Screen okay? Okay. So coming to the basic, the urosepsis is basically the infection of the bacterial infection of the urinary tract, but it can be fungal other sepsis also. So these infections include both upper and lower urinary tracts. So basically we have divided the urinary tract into two parts, upper and lower. Bladder and the urethra are the lower parts, and ureter and kidney are the upper part. Inflammatory response can lead to multi-organ dysfunction, failure, and even that lead to the death also. So this is the diagram what I was talking. This can be upper tract urosepsis, lower tract urosepsis, and the symptoms of the more or less the same, and the principle of management is also more or less the same. And if not treated, can be life-threatening in neglected cases. And the associated pathology further complicates the problem, like if there is associated stone, tuberculosis, fungal infection, neurogenic bladder, and congenital anomalies also. So coming to the sepsis, the organ dysfunction can be assessed initially by the quick SOFA score, and score of 2 or more than 2 is significant. I will not go into detail. So coming to the next slide. So something was circulatory shock. Circulatory shock is defined can be circulatory or cellular metabolic changes associated with a greater risk of mortality. And euvolemic patient, if the vasopressure requirement is needed to maintain the mean arterial pressure more than 65 millimeter mercury, that is called the septic shock. So this is all about the SOFA score. As previously I said, 2 or more is important. So a clinician should have a very good quick scoring for the assessment of the seriousness of the condition. So host factor is very important, that increases the risk of infections or sepsis. The advanced age is very important because the extremes of the age are more prone for the severity of the infection. Anatomic abnormalities, poor nutritional status, chronic smoking, immunodeficiency, chronic indwelling catheters, chronic steroid use, infected endogenous or exogenous materials or stent is very much used in urological practice, distant coexistent infection, prolonged hospitalization or spinal and bed-ridden patients. So if these are the associated host factor that further complicates the problem. So coming to the basics, how we treat the urosepsis. Earlier I told quick assessment and resuscitation are important. Stabilization of the hemodynamics, because these are the patients, they are hemodynamically unstable. Little or no manipulation of the urinary tract. This is very important. So once there is infection, we should not go for some kind of endourologic intervention. We should try to avoid it. Repeated or multiple cultures should be sent. Proper drainage of the pus must be ensured. Suppose the patient comes with the urinary tract infection, so it's a practice. The pus or infected urine must be drained. Supportive care in the form of the hydration, antibacterial nutrition, and care of the comorbidity like the diabetes, hypertension, CAD, COPD, and good imaging of the whole of the urinary tract should be done. So diagnostic modality as the clinically, apart from the clinical, the microbiology like urine or blood culture, drain fluid analysis, and we should also focus on the in atypical cases like the FV, fungal infections, blood investigations. I'll not go in the detail. Coming to the some markers, the many of the speakers have already covered, but for the urological practice, the cytokines not standardized, as Dr. Malviya said, for the bacterial sepsis, but these are the under trials. Procalcitonin, these usually do, but yes, 100%, 85% is accurate because it may not be raised in the fungal or some of the gram-positive infections. Proadrenomedullin, this is another sepsis marker, rises in early phase of hyperdynamic circulation of the septic shock, and serum lactate, day-to-day practice like in the ABG, we get in many of the information about the seriousness of the sepsis. So these are the spectrum of the urinary tract infections, sepsis, like a pyelonephritis, renal abscesses, perinephric abscesses, emphysematous pyelonephritis, pyonephrosis, xanthogrammatous pyelonephritis, tuberculous pyonephrosis. The name is tuberculous, but it is coexistent with the bacterial pyonephrosis also. And some chronic infections which can lead to the mortality, like the renal malakoplakia and other infections and conditions also. So coming one by one, the pyelonephritis is basically the clinical diagnosis. It is literally the infection of the kidney. And there are two types, the complicated and uncomplicated. But complicated, that should be treated for the long duration, 2 weeks. Uncomplicated cases, 3 to 5 days of antibiotic treatment is enough. But in the beginning, I already said that urine culture and sometimes blood culture can be needed. This renal abscess is very important. Abscess, and there is basically these are the some technical diagnosis, like the renal abscess, localized pus formation in the kidney, the renal abscess, and if you go for the perinephric abscess, means the abscess has come to the perinephric abscess. Name itself says what is the diagnosis. Next is the sepsis progression and perinephric abscess, and can have the little bit of change of the spectrum, that is important, emphysematous pyelonephritis. As happened, what happens, suppose the patient is most of the patients are diabetics, and diabetics have the high blood sugar, uncontrolled sugar, and some of the patients are the uncontrolled diabetic, first time diabetics also. So bacteria infection is a good fermentation for the glucose, and that produces the gas. So this is very necrotizing fasciitis kind of the condition of the renal parenchyma, and that leads to gas formation. So this is the hallmark for diagnosis of this condition. This is very rapidly progressing condition. And the basic principle is the same. You have to control the progress of infection by ensuring the good drainage, by putting a tube inside the kidney. So these are the gradings. I will not go in the detail because these are the primarily for the urologist. Once the patient, there can be the two groups who are responding, not responding. So not responding, we have to be little more aggressive. So next is the pyonephrosis. The pyonephrosis word itself, the pyo means the infection in the kidney which led to the pus formation. We can see here in this diagram, this was the case of the nephrectomy where we remove the kidney for the non-functioning kidney of the pyonephrosis. So you can see the pus, whole of the kidney parenchyma replaced by the pus. So pyonephrosis is a life-threatening condition. Then coming to the tuberculous pyelonephritis or pyonephrosis. The tuberculosis is a very common, not uncommon in the India, and it may coexist with the bacterial infection also. So the clinical presentation and radiological investigations can point out that this patient can have the tuberculosis infection of the kidney, and so high index of clinical suspicion is important, and associated bacterial infection that also needs to be treated. And along with the ATT, the patient can be taken for the surgical intervention in the form of the removal of the pus, or we have to go for the removal of the kidney also. So coming to the infected hydronephrosis, because day to day these are the important clinical scenario, because many of the senior residents are sitting here. Many times they are confused, they are sending references ki pyonephrosis, but in fact this was the infected hydronephrosis. Hydronephrosis is the dilatation of the pelvic calyceal system. You can see in the diagram. It is dilatation of the pelvic calyceal system because of the stone. But when it gets infected, the system gets infected, then it is the infected hydronephrosis. But once the pus in the parenchyma, that is the pyenephrosis. But these are, but basic principle of treatment are the same. So some of the chronic conditions. Now I am coming to the some of the important situations. These are very important, like operative urosepsis, transplant kidney, UTI in the pregnancy, sepsis in the spinal cord injured patients, and prostatic abscesses. So these are the important conditions. I'll present something about a case because day-to-day practice we get the stricture urethra cases, road traffic accident, and we take a patient for the erythroplasty. You can see here in the diagram, this is a micturating cystourethrogram and RGU also. So that patient we have not done upper tract imaging because of the injury in the lower tract. But this patient following the operation was shifted to the critical care medicine because of the AKI. What the later on we got the patient, investigation done, ultrasound, bedside ultrasound done, and that showed this patient had solitary kidney, and that kidney also had stones, and the patient went in the anuria, and patient finally went in the urosepsis. So imaging of the whole of the urinary tract is important. Even the patient has the lower tract pathology, that is important. This was the important message in this case. The next case is the transplant kidney. So urosepsis in transplant recipient need special attention, especially female gender, diabetics, cadaveric transplant. 2 episodes of asymptomatic bacteria, prolonged HD hemodialysis before transplantation. Asymptomatic bacteria must be treated in the transplant patient. Generally we say in the normal persons asymptomatic bacteria should not be treated, but there are some special situations like the transplant patient, they need to be addressed by the suitable antibiotics. Immunosuppression must be continued or tapered depending upon the severity and demand. So another condition is UTI in the pregnancy, urosepsis in pregnancy. Asymptomatic bacteria are at the high risk for the symptomatic UTIs that result in the adverse fetal outcomes, pyelonephritis and sepsis. So all asymptomatic bacteria should be treated of the pregnancy, like the previous group, like the transplant patient. Antimicrobial may cause maternal and fetal these adversity also, so we have to be very careful in choosing the drug. And pregnancy with acute pyelonephritis should be hospitalized and treated with the parenteral antimicrobial agents. Another important condition is the urosepsis in the spinal cord injured patient. Symptomatic bacteria only to be treated. Here we only symptomatic bacteria to be treated. Sepsis can cause fever, flank pain, back or abdominal discomfort, pericatheteric leakage. Sometimes the patient comes that I have catheter, suprapubic catheters, and most of the time it is leaking, and then the patient, some other doctor change the catheter, the situation is the same. So these are the catheters, the bladder becomes spastic. So pericatheteric leakage in spinal cord injured patients because they don't have the sensory reflexes, sensory sensation. They have sensory loss. So pericatheteric leakage is indication that patient can have the bacterial sepsis. Increased spasticity, malaise, lethargy, and or cloudy malodorous urine. So these are the some conditions, clinical symptoms. The CIC places patient at the lowest risk for the significant long-term urinary tract complications. Chronic infection can be carcinogenic. That also to be taught to the patients. Some patients prefer कि lifelong हम रह जाएंगे catheter पर. This kind of the attitude must be discouraged. We should explain to the patient that the permanent catheterization can lead to the squamous metaplasia and finally the carcinoma formation. And preferably if the patient are not willing for the CIC, we have to put patient on the SPC rather for the whole life on the PUC. This is very important condition like the prostatic abscesses. Recently one of my colleague radiologist, he called me that he had a patient and that patient had the prostatic abscess and that patient had no symptoms at all. Then I immediately asked him whether the patient is diabetic. He said yes, the patient is 12 years old diabetic. So diabetes can lead to the autonomic neuropathy and many times we don't get the classical signs symptoms of the prostatic abscess and prostatitis. So diagnosis is done by the ultrasonography or CCT. Pelvis, smaller lesions 1 to 2 centimeter treated conservatively. Progression of the symptoms, if there is progression of symptoms or the size of the prostatic abscess, surgical treatment must be ensured. lesions that do not respond to the initial percutaneous aspiration, or lesions too large to adequately drain percutaneously should be taken for the transurethral deroofing, that is called deroofing, or in the little TRP, to unroof the abscess. Abscess that extends beyond the prostate may require open surgical intervention. So I had covered many of the uroseptic topic situations also. So finally I am concluding that clinical quick identification is the key for the management of urosepsis. Then stabilization of the hemodynamics, because many of these patients are hemodynamically unstable. Adequate drainage of the urinary system to be ensured in the form of catheterization or suprapubic cystostomy or percutaneous nephrostomy. Good imaging as early as possible. Proper or adequate drainage of the pus must be ensured. Effective antimicrobial or antifungals are to be started in time. Care of associated comorbidities like the diabetes, hypertension, COPD must be started. Many of these patients are cardiac patients also, that also to be addressed. So final outcome of urosepsis, if you address all above these points, we can have the good results. Thank you. Yes. Yeah. Thank you.
Thank you, sir, for a very comprehensive presentation. Now I request Professor Ved Prakash sir to please come on to stage to felicitate our chairpersons and guest speaker. Dr. Vishwajit sir. Professor Apul Goyal sir. Dr. BP Singh, sir. Dr. Vivek Singh, sir. Proceeding to our last session of the day. For that, I would request our chairpersons to come onto stage. Dr. NB Singh, sir, Senior Chest Consultant, Civil Hospital, Lucknow. Dr. Atul Tiwari, Assistant Professor, Pulmonary Critical Care Medicine, KGMU. I request the chair to please introduce the next guest speaker.
Thank you, Atul. So this is the last session of the day. बैक करो भाई जरा पहला कहाँ है आगे जा रहा है हाँ इससे जाना है आगे ना ठीक okay. So a lot has been discussed about the antifungal agents and the sepsis. So this is a sponsored session sponsored by Bharat Serum. The role of amphotericin B in management of invasive fungal infections. So as you know about the invasive fungal infections, in MICU, SICU, the invasive candidiasis, fourth leading cause of bloodstream infections, with increased cost, morbidity and mortality. Transplantation units, invasive aspergillosis is one of the leading cause of infections, complications with an 80% mortality. So mortality is very high. A prompt diagnosis of invasive fungal infection is essential for patient survival, since early initiation of appropriate antifungal treatment is shown to improve the patient outcome. However, this is often challenging. So this is the invasive aspergillosis. The most common candida infection in Indian ICUs is Candida tropicalis and followed by Candida albicans, that is 20.86% and this is 35%. The incidence and characteristics and outcome of ICU acquired candidemia in India, the overall incidence is 6.5 cases per 1000 ICU admissions, and acquisition occurred early after admission to ICUs. Median is about 8 days. Every infections infecting patient with lower Apache score is in admission. The median is 17. 31 Candida species causing candidemia and a high rate of isolation of Candida tropicalis, that is 41.6%. Azole resistance is also seen nowadays in 11.8% isolates. Significantly higher presence of relatively resistant Candida auris and Candida rugosa in public sector hospitals, and 30-day crude and attributable mortality rate of candidemia patient is 44.7%. So it is high mortality, and 19.6% in the patient respectively. So very high mortality in the candidemia patients. The risk factors, as you know, the prolonged ICU stay, and the treatment with corticosteroids, diabetes mellitus, advanced age, and CBA, central venous catheters, GI surgery, total TPN पे जो patient हैं उनको, prolonged antimicrobial use, pancreatitis, and the immunosuppressive agents like chemotherapy, high disease severity score, Apache 2 more than 20 is the risk factor, neutropenia, renal replacement therapy, malnutrition, multiple site colonization, burns over 50% of body site, and major trauma is also the major risk factor for the Candida infections. So this is the spectrum of aspergillosis, likewise the immune response. If the patient is so immunity is low, immune response is low, then there is risk of invasive aspergillosis, like in neutropenia, stem cell transplant patients, and advanced AIDS, and these patients. And as the immune response is better, then the patient may suffer with ABPA or allergic sinusitis. So this is the spectrum. Invasive aspergillosis specters is estimated that 2 lakh cases of invasive aspergillosis occur worldwide per year, and 50% of hematological malignancies like AML, ALL, allogenic transplants recipients. And common risk factors are environmental factors like construction work, inadequate infection control. Emerging risk have the COPD, liver cirrhosis, critically ill patient, and ICU patient with mechanical ventilation. And genetic factors, TOL like receptor 4, interleukin 1. So these are the factors, and risk factors associated with immunocompromised status are prolonged profound neutropenia, prolonged steroids, T-cell immunosuppressants, hematopoietic and solid organ transplant recipients, and primary immunodeficiency states, and CMV infection. So the invasive mold infection in Indian ICUs, you can see that this is the one study conducted in 11 tertiary care centers ICU across India in April 16 to September 2017, and 398 patients proven to probable or putative IMIs, and out of which 96 were proven and 302 probable. The risk group, the classical group like neutropenia, malignancy, transplant recipient, or immunosuppression, and non-classical like chronic obstructive pulmonary disease, diabetes, liver disease, and glucocorticoid use. And the prevalence of 9.5 cases per 1000 ICU admissions were noted, and Aspergillus species was the commonest, like 82.1% in the all isolates, and mucorales detected in 14.4% patients, and new susceptible group like COPD, diabetes, liver failure, chronic liver disease in India for development of IMIs in the ICU, and 42 days and 84 days mortality was 64% and 65.8% respectively in both the groups. The mucorale fungi are incubatous environmental organisms. The major route of infection is by inhalation of spores. Ingestion of traumatic inoculation are recorded. Humans are resistant to disease, but immunocompromised hosts are at risk. Once the spores begin to grow, fungal hyphae invade blood vessels, producing tissue infarction, massive necrosis and bone destruction, and thus producing the life-threatening invasive rhinocerebral and other organ-centered manifestations. So this is the mucormycosis pathophysiology. You have seen many patients during COVID pandemic. So this is the pathophysiology of mucormycosis. And clinical forms of mucormycosis in India having rhino-orbital cerebral mucormycosis is the commonest form, ranging from 45 to 74%, and the cutaneous is 10 to 31%. Pulmonary cases are also common, like up to 22%, and renal is 0.5 to 9% cases, and GI cases up to 0.8%, and disseminated infections are also up to 9%. So the clinical forms of risk factors association in mucormycosis, rhino-orbital cerebral mucormycosis is associated with diabetes mellitus, uncontrolled diabetes mellitus, and pulmonary mucormycosis is associated with solid organ transplant recipients, hematological malignancy, diabetes mellitus, and the cutaneous mucormycosis is associated with trauma. So diagnostic method of invasive fungal infections are culture and DST. Histopathology mainly for molds, radiological tests mainly for molds, and serological tests. PCR-based tests are also available, germ tube or chrome agar, ANI-FIS, peptide nucleic acid fluorescence in situ hybridization, and multi-top tests are available, but the limited availability and not standardized tests. So this is the limitation of these tests. The inadequacy of culture and sensitivity methods of blood cultures, having candida suboptimal sensitivity ranging between 30 to 50%, need long incubation time. Newer culture methods have raised the sensitivity of candida detection in almost 70% cases, but they require a minimum of 24 to 48 hours to become positive, and thus their result may come late in the course of the infection. And the positive, VC is positive for Aspergillus is extremely rare. In isolation of Aspergillus from cultures of bronchial secretions, bronchoalveolar lavage, or other body fluids or tissues might represent the colonization rather than the infection. So diagnostic approach for invasive aspergillosis or mucorales is like histopathology, radiology are the diagnostic methods. For aspergillus, definite diagnosis and no specific findings in the radiology. For mucorales, definitive diagnosis histopathologically and no specific findings radiologically. In blood cultures, the aspergillus rarely, extremely rare, and mucorales are also rare. Respiratory sample cultures, sensitivity 10 to 80%, and for aspergillus, and 67 to 100% in ball samples for mucorales. And this is PCR blood based in the ball samples. It is 67 to 100% sensitivity, and specificity is ranging from 55 to 95%. And for mucorales, the sensitivity is 40 to 90% and 100 with 100% specificity. So the antigen assays are also available, glucomanomas and for aspergillus, and investigational for mucorales, and algorithms are also available for these tests. So why the fungal diagnosis is difficult? It is difficult because invasive fungal infections may be asymptomatic during early phase. When present symptoms are non-specific, that is fever or cough, that may be due to many reasons. Microbial culture techniques have low sensitivity. Invasive diagnostic procedures not always possible, because in the neutropenic patients with hypercoagulable state, hemodynamically unstable patients, we have in which we suspect invasive fungal infections. The radiological features are also non-specific for fungal infections. So, and serological tests are not easily available and are not confirmatory also. So, PCR is still developing and not standardized. So, you can see the state regarding the diagnostic facilities. So, you can predict how difficult is to diagnose the fungal infections. So, invasive fungal infections are very difficult to diagnose, and diagnosis is delayed, so the mortality is high. So, to provide effective therapy and early diagnosis must be made based on the risk factor. So, it is more of the clinical scenario of the patient which can help to establish the diagnosis of invasive fungal infections. In 2019, the task force on practical management of invasive candidiasis in critically ill patients against the routine and universal administration of antifungal prophylaxis in critically ill patients, weak recommendation, moderate quality of evidence, not recommended the use of preemptive antifungal therapy in critically ill patients. This is also weak recommendation. Suggests that empirical antifungal therapy might be considered only in the patient with septic shock, multi-organ failure, who have more than one extra digestive site, that like urine, mouth, throat, upper or lower respiratory tract, skin folds, drains, operative site with proven candida species colonization. It has the strong recommendation, so we can consider the empirical therapy of antifungals in this group of patients. And not recommended, stating empirical antifungal therapy in patient without septic shock or multi-organ failure. So, criteria to start early antifungal therapy is patient in hospital for more than 7 days, plus antibiotic in last 7 days, or CBP lines for 7 days, and in plus the 2 of the following, like TPN use for 1 to 3 days, and dialysis days 1 to 3 days, and major surgery, pancreatitis, steroid use, and immunosuppressive agents for up to 7 days, plus candida colonization or beta glucan and or very low procalcitonin. So, this is the criteria to start early antifungal therapy. We should start as early as possible. So, invasive fungal infections management strategies have the disease progression, like no disease markers, sign and symptoms, full-blown disease, and sequel. So, in no disease, prophylactic, asymptomatic high-risk patient, we can consider with in this preemptive with the positive markers, the asymptomatic plus colonization of novel agents, diagnostic, and the empirical group will consist of markers positive plus signs and symptoms having the high risk plus antibiotics plus fever. So, these are the scenario for empirical therapy, and in full blown disease therapy has to be given in evidence of infection plus clinical disease. So this is the sequence and management strategies regarding invasive fungal infections. So this is the mechanism of action of antifungals, Paulins and amphotericin B works on membrane function, MPO-B, and cell wall synthesis is inhibited by echinocandins, and ergostol synthesis by the azoles. So the practice guidelines for aspergillus is in IDSA guidelines 2016 says regarding the empiric therapy for high risk patient with prolonged neutropenia who remain persistently febrile despite broad spectrum antibiotics. So this group of patients with the febrile neutropenia, and antifungal options are lipid formulation of MPO-B and echinocandin like casfungin or micafungin having the strong recommendation, and voriconazole. We have the strong recommendation for voriconazole and lipid formulation of MPO-B also. So liposomal MPO-B, the mechanism of action is it forms the fungal cell wall porous. The pore formation in the cell wall of the fungus is by this amphotericin B liposomal. These are the amphotericin B molecules, free and liposome bound, and liposome with MPO-B interfere with the membrane and ultimately make this membrane porous. So the fungus cannot survive, and this is the evidence in Cochrane library, the amphotericin B deoxycholate versus liposomal MPO-B effects on kidney functions. So the current evidence suggests that liposomal MPO-B is less nephrotoxic than conventional MPO-B. So this is the last slide. To summarize, the prophylaxis is described and applicable to unaffected patients who are at risk for invasive fungal infections, and these are the pro and cons. So possible reduction of incidence of invasive infections, and cons is potential onset of resistance, drug toxicity, drug interactions, and high cost. So these are the points against, and the suggested molecules are posaconazole and fluconazole. So in the empirical approach is early treatment of occult fungal infections when patients have clinical signs and symptoms of infection but no clearly identifiable pathogen or radiological signs. So the points in favor are suggested by many international guidelines. Early therapy for patients with an undetected but possible infections because survival seems to be affected by the early initiation of the treatment. The points against are high risk of over treatment with potentially toxic and expensive drugs, and it is a less targeted antifungal treatment compared with diagnostic driven strategies. So the agents are liposomal MPO-B or caspofungin. In preemptive approach, the administered in neutropenic patients with persistent fever who show image documented pneumonia, acute sinusitis, or a positive galactomannan test, and the points against are early detection of asymptomatic infections thanks to the intensive use of screening markers nowadays, and reduction in the use of antifungal drugs compared with an empirical approach. And the point in against our need for an early or early and insensitive diagnostic workup, availability of serial microbiological and radiological tests are required, and the agents are not specifically. And this is the targeted therapy administered in the patient with clear evidence of fungal infection. Possibility of administer an antifungal treatment really effective against the pathogen, and reduction in the use of antifungal drugs compared with an empirical approach. The points against for this approach are the diagnosis can be late, frequent, inapplicably histological exams in thrombocytopenia, hemodynamical instability, and performance status. So these are the points in favor, and this is the against. And the agents are voriconazole for aspergillosis, echinocandins for candidemia, and ampho-B liposomal for zygomycosis, and voriconazole for secondary sporosis. So these are the modalities, and this is the all summary regarding the prophylaxis, empirical approach, preemptive approach, and the targeted therapy regarding the antifungal agents in invasive fungal infections. So this is all. Thank you for patient listening. Thank you all.
Thank you, sir, for the elaborative talk on invasive fungal infection and role of improvisation. Thank you, sir. Any question from audience? I think all have done from morning to evening. Thank you. Now session is closed.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir, for the wonderful presentation. I now request Professor Vishwajit, sir, and Professor D.K. Verma, sir, to come on stage and felicitate our speaker and chairpersons. Professor Ved Prakash, sir. Dr. N.B. Singh, sir. Dr. Atul Tiwari, sir. Now I request Professor Ved Prakash, sir, to come and deliver his vote of thanks.
Thank you, Subhra. I would like to thank all the dignitaries who come long way from Chandigarh, and our Deputy Chief Minister, Sri Brijesh Pathak ji, our Honorable Vice Chancellor, who were so much busy in making some guidelines regarding the vaccines, which has to be taken up by the central cabinet. So she was so much busy, but she came here, and our guest of honor, Dr. D. Behra sir, and Dr. Jindal, S.K. Jindal, who come long way from the Chandigarh, and all the dignitaries who attended, and the delegates. I thank you all, and I also take the opportunity to facilitate my team, Dr. Sachin. सर आप आ जाइए, इनको भी फैसिलिटेट करिए जो हमारे लोग हैं, डॉक्टर सचिन, डॉक्टर आरिफ, अतुल, डॉक्टर मृत्युंजय, डॉक्टर अनुराग, कम ऑन स्टेज, दीपक, रवि, पुलकित, सुब्रा, कहाँ है सुब्रा? हाँ सुब्रा हैं। दो भाई इनको फैसिलिटेट करो, डॉक्टर सचिन, अतुल, हाँ कुछ दो भाई ले जाके। Dr. Sachin is assistant professor and second in command in the department, so he manages all the show. And Dr. Atul Tiwari is assistant professor, completed his DM from Sanjay Gandhi PGI, and now permanent assistant professor at Varanasi. And Dr. Arif is assistant professor here. Dr. Arif is first DM student in our department, now serving as assistant professor. Dr. Mrityunjay is first candidate in the second batch for DM. And Dr. Anurag is also DM final year. Dr. Subra is second year DM. And Dr. Deepak is also second year DM. And Dr. Ravi तो आपके भी स्टूडेंट रहे हैं सर. Ravi is doing PDCC. Dr. Pulkit. Last but not the least, our ANS. कहाँ है मैडम? ANS हैं? आइए दोनों ANS, तीनों ANS आ जाएं. पूरे डिपार्टमेंट का मैनेजमेंट यही लोग संभालते हैं. मर्सी मैसी रॉस, सुरुचि जी, राकेश, these are all assistant nursing superintendents in the department. Rakesh looking after ICU. Suruchi ji looking after wards, and Mercy sister looking after HDU, and she is the guiding force of all the nursing officers and the management. Backstage management done wonderfully today. And the office, राजन जी, और आपके कहाँ हैं जोड़ीदार? ये हैं, देखिए, आ जाइए. So रात और दिन जितना भी काम हुआ है, रात के 11:30 बजे 12 बजे तक ऑफिस खुलता है सर हम लोगों का, और रात भर ये लोग काम कराते हैं, राजन जी और गोस्वामी जी दोनों। बैक स्टेज जितना संभाला है, जितनी गर्ल्स ने, सब लोग आ जाएं, इकट्ठे होके आ जाएं सब लोग। आइए। Behind the success of this program, this is our team. ये हैं सपना, सबका नाम तो मुझे पता भी नहीं है, कीर्ति, ज्योति, पारोल और ज्योति, दिव्या और क्या क्या नाम है, सोनिका, निधि, श्वेता और हैं, इन्हीं को दे दो उठा के, सब ये जो रखे तो हैं, ले जाओ ना, इनको दिलवाओ, ले जाओ। So all they are working for around 15 days, day and night rehearsals they were doing for this program. सभी को हम लोग नहीं बुला सकते हैं, इतने कुछ रेस्ट्रिक्शंस हैं यहाँ पे, लेकिन आप सबका धन्यवाद जो अंतिम समय तक यहाँ पे रुके हैं और पूरे सेशंस अटेंड किए। थैंक यू ऑल डेलीगेट्स, रेजिडेंट्स, फैकल्टी एंड ऑल द डिग्निटरीज एंड I also thank to the our associations like Indian Sepsis Forum, UPTB Association, National Academy of Medical Sciences to associate with us and to have the faith, and also thank our partners from the pharma industry. अभी बस सर ख़त्म हो रहा है, 2 मिनट। Sedna Biotech, Glenmark, and Dept, Pharma, Pathkind, and all the pharma divisions of companies who have helped in organization of this event. So thank you all. Thank you.